नहीं, हाँ सर, नहीं जून वगैरह लिंक आपके पास पहुंच गया है ना सर, वही पूछना।
Good morning, Dr. Sitanshu.
Good morning, Dr. Prabdeep.
So can we quickly go over the session plan?
Yes.
5 minutes? Yeah.
Yes. So please mute it. How we are planning to start is,
yeah.
Just a moment. We are just looking at the session.
Sure.
Is it okay to start now? Yes, yes. So good morning, everyone. So the plan is, we have sent you an SOP, but in that we'll start.
I saw that.
The chairpersons, like I'll be introducing you and Dr. Arun.
Okay.
Then we'll hand over the session to the chairpersons. So
Dr. Arun will go first. From what
Dr. Arun will go first.
Okay.
So as alternatively, we'll go back and forth. Okay.
All of it, most of it is in recordings.
Yeah, only Dr. Rajni's session will be live. So that's what we are going to do now. So we'll be sharing all the videos will be shared from our end, and then it will go forward.
So we have to mainly moderate any questions from the audience.
Yes.
And will it be posted in the chat box?
Yes, we'll post the questions in the chat box.
Okay, fine.
Sundar.
And also you can give your reflections at the end of the presentation. 1 or 2 minutes, you can give your reflections.
Hi, Anthony.
Good morning, sir.
Good morning. Great to have you, ma'am.
Yes.
Hi,
Nice
Prabdeep.
Good morning, ma'am.
Is the process
yeah,
clear, Dr. Prabdeep?
Yeah, I just want to make sure that, we stay on time. Yes. So I think since we have four presentations.
Yes.
So maybe Dr. Arun can, so the questions are going to be at the end of all 4 or after each one?
At the end of all 4.
At the end of all 4. Okay. So I suggest we'll do this way. The first 2, Dr. Arun can keep going.
Right.
Is he there? Dr. Arun is there.
Sir is joining. I just called him. So probably he'll be joining in a minute.
Maybe you can text him this plan, no?
Yeah.
We are all okay. So he can start. He can do the speaker introduction. You are going to give us a slide or something? We haven't.
We'll share the slide from our end. You have to just.
Fine. I understand. We read it out. And then the next 2 I can introduce.
Right.
And then for questions, he can moderate a few, I can moderate a few questions. Yes. And then maybe he can summarize and then I can summarize. Do you want, I think after each session, we can just keep introducing and moving.
Right.
So we have enough time at the end for questions.
Exactly. So we have kept introduction slides to a very minimum because people know everyone here. So we'll not.
You are very prominent speakers. They don't need introduction actually.
By the way, Dr. Sundaraman said that there is no need of any introduction slide in one of our meetings because why to waste time? So but anyway, that's the.
That's
this is a new audience thing.
Yeah. No, we need to be.
I am all old story. Now people have forgotten. We who are partly there's a young people there who will say, who this guy, where? So that is all past now.
No, there are a lot of PGs, sir. So I think we need some introduction, context.
Some of them may have heard or read something that we've written, but they haven't actually, it's not been that thing.
Absolutely.
Right. So we are 5 minutes away from the session. It is going to be live in 8:58. Let me check with Dr. Arun and get back.
Yeah, can you call and just tell him this plan so that because we won't be able to talk to him when you're live. So that makes sure that I'm just very particular that we stay on time because online people tend to ask a lot of questions sometimes. So we need to keep enough time for that. Okay, over to you, Dr. Sitanshu.
Yes, thank you. I'm just calling.
Good morning, respected doctors. We have 4 minutes to go live, but after your indication. 2 minutes to go.
Yes, yes, 2 minutes to go. Good morning, sir. Sir, you are on mute, sir.
Yeah.
Sir, it's 8:59.
Yeah, good morning. I was facing some internet problem with my BSNL, so I'm switching over to my mobile data. Trying.
I think
Anyway.
you are right. I think it means it is a national BSNL problem. My BSNL also was not working, so I switched to the alternate alternate internet.
Sir, it's
What?
8:59. Are we ready?
Yes, we are ready to go.
Sir,
Dr. Sitanshu, just one moment.
Yes, ma'am.
Will I be able to share or will you put the PowerPoint on? Have you given
We'll
me
share,
the
ma'am. We'll share. Will that be okay, or you want to share, ma'am?
No, you can go ahead and share. That's fine.
Our tech team.
All right. Thank you. Thank you.
Combination.
so I'm putting
Professor
every-
Sundra Raman, pranam.
प्रणाम जी। आप तो यहाँ आते तो हम कहीं ले जाते, लेकिन अब कहाँ करें, यहाँ चाय भी तो पिला नहीं सकते हैं।
सर, आपके नाम की चाय हम आप पी लेंगे, बात तो एक ही है।
Sir, it's 9. I'm putting
Yes,
everything on recording.
Okay.
And
How many
And I'm-
participants?
sir, can we start?
Yes, we are going to start.
Sir, I'm giving a countdown. After that, you can start.
Yes. Yogesh, good morning.
Sir, I'm giving the countdown.
Yes, we'll start now.
5, 4, 3, 2, 1. Please start.
Good morning, everyone. I welcome you to the 65th Annual National Conference of Indian Public Health Association. And we are going to start our scientific fest. We have 18 plenaries in total at this conference over a period of 3 days. And we are going to start the first plenary today. The title of the plenary is Roadmaps to Universal Healthcare and Pandemic Response. We have a panel of distinguished speakers, and we are looking forward to this session. We have two chairpersons for this session. First one is Dr. Arun Kumar Agarwal. Dr. Arun Kumar Agarwal is professor at the Department of Community Medicine and School of Public Health, PGI, Chandigarh. His areas of interest are reproductive health, child health, quality of care, micronutrient deficiency, operations research. Sir is a member of IAPSM and IPHA and Indian Association of Maternal and Child Health. Sir has got multiple funded projects and numerous publications in national and foreign journals. And it's also my pleasure to introduce my teacher, and I have learned the principles of management under him. So welcome, sir. Thank you so much for joining us.
Thank you.
Next, move to Dr. Prabdeep Kaur. a very dear friend, scientist E, and head of Division of Non-Communicable Disease at ICMR National Institute of Epidemiology, Chennai, a physician and public health professional involved in research, teaching, and implementation science for scaling evidence-based public health interventions and policies in the healthcare system. She is a member of Chief Minister's Expert Task Force for COVID-19 control in Tamil Nadu since April 2020. She has visited Pondicherry and also helped the LG's office here to work for the COVID response in Pondicherry as well. She is the course coordinator for FETP NCD Track Fellowship and India Epidemic Intelligence Service South Hub, involved in designing and implementing many public health interventions, and has got a lot of publications in the area of non-communicable disease. So I welcome you, Dr. Prabdeep, to this session. Thank you so much for sparing your valuable time and joining for this plenary. Now I hand over the session to to both the chairperson to conduct this session. Thank you so much.
Thank you so much, Dr. Sitanshu. Can you switch over the slides to the profile of Professor Sundara Raman first? It is indeed a proud privilege to be with Professor Sundara Raman once again. I have heard him so many times, and I mean, he is indeed ocean of knowledge and experience on health systems. I can say that whenever I have listened to him, it is always a mesmerizing speech and full of pearls of knowledge. So as you see that currently he is adjunct faculty at JISP at Puducherry. He was former dean at TIS Mumbai, and he was a professor of internal medicine at JIPMAN only for 22 years. And he was at State Health Resource Center, Chhattisgarh. And you know that so many useful interventions that were initiated from Chhattisgarh. He was the brain behind all those interventions from Chhattisgarh. And adjunct faculty, JISPH, JIPMER, and Dean TIS Mumbai has been mentioned before also. And about awards, fellowship, significant contributions, is founder member of India's Jan Swasthya Abhiyan and global coordinator of People's Health Movement, large number of publications, etc. But the most important thing from my perspective is that he was the first ED of National Health System Resource Center. And most of the policy initiatives that have occurred in this country, he is the brain behind that actually. I mean, he has penned down most of the policy initiatives, either it was for Chhattisgarh or for country, and currently also in COVID time. I have seen his write-ups and his write-ups in the newspaper, his write-ups to the government. He is writing very boldly, bravely about the scientific truths about this disease, this COVID-19, and I mean, sort of guiding government to take corrective actions and follow the right strategies. So it is always a honor to be with him and to learn from him. And then our second speaker is Dr. Anthony Kolnur R, if I have pronounced it correctly, and he is Independent Monitor, National Health Mission, Government of India, and Director of State Health Resource Center of Chhattisgarh. Again, I think this is a good coincidence that Professor Sundara Raman initiated a lot of things at Chhattisgarh, and he is now continuing and is adding to the Chhattisgarh intervention. Health and Nutrition Specialist, UNICEF India, and is life member of Indian Academy of Pediatrics, Indian Public Health Association, Public Health Resource Network, WHO International Technical and Evaluation Committee on AFP Surveillance for Polio Eradication in India, and significant contributions are that he drafted first module on safe motherhood and newborn care in India for Government of India, piloted 3-tier newborn care model in Warangal, and weekly IFA for adolescents in Medak, JE vaccine in Plenary, and AD syringes in Ganjam, hepatitis B vaccine in Kolar, and I think all these intervention in which he has contributed are the flagship interventions of the government of India. So this is great that he is there with us, and we'll have a privilege to listen to him. He has written a lot of books and publications, writes in Delhi. The Hindu is a very popular newspaper. The Indian Express, Deccan Herald, Economic and Political Weekly. I think all are very renowned papers. Health Action Magazine, British Medical Journal on Issues in Public Health, Indian Pediatrics, the National Medical Journal of India. I think this panel is, we are proud to have such eminent speakers with us. And now I think over to Professor Sundara Raman for his deliberations.
Sir, we'll start with Dr. Antony's thing. We are going to present sir's video, right? Thank you.
Sure.
And sir will be speaking on concepts and realities of UHC during pandemic.
Okay.
Thank you.
Okay.
Good morning to all of you, delegates of All India Public Health Association Annual Conference and the faculties. At the outset, let me thank the organization for giving me this opportunity to address you. Today, I'm going to talk about universal healthcare and its impact during the pandemic. What are the concepts about universal healthcare you know of, and what those concepts were the realities during the pandemic, the long-drawn traumatic experience during the pandemic. Let me start my PowerPoint presentation. You all know about Alberta Declaration and its emphasis on primary healthcare with its 8 components. Universal health coverage is a much more revolutionary advancement over primary healthcare declared during Alberta conference. It aims at improving access to people who are living in remote rural areas, in tribal hamlets and hill areas and the cut-off islands, covering all beneficiaries, and by special services, mobile medical units, outreach sessions, apart from the fixed day services in the institutions. So it also increases the frequency of services with regularity. It aims at increasing the range of services, expanding the package of services from basic primary care to MCH, immunization, control of TB, malaria, to a wider choice of services, and increasing the range of services from simple cataract surgery, which is provided, from there to congenital heart disease surgeries and even cochlear implant. And those who need secondary care and tertiary care, it ensures that. And it also aims at improving quality of services, in improving the standards of care by NABH standards and national laboratory standards, and incorporating a lot of technological advancement like MRI, CT scan in diagnostics, and a lot of autoanalyzers and wide spectrum of biochemical investigations, whatnot, and improving the standards in the ICU care by clear-cut algorithms and the application of rationality in drug use and investigations. It improves client satisfaction by, one is the cost being made affordable and minimum out-of-pocket expenditure, and there is wider participation and empowerment of the community. So 4 dimensions for client satisfaction is, one is improving the range of services, as I said, and improving the reach and access to the community and those who are marginalized with an assured quality and with an affordable cost. There is some difference between universal health care and coverage. Now all the governments are giving emphasis on coverage, but universal health care is a much more comprehensive realization of health goals. Like it addresses the social determinants of health, like safe water, sanitation, nutrition, food security, primary education, livelihood, and poverty aversion, and empowerment of the communities with gender and social equity. So if that is the wide spectrum of health care, not health coverage, service coverage, but it is a health care, then the health ministry has to be serious for convergence with allied sectors, and it needs to build up its own capacity for inter-sectoral coordination. Essentially, it emphasizes health is a basic human right and everybody's right it is. Under the Constitution, it guarantees health as a human right and under the entitlement for right to life. But unfortunately, it still has to become a justiciable right. I mean, justiciable right means you must get justice if the health is denied. That is way behind. I'm also asking, apart from the four dimensions of client satisfaction, four fundamental questions. Whose healthcare are we talking about? We are talking about healthcare for all, no discrimination. There is equality in health services with more equity for the with a special concern for the poor, neglected, voiceless, and marginalized. And that is very paternalistic an approach. Second question is healthcare a public good for the welfare of everybody, or is it a marketable commodity or a purchasable object which only those who can afford will purchase, otherwise is left high and dry? Of course, it is not. It is a public good. It has to be realized for all. Then the third question comes, who will do it in a democratic socialist welfare state? Of course, the government, because the government is for the people and by the people. So a welfare nation should not abdicate that responsibility to the private sector. Hence, the need for a public health system, not a private health system. Fourth question is, if that is so, who should bear the cost? Not the unfortunate fellow who falls sick, who fell sick and poor, but the whole society bears the cost. So the government of the people from the taxes paid by them, not by an insurance agency. My friend Dr. Abhay Shukla in Jan Swasthya Abhiyan People's Health Movement, he predicted something which is injurious to health. A weak public system and a high levels of privatization, both are injurious to health. What an irony. Private sector is not homogeneous. It's so heterogeneous and scattered in its presence and availability. And you cannot be sure early dependent on that. Private sector displayed its lack of standardization, a total medical anarchy, and uncontrolled exploitative pricing. Nothing comes free. Someone has to pay. So the cost of healthcare requires a financing system. That is to protect people from financial hardships and being pushed into poverty from the healthcare cost. When health expenditure gone by government is very low, that is shifted to the personal pocket, and that out-of-pocket expenditure for fellow who fell sick becomes very high. In a democratic country, financing healthcare must be from a pooled resource, mainly tax funds. It cannot be left to the vagaries of market forces or to insurance sector, because insurance sector is very poorly enrolled and also poorly reimbursed, and insurance companies themselves aim at profit. In any business, poor investment gives poor returns. In healthcare also, poor spending gives poor results. So that's why in per capita health expenditure has to be high, a percentage of GDP than now. Per capita health expenditure varies state to state also. We must have allocated about 80,000 crores for health in this year's budget, but our finance minister has given much less. Out of this chunk, 55 to 60,000 crore would have been allotted to National Health Mission. Globally, the proportion of GDP for health expenditure is around 6%. That's why we are demanding an immediate allocation of 3% of GDP, more than double of the current allocation for health sector in India. And thereafter, you have an incremental increase to reach 6% target. But what's the reality? The health expenditure government is very low. It has touched a bottom at 1.1% of GDP in 2015-16. It was much better in 2009-10, 1.4%, and now it's slowly increasing to and steadied at 1.3 since 2018-19, 19-20, 2021 is again 1.3. When health expenditure by government is low, out-of-pocket expenditure increases. And there is a wide interstate variation exists for decades in health spending. Even way back in 2004-5, Balrajan et al. In Lancet 2011 stated that Bihar was spending only rupees 93 per head to Himachal Pradesh, which was spending rupees 630. So 100 to 6-fold even Bihar to Himachal Pradesh. The expenditure of the government out of its total spending in 2009 ending one decade, in the first decade of this millennium, we have spending 4.4%, and that is 183rd rank by WHO's thing. But at the same time, the out-of-pocket expenditure has increased 60 times over 25 years. That's the Kerala experience. From rupees 88 in 1984 to 5,679 in 2011. This is a study by Kerala Science and Literature Society, Kerala Shastra Sahitya Parishad. And this 60 times increase is mainly on the cost of drugs and higher expensive investigations like scans and x-rays and cardiological investigation, neurological investigations, etc. Out-of-pocket expenditure, if it is more than 15 to 20%, it can lead to impoverishment, WHO guideline says. But instead of 20% upper limit, India's out-of-pocket expenditure is 61%. In way back in 2010, even in 2020, it is 62%. So universal healthcare, if it is critical component for sustainable development and reduction of poverty and reducing social inequities, and it is essential for our achievement of goals in the Sustainable Development Goal of 2030. For universal healthcare, an efficient, reliable public health system is a must. If that public health system is reliable and of good quality, people will start utilizing. You see the rush in Madras Medical College just outside Madras General Railway Station. Utilization of public health system was 28% in Kerala to 1992, but increased to 48% in 2020. One significant difference that is happening all over India is through National Health Mission since 2005. And recent experience of during the pandemic was health and wellness centers in the grassroots level was the main succor the poor people had. You also will say that Ayushman Bharat, Prime Minister Jan Arogya Yojana, or the much glamorized PPP didn't come up to the expectation. Let's ask, did health insurance save the middle class and the poor? And the solution was Ayushman Bharat. It had a potential to enroll 65% of eligible population, that is about 59 crore, but it was a potential, and they never got enrolled. ESI scheme was covering 15% of the population. CGHS, Central Government Health Services and Public Sector Undertaking coverage was less than 5%. So 15 plus 20% is there, and out of that 20%, the coverage is so low. Out of the 26%, 39 crore still uninsured. Only about 6% are the rich who can fully afford costly treatment. Balance 20% are middle class who can get trapped due to high out-of-pocket expenditure. Insurance coverage was anything far from the desirable. Bihar was having 14.5% coverage as per NFHS 5 data, and Maharashtra 20%, Karnataka 28%, major states. UP figures are not yet out. And wherever there was, in these states, the out-of-pocket expenditure during admissions in private hospitals in these states were 7 times higher. Even we analyzed the COVID claims of insurance, 14.8 lakh customers claims of 22,955 crore. As of mid-May, only 62% claims were reimbursed by insurance. 38% fell on the individuals. So what did the people do? The panicky people, they wanted to raise the premium from 2 to 3 lakhs. In case of a COVID severe disease admission in ICU, you spend in lakhs and lakhs. And so they wanted to raise the coverage to 5 to 7 lakhs. So when sum assured is increased, your premium also goes up. Insurance company benefits. Overall experience is privatization is bad for health, and that's a pandemic experience. Italy had private operators in public health institutions, not interested in prevention or control of communicable diseases or epidemiological investigation because there is no profit. Similar was the experience in India too, in PPP in Uttarakhand, which I have investigated myself, and in the Gujarat, in the Kutch area, the Chiranjeevi scheme, which was a savior for common people to get costly surgeries done. It was only profiteering for the people in the Baroda, Ahmedabad, Surat belt, and not in the Kutch, Ran of Kutch. Spain had 25% health budget for private sector, and it were all PPP revolved, favoring profit for the private sector. And when the private sector was exploiting, some organizations like Sati in Pune got their patient advocates go through the bills, itemized bills, and then they had to get 5 lakhs reimbursed to 6 patients as a case study I want to make. So the private healthcare was a market disaster, and that's why there is an urgent need for regulation and accountability. There is a Clinical Establishment Act applicable in 11 states, passed in 2010 by Parliament, but it is non-implemented. Central government was lethargic in regulating private hospitals or promoting patient rights in any form. National Human Rights Commission has to step in. They said two sets of advisories, September 2020 and May 2021, asking for minimum patient rights charter, rate capping in price in hospitals, and a grievance redressal mechanism. Thank God there was some judicial activism. The Karnataka High Court stepping in to reserve COVID care beds in private hospitals, and Kerala High Court capping prices of PPE kits, beds charges, and ICU care, and also Delhi High Court to ensure seamless movement of medical oxygen through the borders of UP and Haryana to Delhi. There was no regulation of treatment practices. Those standard protocols have been issued. Then there is black marketing of remdesivir, steroid misuse, etc. Remdesivir is sold at $300 against $6 cost. Around 15 state governments had to invoke National Disaster Management Act and laws to regulate rates for COVID treatment. Maharashtra capped 170 medical procedures charges. And in spite of all these things happening, Niti Aayog invites foreign direct investment as a business opportunity. I mean, we are a bit ashamed as public health professionals of Niti Aayog having this approach as a business. It already the foreign investment in hospital sector has increased over 100-fold from 2002 to 2013-14, $0.3 billion to rupees to $40 billion. And for the nexus, that's 5 large hospital chains, Apollo, Fortis, Narayana, Max India, Healthcare Global, and their revenues had increased about 80% over a 5-year period. The increasing role of financial actors and market emphasizes generations of profits and economic efficiency in business. Pandemic time experience was large-scale overcharging, irrational care, and other negative behaviors by the unregulated private sector in India. For an example, a Delhi corporate hospital charges 10,000 for PPE kit, whereas the same thing in a Mumbai charity hospital is only 3,000. So I'm concluding. Coronavirus taught us many lessons. It's a great teacher. First, it exposed the vulnerability and fragility of the existing public health system, which is had a cumulative neglect for decades in funding, staffing, infrastructural and technology upgradation. That resulted in poor clientele and bypassing public health system to private sector. But the pandemic also proved relevance and essentiality of public health system. The nation needs it with an immediate upgrade because it is the only option for the poor and marginalized. Private sector can't be relied upon. Their shutters were down and gates were closed. Thank you, Corona, for teaching us many lessons. A great teacher. Now we'll discuss the other aspects. Thank you.
Thank you, sir. Thank you so much. Really, pandemic has given so many lessons and has given opportunity to restructure the entire systems. And now I think we request Professor Sundara Raman for his address.
Sir, now we have, after this, may I request Dr. Pradeep to please introduce Dr. Yogesh Jain. And
Okay.
Dr. Agarwal, I am coming in as the last speaker on the thing.
Okay. I was not aware about the. He must have communicated to me. I could not read.
Yeah.
Okay.
So,
Okay. So continue.
Yeah. Thank you, Dr. Kar, for the opportunity to introduce a very a stalwart in public health in India. It's a pleasure to again have Dr. Yogesh Jain. And I was just thinking, when was last time I interacted with him? It was just before COVID in our FETP Iphacon. And I remember Dr. Kar was also there. And he talked to us about his experiences from JSS. So for those of you who don't know, Dr. Yogesh Jain is currently running a very good initiative in Chhattisgarh called Jan Swasthya Sahyog, which he co-founded. And he's been there for many years. And I have had the opportunity to visit the place and was just completely in awe to see the kind of services they are providing and how grounded those services are in community and addressing the needs of tribals of not just their district, but all the surrounding districts from Chhattisgarh as well as Madhya Pradesh. He was earlier assistant professor in pediatrics at AIIMS prior to moving to Chhattisgarh. He has received many fellowships, awards for his contribution. And recently, they had also done a very good, a special report in Lancet, highlighting the tribal health issues. And he has several publications to his credit. And over to Dr. Yogesh, it's always a pleasure to learn from his grassroots level experience because he talks the language of people, and which many of us miss sitting in higher level institutions. Over to Dr. Yogesh.
As a public health practitioner in rural Chhattisgarh, I'm now going to discuss about the challenges in secondary level care that COVID has shown us to be important and the ones that have to be addressed. And I'm going to largely use the experience of my work in rural Chhattisgarh to buttress the case for secondary health care. So let's take it as that 15% of at least in the case of COVID-19, we saw that 15% of people require hospitalization, and that is those who require secondary level care. And almost almost all of the care for hospitalization had to be done in at least central India, in district hospitals or in medical college hospitals, and in some, in the second phase at least, in some private hospitals. But the CHCs and primary health centers were hardly the space where the places where secondary care was provided. Let's take it as that, very few block level hospitals, at least in Chhattisgarh, admitted sick COVID patients. That is also true. In fact, oxygen availability was very poor. The plants for oxygen came up only in the last few months. Almost no ventilation care, no non-invasive ventilation was provided in any of these block level hospitals, the CHCs of the country. And if the use of remdesivir was there, which is not always rational, but whenever it was there, it was for poor indications, and almost no use of tocilizumab was made in the CHC hospitals. In fact, all the lab investigations were largely outsourced to the private sector, making a mockery of what we call as comprehensive care. And almost in all of those block level hospital, long COVID care, that is post-COVID illnesses, is just starting. It's not even there really. So in the context of this, we started running as an experiment, providing secondary care for COVID in one of the most backward districts of central India, in Sarguja, in northern Chhattisgarh, where we showed that by running the ICU of, when I mean us, I mean my organization called Sangwari in northern Chhattisgarh, was able to run the ICU in the medical college and the district hospitals of Sarguja, where we showed that it is possible to run the services with some facilitation of future roles. And the quality of the ICU and the secondary care that we provided we managed to provide in this district hospital was judged to be superior to the private providers also by and contrary to the usual opinion by most of the people in the area, in the district. And we feel that some sustainable changes were made in the systems and supplies, especially in the laboratory. And post-COVID care could be initiated in the secondary care service that we ran, and the triaging and continuity of care could be initiated. Continuity of care with the tertiary care, and also continuing it downstream towards the primary care could be started in this way. And actually, we also realized that we didn't require any additional funds needed for this, except all the drugs and diagnostics came from the Medical Services Corporation of the state. So let's look at the role of secondary care as it is provided at the moment. In fact, pre-pandemic, what was the situation of district hospitals and CHCs? If you went to any district hospital in central India at about 7:30 p.m. in any evening, the one place where there may be light shining, otherwise the entire district hospital would be dark at 7:30 p.m. But the light shining may be only in the labor room and in the postnatal ward, largely because of the interest that we have given to the focus that we have made on maternal and child health care. And to this, add to this, there is also the special care neonatal units running in most of these district hospitals. Secondary care largely has been reduced to maternal and child health care and some trauma care in most of central India, at least I can say for. Who looks after, so therefore, if I may pose, who looks after a sick child with pneumonia admitted in the evening in a district hospital or even a CHC? Could it be a pediatrician? I would doubt it. What about someone who comes with a stroke at 6 a.m.? Is it likely that a person who's specialized in providing intensive care is available, or is an internist likely to be there to see a person at 6 a.m. or a neurologist? Or someone with a duodenal ulceration with a perforation coming at 6 p.m. Would a surgeon be able to see in good time? And we know that there are no ICUs in district hospitals, certainly not for adults, not for children, and even for the sick parturient woman. Suppose for all the sick obstetrics, emergency obstetrics, there is hardly any ICU in any of the district hospitals that I know of, or for newborns also. So, when we talk about universal healthcare, you can't provide that by having a minimal care package that we have reduced our secondary care to. And also just because of the primacy of primary healthcare, primary level healthcare, you cannot sort of provide, you cannot replace secondary care by just providing primary level care, and that certainly would not be any way amounting to universal healthcare. So we really need to build secondary care for good reasons. For example, and I would say for all emergency surgeries and not just cesarean sections, as it has been taken as a bellwether procedure, or oxygen is required not only for COVID-19, but also for other illnesses. Blood is necessary for malaria, to sickle cell, to major surgeries, and so many other illnesses, and not just for one particular illness. And we actually require a well-functioning laboratory for diagnosing common syndromes like fever without localizing symptoms or acute encephalopathy. Otherwise, we would be just groping in the dark and also making healthcare far more expensive and dependent upon the private sector. And also intensive care is needed when you provide secondary care. And I can pose some illnesses like severe malaria. You might be able to run acute malaria care, early diagnosis and prompt treatment at a community level. But when your patient gets sick with severe malaria, that they require second hospitalization and sometimes a significant intensive care. Or for obstetric emergencies, you can't just have cesarean sections and not be able to look after HELLP syndromes or after uterine perforations and placenta accreta or hypovolemic shocks. COVID also requires intensive care, as we know. We have seen it in the recent past. And what about acute strokes, which is one of the commonest illness in adults that kills people? And post-operative complications if surgeries start happening. So you require intensive care also as part of secondary care. And you also require ventilatory care, if I may add, for illnesses which are also important, snake bites, particularly the crate and the cobra bites. Obstetric emergencies often require ventilatory support, either pre-op or post-op. And neonatal asphyxia, one of the common one of the common remaining causes of infant mortality. Pneumonias of all types, not just COVID, whether it's influenza, whether it is bacterial pneumonia, and finally COVID also. So largely, if we say, if you put a figure on it, 25 to 35% patients who are in any area would require secondary level care. And the other thing is, this cannot wait. Even if this is a proportion less than 50%, this is something that cannot wait. So we need to have it here. And this requires, first, staff. It requires staff which is, which is trained internists, pediatrics, anesthetists, nurses, technicians, and lab technicians. When I mean technicians, I mean intensive care technicians or OT technicians. You require stuff like lab consumables, machines. You require drugs. You require monitors to be able to manage these secondary care. You require skills. You require skills of intensive care and not just extensive care, which often primary care is. And you require space. And specifically, you require blood banks. You require intensive care units. And finally, you require systems which has rosters, an ambulance service. You require continuity of care, up referral to a tertiary care and down referral to a primary care provider. And you require information systems that not only keep information, but also are able to connect the levels of care. And you need to be prepared for this new word that you have got into a lexicon, the surge capacity, which is the ability to set up 3 times the routine capacity and to routinely dismantle when the work is done. So this may be needed if at all we get a 3rd wave or 4th wave or whatever, as well as on other pandemics that we are not likely to sort of miss out on. And you require investment for this, but this investment in building surge capacity in a poor country like us should not be done by cannibalizing other illnesses care. So there's no point having COVID care being provided, but you're not able to provide care for childhood pneumonias or for vector-borne diseases. And you can't manage a maximal event like a pandemic in full surge like the 2nd wave that we saw with minimal systems. You need to have a system which has to have the resilience to build up also and to dismantle as soon as possible. Let's talk about staff in part of the secondary care. I think none of us would doubt the fact that we need to have a public health cadre to be able to run the systems well. It is a waste of time and energy to have clinicians who are running programs. They neither are often competent, and also they are wasting their skills, which they would be used otherwise in providing the secondary care, which is in the specialty that they come from. And we need to focus on non-physician health workers. I think we have to get out of our discomfort of encouraging non-physician health workers. They have to be the bulwark of even secondary care, I would say, whether it is the CHOs that we are thinking of or the staff nurses or nurse practitioners, if we can get to that class, or why not midwives, as we are often thinking of, but not doing enough. So whether it is even the ASHA also has to be supported, because it'll require a very well-linked chain from the peripheral level to the senior specialist. And we need to, what about training more formal health workers? I think we need to train the allied health professionals far more. I would not be keen on supporting sort of, more medical colleges coming up to churn out more MBBS graduates. And one thing I would like to recommend here to address the challenges of providing, secondary care is to ban private practice by public system physicians. This is a complete no-no. We cannot be allowed to be, subject to the held to ransom by people who threaten that they would leave the hospital, their medical colleges or their government job. I would say if it is to happen, it should happen. In any case, they're not serving the people largely when there is a conflict of interest in that they are using to provide care in their private setups. And we need to finally universalize free drugs and diagnostics. That is actually, by just providing that, we would be able to give 80% of what we call as UHC. So even though health is a state subject, there must be full resource allocation for this head from national government, like other national programs. And TNMSC actually leads by example. Tamil Nadu Medical Services Corporation, other states are learning, but still they have large paths to cross. Rajasthan has done it reasonably. Kerala, Goa, Mizoram, but others, and Delhi, others need to learn fast and quickly. Essential diagnostics also list has to be implemented. It's there, it's been decided by the ICMR, but still not operationalized in many states, including my own of Chhattisgarh. What about space in providing secondary level care? Do we need more medical colleges? I would say clearly no. Do we need more nursing colleges? I would say yes, but so as to check the imbalance between nurses and doctors in our country needs to be corrected. And I think far more allied health professional support is needed. Space we require for oxygen plants, but this plant should be used and not only to provide COVID care, but on basis of COVID care preparation, we should be able to support other secondary care. Beds, yes. I would argue that a 50-bedded isolation ward, out of which 10 beds should be ICU beds with minimum 5 ventilator beds in a district hospital situation, would be the necessary thing for providing care for a pandemic. 50-bedded ward, out of which 10 beds should be ICU beds with 5 of ventilator beds. What about pediatric beds? I've seen some places in Chhattisgarh starting with pediatric ICU beds when other care is not being provided. I would say this is not necessary. This is part of the mistake that we have made by investing in pediatric COVID care when we know that children are not going to be seriously affected. And I think, but yes, to build up a pediatric capacity for pediatric sick children for many other illnesses besides COVID is a good idea, and that is already been delayed. So we should do that, but not hoping that it should not be a vertical program for COVID, as my fear is that this might all our focus on secondary care at the moment might get reduced to. Systems, of course, we require system for surveillance. Otherwise, we would get episodes like the second wave, which caught us unaware, and actually we were a sitting duck for the second wave. Medical audits of our prescriptions, we know that we don't have a system in place for this, but this is necessary if we want to really move for having a cost-effective health system when we know that our funds are not unlimited for us. Health technology assessment to choose the right treatments and right diagnostics is a necessity that we should pick up from countries like Thailand and other places which have done a very good HTA things, and some work has been done in Delhi on that, but I think we need to sort of really take this to scale to be able to implement a good UHC. And we need a health regulatory development authority like structure, so that for us to be able to monitor the implementation of universal health care. Otherwise, if we work in disparate ways or in unregulated way, then it's not likely to work out the UHC. And we actually require universal health care and not Ayushman Bharat type thing, which is actually leaves such a large gap between the health and wellness centers at one end and support through the PMJY at the large end, and most of secondary care at the district hospital or CHCs, and to some extent on the PHC it falls through the cracks. So we require a really integrated continued care system from primary to secondary to tertiary, and secondary being the primary focus. So continuity of care and referral linkages, we need systems for both forward referrals and backward referrals back. So if a person with a hypothyroidism is picked up at primary health center, and a sample can be sent to a district hospital where a TSH report may be done, but the report may be sent back to the primary health center doctor for him or her to continue giving L-thyroxine later, rather than hoping that each time that the patient would go to a district hospital to collect his or her drugs. And for continuation, for linking, we should use not only internet in telemedicine, but we should also use cell phones for telemedicine for care and learning both. Most decisions can be taken on cell phones also. And triaging during surge in numbers of sick people, we have had some good learnings from Maharashtra, particularly Bombay, and some other places, which we should learn to do proper triaging. Otherwise, we make a mess of our secondary care if we don't do those things. And supporting peripheral workers and communities will have to continue by our providers in secondary level facilities. And inter-facility linkages for both patients and information should be done. And enough investment should be made into this particular requirement also. Finally, nothing can be said about data management, which is also a very, very important thing. Thanks for for this attention, and I would be happy to take any questions that might come up over this time. Thank you.
Thank you very much, Dr. Jain. That was an extremely comprehensive talk. And before wasting further time, I think we should move on to the next session by Dr. Rajni Ved. Again, a very well-known face in the field of public health. Dr. Ved was former executive director of NHSRC New Delhi. She has a medical degree from Madras University and an MPH from Harvard. She's also a visiting scientist there. She has nearly 3 decades of experience with community health program, health system strengthening, implementation research, and in scaling interventions. She's a Lowndes Senior Scholar and visiting scientist, Harvard T.N. Chan School of Public Health, 2016 onwards, and a MacArthur Fellow. And for those of you who may not be aware, Dr. Ved was instrumental in designing and putting in place the population-based screening for non-communicable diseases, which is one of the flagship programs of Government of India. Over to Dr. Ved to share her thoughts with us. Thank you.
Thank you very much, Pravdeep. May I have the first slide, please? And while that's coming on, I'd like to thank the organizers for inviting me to participate on this panel. You've already heard Dr. Anthony and Dr. Yogesh speak about one from the civil society perspective and another from grassroots experience of delivering secondary care. My presentation, can I have the slides, please? So, oops, Sitansha?
Yes, it's coming, ma'am. It's coming.
All right. So I can really start. So my presentation actually takes a slightly different tack. Given that I've spent years, as Pradeep said, with the National Health Mission as part of National Health Systems Resource Center, I want to take a reflective look, next one please, a reflection back, if you like, to look at what our health system looked like before the pandemic. Truly, the world is a world before the pandemic, during the pandemic, and hopefully soon after the pandemic. So the first part of my presentation focuses on what was the health system like before the pandemic, what were our achievements, and what were some of the challenges, or if you will, the tasks undone. The second part of the presentation focuses on COVID-induced investment announcements, building on an existing health system platform. And from Dr. Anthony and Dr. Yogesh's sessions, I leave it to you all to decide which of these announcements would actually need to be tweaked before they're actually implemented. And finally, a little bit of time on how do we create a resilient health system, linking back to the title of our plenary, which is Roadmaps to Universal Health Coverage. Next one, please. So where were we at the start of the pandemic? For the last 15 to 16 years, India has implemented the National Health Mission, which, as Dr. Antony pointed out, occupies a chunk of our health budget, the largest chunk of our health budget, but has also enabled in creating a health systems platform for primary and secondary health care. A few of its achievements was to add substantial human resources for health, including 1 million ASHAs. And the reason I bring up ASHAs is it's almost inconceivable that we would have had the kind of limited response that we had in rural and to a limited extent in urban areas to COVID, undertaking functions of tracking, supporting isolation and quarantine. And if any essential home-based care services were being provided, it was by the ASHAs. The second major achievement is the access to emergency transport and referral systems in most parts of the country, providing universal health care for maternal, newborn, and infant health care in public sector facilities. So yes, we haven't yet traversed the full path to UHC, but certainly as far as MNCH is concerned, we have traversed quite a distance. Expansion of services at peripheral facilities and through outreach, especially for functions like antenatal care, postnatal care, population-based screening for non-communicable diseases, etc. Fourth, creating the governance mechanisms for decentralized planning and resource management, which stood us in good stead in the last 1.5 years as we were trying to mount a response to COVID. And finally, NHM did attempt to integrate vertical programs for infectious and for non-communicable diseases. This was a 16-year effort and it's still continuing. The second major reform was the paradigm shift in primary healthcare systems through the announcement of the Ayushman Bharat Health and Wellness Centers in April 2018, denoting a shift from selective to comprehensive primary healthcare. And what did this result in? Two major achievements were increase in use of public health facilities and some reduction in out-of-pocket expenditure. Next one, please. So the NHM investments, very briefly, I'm not going to just ignore the numbers, basically to say 14.5 lakhs or 75 lakhs of HR, of which we had over 1 million ASHAs, medical officers, Ayush practitioners, addition of staff nurses, multi-purpose workers, male and female, community health officers as our most recent addition, who is a non-physician health worker, without whom, by the way, many of the functions that in the health and wellness centers that were operational, community health officers played a very important role in undertaking public health functions. We had pharmacists, lab technicians, and specialists. The NHM enabled the conversion of primary healthcare centers to 24/7 PHCs, representing an almost 15-fold increase. So today, out of the 25,000 primary health centers, we have nearly 15,528 primary health centers, which are 24/7. Some 2,000, almost 3,000 community health centers are functioning as first referral units, limited, as Yogesh said, largely to care for maternal health, but still, at least that is available. Adding 42,000 additional beds because of 600 maternal and child health wings in district hospitals and sub-district hospitals. From a baseline of almost zero, the addition of 21,553 ambulances, mobile medical units for expansion of outreach, and mainstreaming Ayush in several facilities. Next one, please. Can I have the next slide? Okay. Right. NHM also enabled, remember it was about primary and secondary healthcare. So it also enabled secondary care services, and don't worry about the numbers, but just look at the conditions that were supported, non-communicable diseases in the form of NCD clinics and cardiac care units and dialysis facilities, mental health, geriatric care, rehabilitative care, and oral health. The point I want to make here is that these services were selective and not necessarily linked to either the primary healthcare facilities or an organic linkage to tertiary healthcare facilities, leaving them as isolated centers at district and sub-district levels, incapable of responding to primary healthcare needs. Next point, next slide, please. So I just have a couple of slides on achievements. I'm not talking about reductions in infant mortality, newborn mortality, maternal mortality, and under 5, all of which were substantial and at quite a rapid pace. The point of this slide is really to say in 2014, when the proportion of women who availed antenatal services in the public sector was 59%, within a 4-year time span, it increased by 29%. In rural and in urban areas by 30% for ANC. For use of public sector hospitals for institutional deliveries, we went from 56 to 69%. And in urban areas, we also saw an increase of 14%. And for women who availed postnatal care in public sector facilities, a corresponding increase, 56% in rural areas and 46% in urban areas. So basically to say that the investments of the National Health Mission targeted largely to maternal, newborn and child health did pay off dividends in terms of increase in use and access of public sector facilities. Next one, please. So another slide to show how when investments are made in public sector facilities, how they bring down costs of care. Now, this is for inpatient care, not just for maternal health, but for overall inpatient care. You can see that between 2014 and 2017, which is when we have NSSO data, I didn't use the earlier round, you have a decline in public sector expenditure in rural areas by 23%, in urban areas by 37%, and a corresponding increase in the private sector in rural and urban areas to from an already very high baseline to a even higher level. Now, you might ask, why should there be any expenditure at all in the public sector facilities? It's because we invested largely in maternal, newborn and child health and much less in chronic diseases that we were unable to provide care for the chronic disease conditions which are required at secondary and tertiary levels. Next slide, please. Now, in 2018, and I won't spend much time on this, this was the Ayushman Bharat. It has two components. In contrast to what everybody thinks, the Pradhan Mantri Jan Arogya Yojana is one part of the Ayushman Bharat. The larger foundational component is a primary healthcare initiative to strengthen our peripheral facilities to health and wellness centers. Basically, over 75,000 of them are operational. And as I said earlier, even these 75,000 in the times of COVID have proven to be invaluable in supporting the public health response from the public sector. I won't spend time on this because of paucity of time and I have to get to the next slides. Next one, please. Okay, so regardless of all these investments over a 15 to 16 and of course a much earlier period since independence, what were the major gaps highlighted by COVID? So COVID showed us all the parts of the dark belly of public health really, which never came into the limelight before. There was a lack of convergence between essential public health functions and the service delivery system. And by this, I mean functions like surveillance, monitoring of illnesses, health literacy, workforce development, enforcement of public health rules and regulations, creation of a public health cadre, and lack of investment in public health and epidemiological research. It also showed us that we had insufficiently capacitated district and block health systems, and therefore we were unable to mount a decent secondary care response, and they were also unable to serve as a unit for planning, implementing, and monitoring, relying instead on state-level decisions. Third, the health system was unable to manage the dual responsibility of responding to the pandemic and continuing to deliver in an uninterrupted fashion essential functions. Fourth, fragmented urban primary healthcare. In a country that's almost 35% urbanized, we are unable to provide primary healthcare to our urban areas. And the comprehensive primary healthcare system in rural areas is still nascent. A retreating private sector, much has been spoken about that already. And really, we cannot rely on the private sector to provide essential public health functions because there's no user fees, there's no competition, there's no performance-based incentives here. The rules of contracting would have to be incredibly complex to allow the private sector to take any part in delivering public health functions. We also have a weak research capacity, which is not nimble. It's slow to respond to policy and programmatic needs. We have ill-defined mechanisms for multi-sectoral convergent action, which was clearly required during the pandemic, and also to address the social and environmental determinants of health. We have limited capacity and engagement of the local government bodies and with the local government bodies to support health systems. And finally, and perhaps the most important, the persistent barrier of equity, which we've never been able to overcome, despite all these investments or lack thereof, exacerbated multifold during COVID. Next slide, please. So the next 3 slides really talk about the investments announced by the government, and all of this data is in the public domain. The first response package announced in April was the Emergency COVID Response Package 1 of 15,000 crores, which focused entirely on providing for dedicated COVID facilities, COVID health centers, COVID care centers, oxygen-supported bed, isolation-supported beds, and ICU beds. The second package, which was announced in July of this year, is about 23,000 crores. It enables pediatric care units in all districts. And I hear Dr. Yogesh, why is it necessary when COVID itself is not such a big deal among children? However, hopefully it lays the ground for having good pediatric care units at all district hospitals. Pediatric centers of excellence among the National Institutes of Excellence to support the district centers, providing for a buffer stock for essential medicines for COVID management in the district, creating field hospitals and prefabricated structures at all levels of the health system, particularly to meet this excess surge capacity that's needed, creating 1 unit in each district of a liquid medical oxygen storage tank with a medical gas pipeline system, augmenting the existing fleet of ambulances, engaging final year medical students, and supporting states to ensure that we maintain a certain level of testing per day. Next slide, please. The second major announcement that also came during this period is the announcement by the 15th Finance Commission to about 70,000 crores over a 5-year period to panchayats in rural areas and urban local bodies. Again, much needed support for diagnostic infrastructure. Look at it, urban primary healthcare will get 63% of this total allocation and 37% for rural areas. So support for diagnostic infrastructure, creating urban health and wellness centers, which is basically decentralizing primary healthcare in urban areas, infrastructure for sub-health centers, primary health centers, and community health centers to meet the infrastructure gaps, creating block public health units, which would support block public health units, which would integrate the functions of service delivery, action on social and environmental determinants, public health action, laboratory, and reporting. And finally, running costs for a set of rural primary health centers and sub-centers to be converted to health and wellness centers. Next one, please. Finally, the most recently cabinet cleared program, which is 64,000 crores, is the Atmanirbhar Swasthya Bharat Yojana, which is both central sector component and a centrally sponsored scheme, but focus is much more on strengthening the public health functions, the National Center for Disease Control, creating new institutes of virology, better surveillance at ports of entry, expansion of an integrated health information portal, and filling in the gaps that the 15th Finance Commission will not be able to fill in completely. So infrastructure gaps in rural as well as urban areas. Next one. Okay, so what is the way forward really, or the roadmaps? And all the speakers before me have presented different views on what they think the way forward should be. For me, the first and most important is a social compact between the public and the people, between the government and the people, but not government as a last or an only resort, which really was kind of the prime feeling in the last 1 year, that because there was nothing else, people flocked to the government sector, but it should not have to be like that. So any future health systems or building back better or roadmaps to universal health coverage will have to make sure that this social compact is created. It also needs meaningful engagement of civil society and bringing them back full time into the public health system. Second, of course, which others have said before, building public health competencies across cadres, creating a public health cadre. It's high time and not to be limited to a few states only. Reorganizing service delivery to improve both service quality. So shifting functions like screening for chronic disease, routine management of follow-up of chronic disease patients, and moving up surgeries and other functions higher up to the system. Given the fact that we do have technologies, that we do have better transport now, this should be made possible. And also given that COVID really was much more severe in those with existing non-communicable or chronic diseases, much more attention to be paid to chronic disease care. Improving mechanisms for quality of care in health facility, going beyond the present certification and accreditation mechanisms, which all of which is just a checklist and a tick box. We have to go much more into ensuring that quality is ingrained into the teams that perform at public health facilities. A complete overhaul of data collection, analysis, data quality improvement, and feedback systems. Use the learnings to design and implement health in all policies, again, a much overdue reform. Strengthen research competencies. And finally, improve the capacity to convert evidence to policy in real time so that it is meaningful to policymakers and practitioners alike. I think this is the last slide. Thank you. Maybe you should.
Yes, thank you so much, ma'am. Now we'll move to Dr. Sundararaman's session. Sir has already given the introduction by Dr. Arun Kumar Agarwal, because we have to close this session at 10:30 for the oration. So we'll go to the session directly. Is that okay, Dr. Sundararaman, sir?
Yeah, please go ahead. Please, thank you.
Thank you for this invitation to speak in this panel discussion. All my co-panelists are people whom I have worked with, and it has been a great experience to work with them and now to share the stage with them. One dimension of the road towards universal health coverage, which the pandemic has emphasized, is the need to build what are called resilient healthcare systems. Now, what exactly do we mean by resilient healthcare systems? There are many definitions going out there, but the definition of my choice has been to look at it as health systems resilience can be defined as the capacity of health actors, institutions, and populations to prepare for and effectively respond to crisis, maintain core functions when a crisis hits, and informed by lessons learned during the crisis, reorganize if conditions require it. A further elaboration in this is that resilience is an emergent property of the health system as a whole rather than a single dimension. These are useful concepts to keep in mind when we examine our experience with the COVID-19 pandemic. There are conceptual analytic frameworks that have tried to measure resilience and that they have tried to assess resilience, or the features that make for resilience. What makes a system more resilient? One of those which are commonly used are these two, Johannes and Margaret Crook, and all of them in some way relate to the building blocks, but their emphasis has been on different areas. Now, when it came to examining the Indian experience, I found both of these have ways complex and not quite suited, but taking a bit from both and combining to make our own, we developed a resilience framework on the basis of which we proceeded in our study on this. So, I would like to actually look at resilience, as we have learned from the pandemic, as a health system which copes with a crisis with less disruption of social and economic life, with less disruption of other essential health services, and also leads to a lesser COVID morbidity and mortality, which learns and adapts to new situations better, and where there is equity in the response. I think there is a need to build our definition of resilience along these lines. And the features that lead to resilience are the preconditions, as in Margaret's framework: adequate financial resources and adequate human resources, both number and in the nature of human resource policy. But once these are in place, one looks at the key design characteristics of each of the building blocks separately. So, these would be a framework which is much more useful on this. One point that one needs to emphasize is that the lockdowns are seen as necessary and as having been the main source of strength. But there are lockdowns and there are lockdowns. and the stringency of a lockdown, there are countries that did not actually stop schools, there are countries that did not stop public transport, there are countries that stopped it, but for much lesser time and at different points on the pandemic. There is much learning to be done on this issue. But one quick point that I would like to make is that if you look, there is no automatic correlation between the stringency of a lockdown, the duration of the lockdown, and the final outcomes in terms of cases per million or deaths per million. So, we need not look at lockdowns as a given, we need to probe further to understand what lockdowns, how much of this disruption was necessary in the first place is a question that we need to ask. And we need to, as I said, define resilient systems as responding with limited disruption of social, economic life and essential health services. This point is something that once we look as a criteria, we would be able to comment much better and build back better. Now, fortunately, there is some information available on it. It has its weaknesses, but eventually it's better than nothing. There is a operational guidance released by WHO on June 1st. So, actually the recognition that you may be having a lot of excess deaths, not due to the pandemic, but due to the closure of other essential services came in quite early. And there were two surveys that WHO has done across most of the countries in the world with a very high response rate, which tries to understand the extent and the causes of disruption. So, while disruption was universal, disruption was much more so in some countries compared to others, and that was partly due to policy issues and partly due to other issues on there. And if you look at why there was disruption of essential services, some of it was, a lot of it was because patients couldn't reach the facility or even didn't want to reach the facility because they were worried. Others were from the supply side, the cancellation of elective care, the redeployment of clinical services, the closure of outpatient disease specific consultation clinic. So, all of it is not therefore patient behavior, much of it is government policy. And then there were gaps like insufficient personal protective equipment, lack of changes in treatment policies, stock outs of health products which take place because supply chains are disrupted. So, there were the mixture of issues that lead to the disruption of services. Now, if you look at preconditions, there is data that supports this, but broadly I would say that they are obvious, that nations that spend more on health tend to do better. Now, if you look that within a category of nations, now if you look among the developed nations, within that category, then the design features will dominate. But you would find a difference between a poor income country and a much better country if you adjust for reporting efficiency. Nations that have more financial protection will tend to do better. Higher densities of human resources will tend to do better, and nations that have more investment at all levels of healthcare, including ICU beds, do better. I am saying they do better in COVID care and they do better in maintenance of non-COVID services. It is actually more difficult to demonstrate they do better in terms of COVID care because of data issues. But having said that, that's not what I am basically addressing. The point that I would like to make is within subgroups defined by financing and human resource deployment, the variation from this norm, those who do better would depend upon design characteristics of the system, which is what I would like to focus this talk on. One way to understand why, say, between the South Asian countries, some had less disruption of immunization services, some had less disruption of TB services, some had less disruption of essential surgeries in the district hospital. One can look at best practices, places where there were less disruption, and see what did they get better why, though they had similar human resource issues, though they have similar financing issues, how come their disruption was less than in ours? And we tried to do a study on this grounds. And what you learn from studies is that you find that local people, very often for problem solving reasons, have actually come up with innovative design solutions to get across the barriers, and allowing people to share these positive examples and showcase them provides the administrative and political will to do better. Otherwise, everybody accepts the closure and the failed services as some sort of God-given law. It's not so. It's actually, it was eminently avoidable, and many of these, there are places which manage severe crisis without such closures. And therefore, if we learn well, we would be prepared for the next wave important, or next wave in a much better way. And one of the important ways in which we can do this, because there is not uniform homogeneous data available, we need case study methods on this. So, there was one WHO study on best practices in the Southeast Asia region, all best practices on non-disruption of services, which I am associated with, where we picked up 20 best practices. Some of 5 of them on immunization and RCH, 8 on disease control, 3 on NCDs and 4 on other areas. And totally we had about 20 studies from which we could draw some interesting conclusions on this. Broadly, we can say the wider the package of primary care in the organization of health services, that building block of a health systems matrix, the wider the package of primary care services, the more resilient the system should be. And you could see Thailand and Sri Lanka having far less disruption because their comprehensive care packages are much wider. Okay, we are looking at disruption of services from what they themselves have reported in the surveys and what we know by dialogue with them. The continuity of care between levels at the same care between levels and at the same levels depended, there were a lot of innovations that were used in this area. Telemedicine was used in a big way, mobile vans, online consultation. The closer to community, the more community engagement was associated with much better ability to retain essential supplies, for example, able to continue diabetic drugs without disruption. So, we have number of good cases which did that and compared to places which did not. Adequate surge capacity is another, and less privatized, the more publicly administered the proportion of service delivery, the more likely that they were resilient and they were able to. So, there was disruption in public services and private services, but the disruption in public services was much shorter duration and much less than the private services, which seized much more longer and much more selectively, despite very often they being covered by insurance programs. The other set of issues relate to information systems, and here it is very important the way it works much better. Where we have decentralized use of information systems, you could use feedback from information systems that showed that this block is doing badly or that district is doing badly to make sure that your immunization targets, your RCH targets are retained very well. So, information systems help you to pick up disruptions of essential health services and fix it. But for that, routine HMIS services themselves must remain functional, and that was a challenge in many of these areas. And one of the big challenges was the integration of the HMIS with the disease surveillance program, because without that integration, very often we couldn't make sense of the data at all. So, I think the whole system of how you would link these have to be thought through, but there were very interesting examples. I will quote one or two. For example, the malaria control in southern Odisha, where actually because of good pointed data, they could step in and make sure that the gap that had fallen in essential health services was closed. The other issue is on resilient healthcare systems. So, where you have a good public health logistics, you do not have, for example, a problem with oxygen. Kerala and Tamil Nadu had one or two ruptures of services here and there, but they were last mile gaps. There was no crisis in oxygen in these states. Kerala also had its own medical oxygen supply mechanisms, but in most of the places there are very good logistic systems that were able to provide the test kits, the reagents, the medicines in time. So, you need that better. And again, the scaling up of domestic production amidst disrupted supply chains. Some were in vaccines, everybody had a problem, but diagnostic kits, for example, India did a remarkable job on scaling up from a very few, less than 1,000 to almost a few million kits per day. That sort of scaling up was possible in some and is a major feature of resilience. And where you could not on any product, like for example in protective equipment, that definitely affected all services, not just COVID care. Design characteristics of resilient health systems on human resources relates to two dimensions. One, how the system supports the health worker, and very often in terms of organization training. I mean, we are not talking of the COVID worker now. We are talking of non-COVID workers on how they are seen to be protected against the stigma, how their guidelines and how their service delivery guidelines are tweaked, how their terms of services are there, how whether they are contractual or whether they are permanent. So, all of this makes a huge difference. And I think that the whole lessons that we learn, a lot of it relates to not only the numbers of health workers, which we were calling a precondition, but the implementation of health policies and the positive work environment that existed prior to the pandemic and how it was managed within. To give you a flare of how these case studies worked, let me cite for you the case study from southern Orissa in malaria, an area that had shown a remarkable gains in malaria control over the last few years, was threatened with a resurgence of malaria, which they detected because of a good information system. The response was to integrate COVID-19 control with malaria control. So, when you go for a fever or you go for a household visit, you ensure that you look for both whether they are using bed nets and whether they are using masks, whether they are testing for malaria or whether they are testing for COVID. And you follow these principles, both programs were able to do better. Similarly, at the hospital level also, we have the case study from Nepal, my favorite one, where in one large public hospital, which provided a whole lot of maternity services in Biratnagar, the leadership was determined to continue both services without disruption. So, they opened up a separate wing for the COVID-19 services, built help desk to guide patients, reassured health workers, had very good infection prevention and control, used effective signages, all the while not for managing COVID-19, but on the non-COVID side also, so that those services also received the same attention. They followed this up with high publicity, so that people knew that the services were open, revised protocols. The single most important thing was one, that they had a leadership that at all cost was determined to maintain its priority. So, the gynecologist was keen that no pregnant woman be pushed into institutional delivery, and you saw some decline, but compared to 46% decline in much of Nepal's hospitals, this saw only an 8.3% decline. And you could see that similar thing I have heard from mental hospitals, where they were able to mental departments, psychiatry departments that were able to ensure that the people who came regularly for their medicines somehow got their medicines. Just didn't sit back and say, it's not my responsibility, I'll have to leave it to what happens, but took that extra mile. When it comes, therefore, the lot of relationships, lot of learnings relate to governance. Decentralization helps. Learning adaptive systems helps. A determination for affirmative action to reach the most vulnerable helps, And above all, it is the system of values, whether the government sees itself as committed to providing health care for all, or whether it provides only to which services that private sector is unable to provide. So, it says, okay, COVID-19, we have to manage the rest, we leave to the private sector. So, this mechanical repurposing of public hospitals to provide crisis care and leave the rest, dump the rest into the private sector is really unacceptable and should be one of our basic understandings of what a resilient healthcare system means. This is based on a number of studies that we have done, but also on other sources. The top two studies are the one that I have quoted in this presentation. Thank you.
Thank you, Dr. Siddharaman. I would like to know from Dr. Sitanshu if there is any time for questions, or should we summarize and close?
Yeah, so we have 3 minutes to conclude the session. Please summarize. We will not be able to take questions in the interest of time.
All right. I request if Dr. Anup can go first, and then I can go.
Sure. I think Dr. Sitanshu, I mean, the thought behind organizing this plenary was very good. Actually, all learned speakers, if you see that they started from the need of UHC and whatever investment and challenges of UHC, and then I mean the major point was that there are COVID, there are care centers everywhere, but actually there is no care at any of the place, and so many lacunas in the secondary care. This is all pre-COVID. This is pre-COVID, and so many points were raised by Dr. Jain that our health systems are practically defunct during the early hours or late hours, and referral mechanisms and all that. And then it was built on that in the pre-COVID era, that how NHM actually rebuilt the infrastructure, gave some hope and some credibility to the system. But all those were basically input indicators or process indicators. But really, some states made use of all that and started providing good care in terms of NCD clinics, dialysis centers, CCUs, etc. We ourselves have witnessed when we had gone for national health review missions in like Odisha. So these services were there actually. So this is all the impact of NHM. But then COVID actually realized us that there is lack of convergence, integration, and lot needs to be done. Lot of gaps, and the most important gap was that how to actually take care of the routine services to meet the crisis, and this thing was faced by everyone because there was no new sanctions of human resources infrastructure even at PGI Chandigarh. When we are to make a COVID hospital, we were asked to draw the manpower from the other sections. So if you are drawing the resources from the other sections, naturally those sections will suffer. But then with the excellent research work and analysis of so many case studies, and I think Dr. Professor Sundararaman had showed the pathway that actually how you can maintain the routine services, essential services to some extent, so that you can manage the crisis. So bolte hai na, this is said that I mean when there is war, and when suppose you are surrounded by enemies, your job is not only to fight the war, your job is also to meet the essential needs of the public you are serving. So the king who is able to maintain balance between the two actually is more successful than the one who draws all the resources from the community and puts it in the war. So this is how I think all these sessions were so linked. And I say that, I mean, when the pandemic struck, I mean, at that point of time, probably it was not possible to predict whether to have lockdown, with what frequency, what will be impact. But now with the learning, global learning, Now we should be prepared to tackle it for the future. With these comments, I hand over to my co-chair.
Yeah, sir. Thank you very much for that excellent summary. And I think it was the best sort of panel I have heard after COVID. I really request Dr. Sitanshu to make this available through a website or something. And I would like more people to hear this. I'm not sure how many were able to hear it today morning. It was a great learning for me and a lot of reflections. There's just way too much to absorb, but I would like to summarize few key points. I think one cross-cutting issue that we already had a fragile health system, and COVID just reminded us of that. COVID was a teacher, as Dr. Anthony said. They also say COVID is a best CEO because it taught the whole world how to do things differently. So COVID has been an eye-opener to all of us, and highlighting again the need to invest more in the health system, primary healthcare, secondary healthcare, and so on. And more importantly, I think the issue of inadequate investment, which has been highlighted by public health experts over decades. I think it's high time that there is more political will to take it forward. Very important issues were highlighted and gaps in secondary healthcare, which I did a lot of field visits during COVID, and I observed how the systems were just crumbling. We were really doing what we call as a stress test, right? If you've been on a treadmill, you know what a stress test is, and this was a stress test of the health system, and everything was just crumbling under that pressure. And at the secondary care, very important issues have been highlighted by Dr. Jain. We really need very good secondary care hospital, and he gave very good sort of summary saying staff, skills, space, systems, all of that. We need a kind of framework as to what a secondary care should look like, and also what it should look like during surge capacity. And I like the term he used. We cannot provide care during pandemic by cannibalizing the care for other illnesses. I think that's an excellent word, and I'm going to use it in my classes hereafter. And Dr. Ved highlighted the investment made in National Health Mission, which definitely helped us in coping during this pandemic. It was very clear that services at PHC, hospitals, 108 ambulances, a health wellness center, which were the only sort of points of care for many people when all the other transport was shut down. Personally, I have seen that for NCD services, which I'm closely involved, that only place people could go and get drug. So the health wellness center, which was recently started, really came to rescue. And I think the big issue was how can health system take this dual burden of COVID and essential services, which is highlighted by Dr. Sundaraman, and looking at various case studies, what worked, what didn't work, and what we can learn from places where it worked well, and how we need to design our health system differently to cope with the surge. And most importantly, which is something very close to our heart at NI, building public health cadre. Without that, we really cannot run our health system. We need dedicated public health cadre. We need good information system capacities for data analysis and rapid translation of evidence to policy. So thank you very much. And with this, I think we can close this panel. And I really hope all those who didn't attend should listen to this online on some website. Thank you very much.
Pranam sir, pranam ek baar. It was a great deliberation, and it was privilege to be here.
Thank you for chairing and co-chairing, both of you. And it was a good enriching.
So thank you so much. Thank you so
Sitanshu.
much, all the chairpersons and the speakers for this excellent panel and excellent deliberation. Because of the want of time, we'll not be able to take questions. But as Dr. Pradeep said, we are going to make a repository of this, all this learning that we had from this conference, and we're trying to post it there. With this, I conclude this session. Thank you so much once again. Thank you so much.
Thank you. Thank you very much.
Thank you.
Now we move to the next session, which is the oration of our Dr. Vishidas Gupta oration. Will be joining very shortly. Thank you so much.
Dr. D.K. Srinivas, Chairperson, Vishidas Gupta oration. Sanjay Rai, Gautam.
ಏನು ಈಗಲೇ ಕೆಮ್ಮು ಬರ್ತಾ ಇದೆ. ಇತ್ತಮ್ಮ ಲವಂಗ ಕೊಡಿ, ಕೆಮ್ಮು ಬರ್ತಾ ಇದೆ. ಲವಂಗ ಕೊಡಿ, ಕೆಮ್ಮು ಬರ್ತಾ ಇದೆ.
Mic is on, sir. You can talk. Yes.
അല്ല ഇത് മണിപ്പൂർ
ഗവൺമെന്റ് അരുണാചൽ പ്രദേശ് ഇൻവൈറ്റഡ്
അവിടെ പോയി സ്കൂൾ
They have not done.
A very good morning to everyone, and welcome to Iphacon 2021, the 65th Annual National Conference of the Indian Public Health Association, being organized by the Department of Preventive and Social Medicine, JIPMER, the JIPMER International School of Public Health, in association with the Pondicherry State Branch of the Indian Public Health Association. So we welcome you all to the oration of Dr. B.C. Das Gupta, and I'm pleased to invite our chairpersons for this session, Dr. Sanjay K. Rai and Dr. Gautam Roy. Now, both of them are stalwarts in the field of public health and need no formal introduction. But I would just like you to know that Dr. Sanjay K. Rai is a professor at the Center for Community Medicine, AIIMS Delhi, and is also the president of the Indian Public Health Association. And Dr. Gautam Roy is a professor, senior scale, in the Department of Preventive and Social Medicine at JIPMER, and is also the organizing chairperson for the Iphacon 2021. So with this, I would like to invite Dr. Sanjay K. Rai to open the session and briefly talk to us about Dr. B.C. Das Gupta. Over to you, sir.
Thank you very much. Very good morning, most valued member of the Indian Public Health Association, delegates, dignitaries, ladies and gentlemen. On behalf of Indian Public Health Association, as a president of IPHA, on behalf of my co-chair, Dr. Gautam Rai, and on behalf of organizing committee, I welcome you all in this 65th Annual National Conference of Indian Public Health Association. It's my really privilege to introduce introduce Dr. B.C. Das. Dr. B.C. Das Gupta, former director of Health Services and Secretary Medical and Public Health Department, Government of West Bengal, and a veteran public health experts of India, dies at his Calcutta residence on Tuesday, the 4th January 1966, after a brief illness. He was 73, and they survived by his widow. By his death, India has lost one of the most experienced health worker and illustrious son, whose contribution to the improvement of health services in India and towards world health are outstanding. Dr. B.C. Gupta was born in a rural town of Patukali in the district of Borisal, East Bengal in 1892, and was educated in the local high school. He studied intermediate with science in Bangladeshi College, Calcutta, and obtained his BSc from Dhaka College. He entered the Calcutta Medical College in 1913, secured 2 scholarships in his college career, and graduated from there in 1919 with distinction. At the end of 1941, he accepted the post of Chief Medical Officer, Bombay Corporation. During the tenure of his services in Bombay and Calcutta, he served in many committees. To mention a few, he was a member of the board committee and chairman of the environment and hygiene committee set up by the central government. He attended several meetings at Geneva as a member of the WHO expert committee on public health administration. He also visited Canada and Geneva as a public health expert from India. He was also the chairman of the Indian Red Cross Society, West Bengal and St. John Ambulance Brigade. After retirement from the West Bengal service, he served 2 terms of 4 months each as WHO visiting professor in Bangkok. He was as much interested in public health education in this country as public health service. He conducted the DPH and sanitary inspector course in Bombay and was also a guest lecturer of the All India Institute of Hygiene and Public Health, Calcutta. He was a member of the Indian Medical Council and was called in by different universities to conduct both doctorate and MBBS examinations. He was the founder president of the Indian Public Health Association and was the first editor of the Indian Journal of Public Health and served in this capacity from 1957 till the end of his life, almost for 9 to 10 years. So this is all about Dr. B.C. Das. I will request my co-chair.
Thank you so much, sir. Now I invite Dr. Gautam Roy to introduce us to our orator for the day, Dr. D.K. Srinivas.
Thank you, Dr. Suri. Good morning, everyone. It's my honorous task to introduce a person like Dr. D.K. Srinivas. Dr. D.K. Srinivas, MBBS 1961, MD Preventive and Social Medicine 1967, and postgraduate diploma in distance education 1989, was born at Bangalore on 30th January 1938. He taught community medicine in Maulana Azad Medical College, New Delhi, at Goa Medical College, Panjim, and Jawaharlal Institute of Postgraduate Medical Education and Research, also known popularly as JIPMER, Pondicherry. He finally retired from JIPMER as the dean of this college. He is one of the early birds working for development of medical education in India. He received special training in medical education on a WHO fellowship at the regional teachers training centers at Peradeniya, Sri Lanka, and at Bangkok, Thailand. He was one of the first founding faculty of the first National Teachers Training Center, NTTC, at JIPMER, which was established by the Ministry of Health and Family Welfare, Government of India, New Delhi. He contributed actively in the development of 2 other NTTCs in JIPMER, in India, one at PGI Chandigarh and at the Institute of Medical Sciences, BHU, Varanasi. After his tenure as the Dean of JIPMER, he was invited by the first Vice Chancellor of Rajiv Gandhi University of Health Sciences, RGUHS, Karnataka, Bangalore, to be the consultant for the curriculum development of the university. He made pioneering efforts in developing the curricula in wide spectrum of undergraduate, postgraduate, and super specialty courses like medicine, medical, dental, nursing, pharmacy, physiotherapy, Ayurveda, homeopathy, Unani, and other allied health sciences. The other notable contributions of Dr. D.K. Srinivas include introduction of teaching of medical ethics in all courses of RGUHS, internal quality assurance, introduction of postgraduate synopsis review, strengthening of primary health care and disaster preparedness training. He has been a training consultant to medical education centers across the country, to various state governments, to the Government of India, WHO, and the World Bank. He has contributed to 5 books and published over 95 papers in peer-reviewed national and foreign scientific journals. He is a member of the Board of Management, Academic Council, Planning and Monitoring Board of a few universities. He is married to Miss Geeta and has 2 children and 5 grandchildren. His hobbies include swimming, cycling, and reading. Thank you.
Thank you so much, sir, for this wonderful introduction of our orator for the day. Now, customarily, we would have presented the medallion to Dr. D.K. Srinivas, but today we're doing it virtually. So I request Dr. Sanjay Rai to felicitate Dr. D.K. Srinivas with the IPHA medallion for Dr. B. Dasgupta oration.
Thank you. Thank you very much.
Thank you so much, sir. Now I hand over the stage to our orator for the day, Dr. D.K. Srinivas, to deliver his oration. Over to you, sir.
Thank you. Thank you. Am I audible?
Yes, sir.
Yes. What a pleasure and privilege to be with, may I say, my earlier department, because if I say my, Gautam will be very angry. But it is my earlier department. I joined the PNSM department at JIPMER in 1970. As Dr. Gautam Rai said, I retired in 1996. And after 51 years, I'm back at the department, virtually as it were. And it's a great privilege. It's very happy, very emotional. I put off the video because I was so emotional. And thank you, Dr. Gautam Rai, for introducing me, saying so many good words. Because he was my previous student, no wonder. It is all, I would say, conflict of interest. There was no conflict, but he wanted to please me. Thank you, Dr. Gautam Rai. I thank the honored president of the Indian Public Health Association, Dr. Sanjay Rai. So nice to meet you, Dr. Sanjay Rai. And also Dr. Sangamitra Ghosh, the Secretary General. And thank you for giving me this opportunity by the Indian Public Health Association. I knew earlier one of your members, Dr. P.K. Mukhopadhyaya, if you remember. I've been to his house also. Be that as may, I said, this is a great opportunity given by the president of the 2021 conference, Dr. Gautam Rai, Dr. Sitanshu Kaur, the secretary, and Dr. Prem Rajan, the chief of scientific sessions. This has given me an opportunity to say hello to my good friends, JP Munian. I wonder if he's here or not. If he is, say hi to JP. And then to Sundaraman. Sundaraman, as you would know, was an alumnus of JIPMER, both MBBS, and then he did MD. And it's so nice to see that Sundaraman has risen to such high levels. I remember as a student, we invited him to participate in one of the workshops where we were discussing what should be the percentage of marks for internal assessment. And Sundaraman was one of the student representatives. So I fondly remember all these things. And once again, thank you, Gautam, Sitanshu, and Prem, for giving me this opportunity. Pardon me if I call you people by Gautam and Sitanshu, because I can't help. If I say doctor and all that, I feel very odd about it. Now, the key words of my oration was just spoken by a very, very charming person in the previous panel. I don't know her name, but her face is so wonderful, so beautiful, charming lady. She used one word, doing differently. And she used another word, cannibalism. But my talk is about doing differently. Certain cannibalism took place, but I didn't mention there in my talk. But my talk is about doing differently at the end. Now, we'll start the oration, but I request the organizers, the chair and the co-chair, would you please at the end of my oration, give me about 5 minutes to sort of conclude whatever I said. Now, I think the oration could start. If Stuti is there, please start the
Yes, sir. We'll begin now. Thank you so much.
Stuti, you can.
Yes, sir.
You must be wondering, how do I know her and all that? This is the problem of old teachers.
So can we have the video, please?
Good morning. Let me start. With let me start with Guru Vandana. The centerpiece candle has been deliberately composed there when I prepared the slide. If time permits, I'll explain why I did that. The oration, as you would know, is named after Dr. B.C. Dasgupta, and it's a privilege for me to deliver this. And here is a brief sketch of Dr. Dasgupta. Important thing to note is he was a physician of repute but joined public health service, and he was a member of the board committee, besides being founder president and founder editor of Indian Public Health Association. Since we had a session just before this, let me, as if to break the ice, start with this quiz. Can you identify this planet? This is Venus, and a crater in this Venus is named after an Indian doctor. Surprising, isn't it? And who is the doctor? If you can identify this person, I'll stand a lunch for you at Bangalore, a vegetarian, sumptuous, tasty lunch. 15 seconds. She's Anandibai Joshi, the first ever Indian woman doctor who went all alone to United States of America, joined a women's medical college at Pennsylvania in spite of several constraints and difficulties, and completed her MD. She returned to India, but within a year, she passed away because of malnutrition, 6 months of travel in the ship without sufficient and proper food, and she also developed tuberculosis. This is a tombstone one of our friends installed in New York. The ashes were sent there. She was a pioneer, bold doctor with steadfast determination, and she must be a role model for all of us to pursue and do what we want to. If you want to learn more about this person and 5 more such lady doctors, please read this book by Kavita Rao, recently published. I would like to remember and thank these persons who are part of the CHIPMER and Preventive and Social Medicine Department. Dr. Bisht was the director of CHIPMER. Dr. Datta was the founder, professor of Preventive and Social Medicine at CHIPMER, established the department and very good rural and urban health centers. And Dr. Anand succeeded him and brought the department the national map and international map. I must remember the contribution of Dr. Bansal, Dr. Dhanabalan and Narayan, particularly Narayan and Dhanabalan, who were like my right hand and left hand. The 3 doctors you find on the right hand part of the screen were the medical officers at our rural health center were very popular with the interns and looked after the interns training program very well. The rest were our supporting staff. This is the title of my presentation. This title is incomplete. I have purposely hidden part of it, which I shall expose at the end of my presentation. I quote this from the Kena Upanishad, because when I present, you will say, oh, don't I know this? Yes, of course, but maybe there is certain things we may not know as well. And what to expect out of this presentation? I have classified into two. First, my own expectation of my presentation is that at the end, you might consider me a very disloyal person. Absolutely no loyalty at all to the department which made my life. You also may feel that I am a cynic, a senile person, and you might become angry, disappointed. I will be very happy if you're angry with me and hate me, because the persons who are hated are often remembered. And I want, therefore, you will remember my presentation and think about it. The second part is that regarding medical education, I'll start with the past and then how the past has influenced the present, and I make some hypotheses about the present development, and I make two suggestions. Most important, can we think differently from what has happened? Start with the 19th century. 3 medical colleges were established by the British, following the British education system. There are 2 students who joined Calcutta Medical College at the beginning. But I moved to 20th century. A very, very important development that took place was the recommendations made by the Board Committee. And amongst the recommendations, these 3 were very interesting. They suggested that students should learn by themselves, that is self-study, and they should develop higher cognitive abilities and also encourage research. The numbers you see on the right and top is the number of medical colleges at that time. The Board Committee also recommended 3 very important issues. One was establishment of primary health centers, then establishment of preventive and social medicine department. The term preventive and social medicine for the first time came into existence here in India. I looked at the web. There's no other place where preventive and social medicine is associated with medical colleges, particularly in the 1940s. They also suggested internship. And the development was establishment of the first private medical college by an entrepreneur, Dr. T.A. Pai, at Manipal. It has become a huge university now. Then in 60s, an important development was the commission of Mudaliar Committee to find out what progress was made between the Board Committee recommendation and the 60s. Of course, they laid down some norms, but more importantly was they reinforced the earlier recommendation that, yes, there is need for establishment of PNSM department. They should have full-time teachers, and PSM should be taught throughout in the MBBS course, there should be a separate examination in PSM. You know, the exams varied in certain places, certain universities, which was in the final year. I remember in 1970s, I came to St. John's Medical College to conduct an examination in PSM in the first year itself. Well, the other recommendation was integrating with other departments. I want you to find out how well it was integrated. The next recommendation made in the 60s was by this committee. Amongst the recommendations important was that the duration of MBBS was reduced by 6 months, 4.5 years plus 1 year internship. And in that 1 year internship, 3 months should be posted in the rural areas. And look at the next one, very interesting and important. The 3 PH primary health centers should be attached to each medical college. So 3 months mandatory rural posting and 3 PHCs. All of this are to be managed by P&SM department. Then came Srivastava committee. Again, this committee was appointed to find out and recommend on medical education and other health manpower development. But their observations on medical education, they said whatever changes or improvements have taken place is very disappointing, very tardy. It's and the number you see is here on the right-hand side is the number of medical colleges at that time. Srivastava committee also made certain other recommendations that the medical education should be suited to cultural patterns of each area. Notice if there is an all India admission, this may not be easy. And students have to develop qualities and interests so that they effectively serve community. They develop managerial skills, they develop innovative and improvement. All this to be done by whom? By the P&SM department during their teaching from first year to final year or during RSC posting. The next was very interesting. Can you identify this person? A well-known fighter. I stand breakfast at Bangalore, if you recognize this. He was Sri Raj Narayan, the Minister for Health and Family Welfare, so well known for bringing down Indira Gandhi by filing a case against her election practices, and he won the case, and that's how immediately after the emergency, the Janata Party came into existence. And the reorientation program was started by him in this way, that in the medical colleges should have 3 mobile vans attached to each of the medical college. How it happened was that he wanted to improve the health service in India. And a very smart IAS officer, the health secretary then, who was himself had a doctoral degree from Harvard, took him around UK to show the National Health Service. And during the visit, he was also taken on to a Bedford company which used to manufacture trucks and buses. And they had a prototype, huge mobile van, a hospital on wheels. And he was very impressed by looking at it because it was air conditioned. It had an operation, a small operation table, lights and instruments for ophthalmic examination, ENT examination, gynecological examination and all. So Mr. Raj Narayan was so impressed that he said, look, isko bhej do. Then the 106 colleges then were to have 3 mobile vans, and PSM department has to organize rural camps utilizing them. So he ordered 318 mobile vans. With all these recommendations, including the MCI, Medical Council of India recommendation in 1997, when they revised the curriculum of the MBBS, the doctors recommended were of these types. Board committee said social physician, Mudaliar, and Medical Education Commission, basic doctor. Ramalinga Swami was director, AIMS, and Director General of ICMR, a pluripotent doctor, a social biologist. WHO said 5-star doctor, and MCI said physician of first contact. Wonderful. Now let me see to what extent we were able to achieve this. So, but before that, in 2019, the National Medical Commission recommended competency-based curriculum. And they said the doctor, the Indian medical graduate, IMG, should play these 5 roles. Now my next part is, I call it reflections, and find all these recommendations. How did we work on these recommendations? And based on the reflections, I would make certain hypotheses. First was understanding the terms. The board committee said preventive and social medicine. Sometime later, many departments called themselves as community medicine. Christian Medical College Vellore and St. John's called it community health. And some people also called it public health. And very often I get into problem and people ask me, what specialty do you practice, doctor? I say, I'll say preventive and social medicine. They'll say, what is that? Then I say community medicine. They say, what is that? So there is some problem. Let's go to definitions to understand more. And I quote Park and Park definition of what is preventive medicine. And because Park and Park is most often referred by undergraduate students, even postgrad students. It's a very popular book, as you know. It says apply to healthy people, but it is distinct from public health. And then the definition by Park and Park on social medicine is fairly simple. It's social sciences, anthropology, and social psychology. Find out social causes. The combination of these two is PSM or community medicine. However, the definition of preventive medicine as defined by the American College of Preventive Medicine is interesting. It was a lengthy one, so I split it into part 1. And it is, notice here, it is practice of prevention in clinical settings. Whereas this does not come at all. It's healthy people in park. And it's about biostats, epidemiology, and more of administration, isn't it? Planning, evaluation of health service, management of healthcare, and so on, research. The part 2 is about social sciences, social behavioral sciences. But in part 2 also, I split into 2 parts purposely. Look at the 2.2, the second part of part 2. It is to improve the health quality, etc., populations through disease prevention and health promotion. So that means it's applicable to groups of people, populations. So isn't it, is this not public health? And here preventive medicine includes social health. Park says preventive medicine is distinct from public health. So it's for you to decide. Let's therefore look at what is the definition of public health. There's well-known definition by Winslow that it is science and art of preventing disease, prolonging life, etc., through organized efforts, again, to large communities. Similarly, the WHO definition is very similar. So it's large population, preventing disease, etc. So I somehow don't feel any different from the definition of preventive medicine, because both are preventing disease, prolonged life, promoting health, etc. So then I came across a paper published in 2001 by Thakur. Thakur was a professor at St. G.S. Medical College, Mumbai. He said, look, they're all synonymous terms. So there goes, settles some problem, which I had, I suppose. However, now impressions about this subject, I quote Acheson. Most people know what public health is, but the appearance of social medicine caused confusion. He also says that adding community medicine adds more confusion. This was from an oration he gave when Cambridge University completed 100 years. So it's not an offhand remark. Now let's go to course contents, otherwise the syllabus, what we teach in community medicine from first year to final year to change their attitudes and qualities. I've also included in this the latest National Medical Commission's competency-based curriculum in community medicine. And they define 20 competencies. These 20 competencies lead to 107 outcomes. But look, only 10 skills. It's very funny. A glimpse of what is taught is shown here. You will notice that I have not arranged in serial order deliberately. The numbers, the serial numbers you notice is the competence given in the competency-based curriculum of the NMC. But I have rearranged with a specific reason that all these purple colored are, I feel, must know and must do, whereas the black ones are more of administrative. The other ones are more of clinically oriented. Further, I give few examples of the competencies defined as outcomes by the NMC latest curriculum. In epidemiology, I notice that one of the outcomes is enumerate and evaluate the need for screening test. Mark the word enumerate and evaluate, whereas the outcome, they say, is a skill. The action verb is enumeration. Enumeration is not a skill, it's more of a cognitive domain. The next one is describe and demonstrate applications of computers in epidemiology. Of all the things, I don't know why P&SM should teach computers, and that too application epidemiology. Computers can be applied for all subjects and in so many ways too, but then PSM is the home for it. And the term used is demonstrate, but the assessment is through written and viva. So there is some disharmony between the words used and the type of assessment, although this is competency based. The next is very interesting. Describe warning signals of mental health disorders. Warning signals. I wonder even psychiatrists have difficulty in that. But then PSM people are supposed to teach this, although they have very little training in psychiatry or psychology. Then occupational health. I found somehow the sentence a little odd. Enumerate disease, enumerate and describe presenting features of patients with occupational health, whereas preventive medicine defined by Park is of healthy people. Anyway, the next part was I listed these 10 skills, the outcomes described by the competency-based curriculum. The first one, concept of health and disease, is to be demonstrated through simulated communication of doctor-patient relationship. I want to ask, the doctor-patient relationship can easily be demonstrated and explained and trained by clinicians because they come more often in contact with patients. I don't know why it should be by the PNSM department, whose contact with patients is rather limited. Similarly, environmental health problems. Identifying vectors of public health importance is a skill. And principles of health promotion and education. Demonstrate health promotion and education. I wonder how we can demonstrate health promotion. Anyway, similarly, I have listed other skills, the 10 skills. Notice this biostatistics sampling collection of data is shown as a skill, whereas I think it's an analysis and cognitive process. I leave it to you to see whether these are really, many of these are not skills at all. What the students felt about the subject, it's very interesting. Look at this picture drawn. Look at the eyes of the student, so anxious, so many syringes are being. A student said, disjointed teaching of different subjects and has been shown very well in this picture. One student said, "Ma'am, aap अच्छे बोलते हैं, but करते कुछ नहीं." It is evident. And she said also said that it's all common sense, somebody said. The teaching learning methods used is mostly didactic and that sense at most academic, virtually isolated from service. Of course, you might say, look, no, we send them to rural center, we send them to families, etc. And based on all this teaching, we are supposed to, shall I say, produce this or these types of doctors. I leave it to you whether we achieve this or not. And the type of doctor we got at the end is this far removed from the community. So that was the main goal. And bound by books and medicines and so on and so forth. Then look at the way he's looking at the community. It's very interesting, beautifully drawn. Why did it happen? Though the recommendations of the committees were so laudable that India needs rural doctors, India needs improvement of rural health services. But I feel that the recommendation is more emotional and they're not evidence-based. No other country had tried this. There was no pilots done. And simply medical colleges were asked to take 3 PHCs and mobile vans were given, so on and so forth. The colleges were unprepared. Capacity of PSM department was overestimated. Further, Srivastava committee made very scathing criticism of PSM department. I leave it to see whether such criticism was justified or not. They said the department lacks scholarly foundation, not the department, I mean the staff. The training is irrelevant to community health needs. Field practice areas are not adequate. There is no significant success. And the next is about the mobile vans. Again, simply 3 mobile vans were sent to the medical colleges with again very little preparation. Nobody thought of its deployment, particularly in the rural areas where roads are narrow or not even existing. And the maintenance of these huge vehicles was not easy. To run a camp, to use this van as a hospital, you needed power supply regularly. We all know that power supply is very much interrupted in the rural areas. And who will bear the cost of this power? The safety of the vehicle. And if we had a camp for 1 week, the driver has to stay there. Who will look after the driver's food, place, and so on? And Canton department managed 3 mobile vans simultaneously. There's hardly any support from other departments. So people called it white elephants. People called it their PSM baby. They made fun that Rome has become Rome. And there were many audit objections. At JIPMER, we ran these mobile vans. We conducted 125 camps. And because the department, in a meeting of the college council, proposed that, after all, the mobile vans will be mobile hospitals, and therefore it's part of the hospital care. And the hospital should be in charge of deploying people, supplying medicines, so on and so forth. Only the logistics will be taken care of by the Department of PNSM, and that was agreed. So we were able to conduct 125 camps. The Oxfam and British Council highly appreciated, but that's not the issue. The issue is very interesting, the audit objection. There were only few colleges which were able to run this. The audit objection I had to answer was, the audit said there should have been 1,460 trips in a year, and only 10 trips have been made. So there is gross underutilization and waste of public money, although there were 3 mobile vans. So I sat with the audit and told them, sir, the arithmetic is wrong. 3 mobile vans into 365 days will not work out to 1,460. It will have the 4 vans, and we had only 3. And this is not a public bus service where you run every day. You got to arrange camps, and clinicians have to be deputed, and so on and so forth. But this was the way it was functioned. And my next hypothesis is about attachment of 3 PhDs. It should have been 4. I mean, the hypothesis. Even after 60 years, state governments are unprepared to hand over PhDs to private or government colleges. There is no clear understanding who will supervise, whether the staff of the government primary health centers will listen to the orders made by the community medicine department of medical college, whether government or private. And can medical colleges take this additional burden of administering, supervising 3 primary health centers? What's the role of the Department of PSM in this, when the government is not even handing over? My next hypothesis about posting of interns mandatorily 3 months in the rural areas. First, let's look at the numbers. When the Boer and Mudaliar Committee recommended this, not Boer, I mean Mudaliar Committee or later Medical Education Commission, the admission ranged from 50, 60 to 100 maximum. But now the admission goes on to 150 to 250. So a mere arithmetic. 3 months of posting means 1/4. 1/4 of 250 will be about 60 and more. And if you have one rural health center, how can you train 60 interns at a time? And how can you engage them when they are more concerned about NEET examination? Another issue is the medical officers. They have no teaching designation. They are administered by somebody else, that is by the state government. The medical college is administered by either private or there's a different administration. And they are not trained in teaching techniques, etc. And many other issues, hostels, cook, safety, and so on. The next hypothesis is about the course contents of the syllabus. Look at this syllabus again. And I feel that most of these topics can easily be taught by different departments concerned, subject specialties. I'll show you how. Here is an example. For instance, competency A7 and 8, that is communicable diseases, epidemiology of communicable diseases. Surely microbiology, medicine, pediatrics can teach, depending upon different communicable diseases. Similarly, non-communicable diseases, diabetes can be taught by medicine, surgery, pediatrics, surgical aspects of diabetes, and so on. Cardiovascular disease, surely cardiology, medicine, surgical aspects, cardiovascular surgery. If there is stroke, neurology, pathology, about the block and other things. Cancers, depending upon the cancer, which cancer breast, cancer cervix, different departments can be taught. And the treatment, radiotherapy, medical oncology, etc. Nutrition, easily physiology can talk about the normal requirements, biochemistry also, and pediatrics about malnutrition, nutrition amongst children, and obsgyne about women's health, particularly nutrition during pregnancy and so on. And the idea is that, you see, these patients come in contact with these departments, not so much as with community medicine. Similarly, here I have drawn about other. I'm sorry, I went back. The other competencies and the departments. My next hypothesis and the final one is the recommendations were more than 5 decades old. It's time for us to see whether they're feasible in the changing circumstances, the changing aspirations, trends, even the policies of government has changed, private, public, and so on. And therefore, there is time to relook entire thing. My third part of presentation is what should be the future of medical education, how to bring change. There are 4 ways to bring change. One is MOTS, that is more of the same, continue, it is going on very well as it has been, it has gone on well for the last 70 years. Why not? Why change? Let it go on. That could be one. The second is, can you guess this? Old wine in a new bottle, make some cosmetic changes here and there, and say here is new, or at least dream for a change, or bring revolutionary changes. I think the revolutionary changes are very difficult in a democratic country like this, because you do something, then they go to the court. As now the court decides when students should be admitted, when examination should be conducted, what type of examination should be conducted, and so on. My dream of future, therefore, is this, that there is no need to have a separate PSM subject. What is being taught by present PSM subjects for undergraduate courses in the MBBS can easily be taught by others. And the change, if it has to be brought, it has to be a coordinated, combined effort, not by one particular department. The unity brings strength. That is one, dream one. I have another, I quote in the long frame, when hit only what the aim, and that should be our aim. Therefore, my title of this presentation is Future of UG Medical Education in India, Sans PSM, a radical view. If I had projected this in the beginning, then Gautam Roy and Sudhanshu Kar would not have allowed me to present it once. Therefore, I'm presenting it now. I have one more dream, and that is to have a new type of medical college. That is, and here is the horoscope for future medical college and medical education. The future medical college will have, again, primary health care and universal health oriented. It's also health system oriented. And there will be only a few departments: a department of biomedical sciences, department of healthcare, department of clinical and communication skills and therapeutic management, department of human values and ethics, which does not exist now, and department of performance assessment and enhancement. We need to assess the performance, and our aim should be to enhance the performance. What are the areas to stress in the teaching? Tuberculosis, malaria, vector-borne diseases, diarrheal diseases, emerging diseases. These should be the focus. Again, important non-communicable diseases, because they are, they say, diabetes and cardiac diseases are quite common in India. So also road traffic accidents. More than 1.5 lakh people die of road accidents in India. Then maternal care and health, child health, and research. And if you think there is any other, you can add on that. This is my dream of future. A medical colleges of 28 or 30 departments, have few departments, coordinated teaching programs. Thank you.
So thank you so much. Now the chairpersons, please.
So any final words, any final note on this talk, sir?
By me?
Yes, sir.
Okay, yeah. Well, thank you. Of course, some people may say that, why did I not say this before? Did I not have courage? I did have courage. I did mention at a couple of meetings, but none took me seriously. Even now, I may not be taken seriously, but no one has reflected. And maybe there is time now to reflect. As in the previous session, when that lady was summarizing, she said doing differently. I think it's time now to do differently. And please think over that. Maybe we should have a lot of debates and question ourselves. Are we doing well? Should we continue what we are doing? This is all I wanted to say. But look, hospital waste management is to be taught by preventive and social medicine. Why? We have never questioned this. At Rajiv Gandhi University, I questioned it. I said, look, hospital waste is not produced by the preventive medicine. It is produced by all the departments. Bio-waste is produced by all departments, starting from anatomy. And I discussed this. I went to each department and showed what waste they generate. And therefore, they should be responsible to teach our students. And Rajiv Gandhi University accepted it. Similarly, about gender issues and ethics and several others. So somebody has to stand up and say, look, this is like a cricket team. One person cannot win the game, and everybody should combine together and develop. If you want a rural doctor, I don't think one department may convert by 3 months posting a young student to a saint. This is all I want to say. Once again, thank you very much for giving me this opportunity. Someone identified Raj Narayan. I stand by my words. Please do contact and we'll have a good breakfast here at Bangalore. Thank you very much, Dr. Gautam, Dr. Rai, Dr. Sitanshu and Prem for giving me this opportunity. If you have any questions or queries, you can always contact me by mail. Thank you. Not WhatsApp, by mail. Thank you. Thank you, Sitanshu.
Thank you so much, sir. You've given us a lot of food for thought. Now,
I must, one second. I must thank Stuti and Anurag, because this was recorded after 11 o'clock in the night, and that was a long day for me. And this was the third. I had made 2 rehearsals and third one. So you might have noticed my voice and so on. I hope you will excuse me for this, notwithstanding my age too. Thank you once again, Stuti, and all the CHIPMA and the IPHA for giving me this opportunity. The President, sir, and the Secretary General. Thank you.
Thank you, sir. Thank you so much. It was a pleasure interacting with you. Now, ordinarily, we would have now presented the memento to you, but Dr. Gautam Roy has assured us that it will be delivered to you in person.
Yes.
So I now request, yes, sir. So I now request Dr. Gautam. Yes, sir, definitely.
Yes.
So I now request Dr. Gautam Roy to close the session for today.
Thank you.
Dr. Gautam, sir, you are on mute, sir, and we're not able to see the video.
Video, please. Yeah. Can you see me now? Okay. Thank you, Dr. Stuti, and thank you everyone for listening. To someone I always say, you should always listen and see how Dr. Srinivas takes classes, how he speaks. And of course, it was a very difficult subject, the topic which he spoke on. And yes, finally, it ended with a question, whether PSM. No, PSM cannot be withered, but then, of course, it needs to be channelized somewhere else. But thank you so much, sir. I'm seeing you live. It was a pleasure.
Just 1 second, Tripti. Stuti, 1 second. 1 second. Sorry for interruption. 1 second. This I'm not talking about the postgraduate. Postgraduate courses should go on. This is only restricted to undergraduate courses, please. Let me clarify that.
Okay. Hey, thank you so much, sir, and thank you everyone for being with us. Thank you. Sir, I'll be coming to your house and giving you these things in person.
Come for a lunch. Come for lunch.
Thank you so much. I knew you would say that.
Yes. Thank you. Thank you.
Thank you. Thank you so much, sir. So now we move on to the second plenary. we thank the chairperson for the oration session of Dr. Bishidas Gupta oration. Now I hand over the session to Dr. Sonali to take it forward. We have a wonderful plenary session awaiting us. So over to you, Dr. Sonali.
Thank you, Dr. Sitanshu, and a very good morning to all again. And I think Dr. Vasan, who is joining from a foreign country, maybe it's evening for you there, sir. So good morning and good evening to all. So we have the second day of the IPHACon 2021 started in a grand way. 2 stellar sessions already over, and we are about to start our second plenary for the day, titled Handling Subsequent Pandemics, Are We Ready? A question that has been plaguing all of us who are involved in public health since this pandemic began. So let us hear from our speakers today on what they think about this. But before that, we have 2 very senior professors in community medicine chairing this session. Dr. Sunila Garg, who is the Director Professor of Community Medicine at MAMC New Delhi. She is also the National President for IAPSM 2021. Ma'am has a vast experience of 40 years, has been a sub-dean at MAMC, and has also been the National President for OMAG, and she is an advisor for the Indian Council of Medical Research and also a member of the task force for the Department of Biotechnology, Government of India. If I could start reading out the list of her achievements, it's a long list. So to cut short, because the group actually needs no introduction to ma'am. She has multiple awards and contributions, but I just wanted to mention here that she has been a recipient of the K.N. Rao Memorial Oration of the Indian Public Health Association in 2018, and has also been awarded the Harcharan Singh Oration of IAPSM for the year 2019, and has been an author for multiple papers and also manuals for WHO. So welcome, ma'am. Thank you for agreeing to join and chair this plenary session. The other experienced chair for this session is Dr. Manmeet Kaur, who is a professor of the community medicine at School of Public Health, PGIM at Chandigarh. Ma'am has again vast experience. She has been awarded and has had a significant contribution to various associations, remarkably the Indian Association of Social Sciences and Health, Indian Association of Health Economics, International Sociology Association, Sociological Society of India. So anybody who has been interested in sociology, as social health is a very integral component of public health, as we were just now listening to Dr. D.K. Srinivasan, would be interested to know that in public health, all this organizations and associations that are relevant and we can contribute in such a wide variety of ways. So thank you both the chairs for agreeing to chair this session. Over to you, ma'am, Dr. Sunila Garg and Dr. Manmeet Kaur.
First of all, a very good morning, and thank you organizers for having this mammoth, workshop in national conference, and thank you, Dr. Sitanshu, Dr. Stuti. We are going to have indeed a very, very wonderful session, and the topic is entitled is Handling Subsequent Pandemics, Are We Ready? So this is the need of the hour. For this, we have got 4 distinguished speakers, and without wasting much time, I'd like to introduce Dr. David Allen, and he is an Associate Vice President of Health Innovation and Translation at National University of Singapore. And he's also Associate Professor of Medicine at Yonglou Lin School of Medicine at NUS. And then he's also a senior consultant in the infectious diseases at National University of Hospital at Singapore. So I believe that now he is a Associate Vice President, which I can make out. That's the late position, new positions now. And he has been awarded, fellowships, and he has been a visiting professor. Courage Fund, he has been awarded with an inaugural professor of Ontario, and he has been also a Ontario lecturer. Now, if we look at some of the important publications, he has published on design and multi-center clinical validation of 3-dimensionally printed nasopharyngeal swab SARS-CoV-2, then testing with the strategy with regard with Joshua and all that, with those people. And also he has worked on, let me say, airborne SARS-CoV-2 surveillance in the hospital environment using high flow rate air samplers and its comparison of surface sampling, which has been published in Indoor Air also. So that is one thing which is, he's got a lot of, I think, experience and credentials to his designation and a lot of papers and all that. And what he'll be speaking on is going to talk on COVID-19 public health response in Singapore. So without wasting much time, can we have talk from Dr. David Allen? Because we all know that we have passed through, it's almost, I'll say from March to now this year, we are still in the midst of pandemic. It has not gone out of our lives. But you see, after handling this pandemic, are we, can we say with confidence, is our systems preparedness there for handling the next pandemic? There are many, many challenges because India itself has seen 196% increase in number of cases when we started from 10th March. So that is where, so we have to talk about, based on our experience, whether we are talking about the systems preparedness, manpower preparedness, or our logistic preparedness, morally, or, in terms of, our mental preparedness is there or not. So these all things are very critical issues which will be discussed in the session. So can we have first, Dr. David Allen for presenting his paper.
Good evening, and let me begin by thanking the organizing committee for inviting me to speak to the 65th annual National Conference of the Indian Public Health Association. It's my honor to be here. I've got my challenge is to present our experience in Singapore, what we've learned, and how we're going to move forward in the next few minutes. So let me quickly begin by sharing my screen and get to the topic at hand. Here we go. All of us were led to believe that we had metrics that allowed us to determine how pandemic preparedness would work. And you can see over on the right, the table that shows a ranking of countries that were thought to be best prepared and those least prepared. And you can see how that didn't really work out very well. So having a pandemic preparedness plan, at least as it was envisioned pre-COVID-19, didn't necessarily protect you from suffering significantly from the pandemic. The metrics for assessment may be wrong, the way they measured it may be wrong. There's all sorts of reasons that we're obviously going to do a post-mortem on this pandemic to understand why. Part of it is that certainly is that it's been underfunded. A variety of conferences have gotten together and determined what the annual cost to provide a global pandemic preparedness would be, and it's in the order of $4.5 billion annually. In reality, this is the amount of money that was spent in 2019 for pandemic preparedness, which is less than 10% of what was proposed. And this is the estimated cost, the economic impact due to the pandemic just at the end of 2020. Now, we know there's been some recovery, but because we did not spend $4.5 billion annually, and not necessarily that it would have changed things, but we've lost $21 trillion. So clearly, we need to make improvements in pandemic preparedness. Let me speak closer to home here. Singapore is a very connected country. It's a small country, 5.7 million people, of which 1.23 million of that 5.7 are foreign workers. We have an airport that connects us to the rest of the world. So when someone sneezes in the Amazon, Singapore catches a cold the next day. We have to be prepared with what's going on everywhere in the world at any time because it'll end up here very, very quickly. Our pandemic preparedness since 2003 has been influenced by SARS. It hit here quite hard. It killed healthcare workers as well as those in the community. And as a consequence, a program came up to develop a whole of government approach with expanded capacity and quarantine isolation and basic research, as well as public health. a lot of war game exercises, none of which anticipated the capitulation of the Communicable Disease Center in the United States and the actions of the president there, and so that they were incomplete exercises despite our best efforts to think of all possibilities. We worked on supply management change and stockpiling after SARS, so that has stood us in good stead. There's been ongoing public education as to the risk to the community without frightening people, and there's ongoing medical education and drills for healthcare workers. More specifically for COVID-19, we've had comprehensive surveillance, aggressive containment, effective prevention, and forward-looking leadership, which has allowed us to act in a relatively comprehensive and integrated way. And you can see some of these, which I'll speak of in the next few slides, but not all of them. I don't have time. I'll pick out some of the more relevant ones. One is the whole of government approach. By that, I mean there was a multi-ministry task force that formed the day the first patient with COVID was identified in Singapore in January of last year, run by ministers and with representation from all the other ministries as well. This continues to this day, excuse me, and it directs the national outbreak response and continues to engage the community and the international community to assure that our response is understood and carried out in a comprehensive way. We expanded infrastructure after SARS and reinforced by in 2009 H1N1 to ensure sufficient capacity utilization of non-government facilities as well, and to unload hospitals to decrease the burden by canceling elective procedures and other modalities to try to decrease the workload there so they can handle the isolation patients. Triage for patients who were well that needed isolation, but not to home. They had to go to an isolation facility up until just the last couple of weeks. In September, we began piloting programs to isolate at home, which I know have been around and available in India and the United States and Europe, but we've been a little more hesitant to do so until recently. And we invested $10 billion several years ago and continue to invest in expanding our basic research, our diagnostic development capabilities, expanded facilities for doing basic research, and hired faculty to do so and developed faculty from within. So this is some infrastructure that's improved. It's National Center for Infectious Disease. It's a beautiful facility, opened in 2019, just before we had monkeypox, and then obviously before SARS-CoV-2. It's got 330 isolation beds, but it can expand to over 600 at this point. And it's doesn't take the majority of the patients with COVID, but certainly helps lead the charge. We've got other facilities, obviously, in the island. It is a small island, but we've got 19 public hospitals and 8 private, over 10,000 hospital beds, and we can expand over 2,000 negative pressure rooms. We've not had, to date, we've not had that many SARS-CoV-2 infected patients requiring negative pressure rooms at this point, but we know that we have that capacity. Additionally, we've got greater than 90 clinical infectious disease physicians, and also we have obviously microbiologists, public health folks, epidemiologists, et cetera. Another important arm of our approach has been public communications. There's an official WhatsApp channel that updates people twice a day as to the number of cases, ICU cases, et cetera. It also advises businesses and workplace what the measures are, reinforces social distancing, and we also have a law passed, an act, to counter misinformation, particularly in social media, to try to make sure that we're doing evidence-based and science-based education of the community and not fear-mongering. There's ways for contact tracing that utilizing technology. We have apps and dongles which are used when you enter any facility outside your home, and then when you leave to know how long you've been there, who you may have interacted with. It's been very, very helpful with contact tracing. We ensure quarantine compliance by monitoring people, spot checks with video calls and home visits. There are fines and potential incarceration should you choose not to follow quarantine orders, which can be at home, unlike isolation, which cannot, or was not able to be at home until recently. And if someone is prosecuted, it is publicly announced to discourage others from doing so. There's also been financial support from the government for those self-employed to help. We've been heavily involved in education. I've been involved in a program called COVID-19 Updates from Singapore. Initially weekly 24 episodes with lots of people from around the world chatting about their experience and what is known and not known. Subsequently, we've done it monthly for the last 10, 11 months, again with the same format. Very informative both for policymakers, for public health folks, for healthcare workers in the community. It's been very well received, and we continue to do it. There's also other ways with cartoons and any way we can communicate with people. So we've done all these great things, and it sounds wonderful, this preparation, these measures, but what has been the result? Well, I am speaking to public health officials, so we've got epidemic curves. The top one is the total epidemic curve, and then we have split curves down below. There's 3 of them, and I'll just touch on some of the points. Well, initial cases were from folks visiting from China that transmitted locally to a few people in the community. These were in single digits or low double digits. Everything was activated at that time. All the sirens were set off, and we were well on our way to quickly being on the lookout, knowing full well how vulnerable we are based on our central location, travel, the number of Singaporeans working overseas and returning, et cetera. Well, that was squashed. And then we had folks, Singaporeans, as the situation began to heat up elsewhere around the world, we encouraged Singaporeans to return home. Well, they were asymptomatic, and this was at a time that it was not known that asymptomatic transmission was a significant issue. And so sadly, we did not quarantine them, and we transmitted to the community. We realized what was going on, took care of that, and quashed that little peak as well. However, our brothers and sisters in the dormitories, you can see on the 3rd row down, the 3rd split epidemic down here where the laser pointer is, the virus got into the dormitory workers where they live, which are generally these are young men living in dorms, and there are several to a room, and it spread like wildfire. We were able to get that under control using what we called a circuit breaker, which is, for all practical purposes, a lockdown, and this worked to control the outbreak in those communities. Seemed to have everything under control. We were continuing to bring back relatives of Singaporeans, et cetera, kept them in quarantine at this point and prevented transmission. You can see no cases in the community, just in these people coming back. They were kept in quarantine and found there. Wasn't much of a problem until somewhere around in here, where we had a few people who developed SARS-CoV-2 after the quarantine period and managed, sadly, to transmit it into the community. And then this was Delta, obviously, at this time. And you can see that cases have run apace. So this is our current situation. Just looking at the center dashboard, you can see we've had, as of, I believe this is today, 71,167 cases with 58 deaths, 7 in the ICU, 700 in the general ward. Active cases, most of these people are either in isolation facilities or at home and being monitored and not allowed out until they meet our criteria for release into the community, which we feel makes extremely unlikely that they'll transmit. Our case fatality rate has been good, and I would say that one of the reasons why it's been so good has been the majority of the cases up to this point have been were many young men in the dormitories who are young, healthy, men without comorbidities. Very few of them fell ill, and as a consequence, the denominator is overwhelmed by these young fellows, and as a consequence, the case fatality rate is low. So what is our current thinking? Well, we've moved from zero tolerance to figuring out how to live with the virus. We We tried zero tolerance. It is in the long term unsustainable. Those countries who are continuing to take that approach, we wish them well. But our goal is to protect the hospitals and the healthcare workers. So we vaccinate and screen everybody, and we've got a very high vaccine uptake rate. We hospitalize only when clinically indicated now, and we're selectively isolating at home. Otherwise, if you're positive and we can't safely isolate you at home, then we still use isolation facilities to assure the community is safe. We limit people coming to the hospital, and we use split care teams still. So what is our assessment? On the bright side, we've got 81% of the population who's had full dose of vaccine, and we've started the booster program. Our successful screening and early stratification really prevented the healthcare system from being overwhelmed. We took the approach of taking the mindset of SARS, not SARS-CoV-2, but SARS, and moving toward and relaxing from there. Other countries took the approach, this is influenza, and escalated their measures from there. We started off very, very conservative and de-escalated. Others started off less conservative and escalated. Our fatality rate is mentioned. We have expanded our capacity, obviously, with isolation, et cetera, and we are self-reliant with regard to PPEs and diagnostics, which has been encouraging. Also, while these are good things, we've got some looming obstacles. There's pandemic fatigue, which every country is suffering from one degree or another, and everybody in the economy is suffering. Increasing numbers of elderly becoming ill in the current wave, despite our efforts to get them vaccinated. Not everybody is vaccinated, particularly in the elderly age group. And so we're going to see more morbidity and more mortality. We are aware of that. And the obstacle of boosters. Well, we've decided we've got a fairly large immunocompromised population due to transplantation, chemotherapy, et cetera. They certainly are getting a third dose. Those greater than 60 are getting a third dose, but we've not opened it up to anyone else at this point. We know that vaccines aren't the answer. With social distancing is still needed. It's just getting people to continue that. In Singapore is probably easier than it is in some countries in the West, but it's still, people get tired of it. So what have we learned from the pandemic? Well, we've learned that earnest, focused, and well-funded pandemic preparation can mitigate, but it won't prevent. We've built in flexibility, so our staffing and facilities, so we're able to move wards and buildings and everything very quickly within hours and get it to the point where we can use it for our pandemic overflow. We know that being honest with the population is very important, trying to get them to buy into the measures that we're recommending. It's fact-based, evidence-based, it's honest, it's regular. We admit when things didn't go as we anticipated. We do not say anything is written in stone because we are going to monitor, interpret, and respond quickly and decisively and reassess as we go. And it's been an educational experience for all of us. And I thank you for your time and attention. Have a good evening.
Thank you, Dr. David, for a very, very lucid talk. And you really started with, this has been, this has had, and pandemic has had an economic impact of $21 trillion. And also you directly mentioned about, upfront approach of the government. That was one thing which is very, very important. And all throughout you mentioned about, evidence-based science. And, there was and also involving the communities at all levels and having the data transparent as well. So that is another thing which is very, very important in preparedness of the pandemic, including a state-of-art infectious disease hospital. I'm really, thankful that you shared all those experiences with us. But I like that basically pandemic preparedness mitigates, but it cannot prevent. If there's going to be pandemic, it's only, we are going to respond with the help of systems preparedness, which we have already done during this time. And also we need to keep prepared, at the times to come. And we must have a built-in flexibility. And more important is that we must respond very, very quickly also. So these are some of the key points. And I'm sure that, with your pace of vaccination, 81%, we have got a couple of things also in our mind. You raised an issue of boosters, whether we need to look at the primary course of vaccine itself rather than making it from 2 doses to 3 doses, or we talk about the 2 doses and a booster, or we need to talk about fractional doses. These are some of the important issues, I think, which will be there. And when the session is over, we'll take up the question answers next time, after that, after the 4 speakers are spent. So our next speaker is Professor S.S. Vasan. He is COVID-19 project leader and CSIRO in the Austria Science Agency, and he's an honorary professor at University of York, UK. And I have also got the honor of working with the University of York with Dr. Kamran Siddiqui, and we are working on smokeless tobacco. And he has an experience of 25 years across Australia, India, Malaysia, UK, and US. So you bring with you, Dr. Vasan, vast experience, of working in different setups also, and including Southeast Asian region. And then you have been conferred with several personal awards like National Scholarship 1996, Indian Institute of Science, and Rhodes Scholarship 1998, Trinity College, Oxford. And your team achievements have been, your Research Council's UK Impact Award has been given for Ebola response, very, very crucial award. And I'll say a very prestigious award and responding to a situation of Ebola. Then British Experience International Healthcare Award for Ebola and Zika response, and CSIRO Chairman Medal 2020 for preclinical evaluation of Oxford, Zeneca, and Innovivo vaccines for CPI. And then his team grew the first SARS coronavirus 2 stock outside China and showed that ferrets are susceptible, number 1. So this is one of the very, very important observations. And then the Oxford vaccine is more protective intranasally. So let's see, and we are waiting for that. And then, G614G mutation will not affect vaccines. And then India's Mindvax worm vaccine is promising against all the 4 variants of concern. I can see only till this much, and systems biology and vaccine learning can strengthen ex vivo and in vivo and human studies. So with this, we will have the pleasure of listening to Dr. Vasan. And Dr. Vasan, the floor is yours for sharing the important things about, we are going to talk about One Health, high containment laboratories, identification to action based on recent public health emergency. So this is one thing which is very, very important, and we need to, and first, I'm very happy that you talked about One Health. That is something crucial which the world has to understand, and we need to talk with this topic in our mind, that we are focusing on One Health, and we need to look at from the one world or one growth perspective as well. So the floor is yours, Dr. Vasan. Thank you so much.
Ma'am, I do not see Dr. Vasan now. Actually, there's some connectivity issues, I think, from his end. He is trying to join. He will be talking live for this session.
Yeah.
So is it possible that we go to the next speaker?
Yeah, we can go to the next speaker. Yes. Dr. Manmeet can introduce the next speaker.
Yes,
and we can go. Yeah, thank you.
Thank you so much.
Sure, I'm there. So I'm really pleased to introduce the next speaker, Dr. Anand Krishnan. I have been working with him, so that was, a very good opportunity for me to learn from him. He is professor of Center for Community Medicine, All India Institute of Medical Sciences. He is head of WHO Collaborating Center for Capacity Development on Capacity Building in Community-Based Strategies on NCTPC. He has vast experience of 30 years, that too after MD. Many awards, FIPHA, FIA PSM, FNAMC, and ICMR, along with MK Sheshadhari Award. It's a long list and has many publications, like 300, and he has impact factor of 2.5 and H index. I'm not able to read, but I invite you, sir, to make the presentation. I think everybody is waiting to listen to you. Thank you.
Hello, everybody, and welcome to this session on handling subsequent pandemics.
Hello.
I was asked to talk about defining boundaries and ruling out public health response, with the intention that I would talk more about multisectorality and its importance in pandemic response. However, when I looked at the topic of defining boundaries, I thought I will explore this concept of boundaries a bit more. So the concept of boundaries is used in social science to define a process of creating distinction between people, time, situation, places, etc. They are often seen as rigid and impermeable, with need something to span between these verticals. But boundary making is actually a continuous process, which boundaries being made and remade repeatedly. And the way people perceive these boundaries could differ from individual to individual. If you look at what are the boundaries of interest in a pandemic response, obviously we start with the man-animal ecosystem boundaries, the geographical boundaries of international or between countries, interstate, rural-urban boundaries, boundaries between private space and public space, the sectoral boundaries or within health and health with other sectors, research and information related boundaries, most interestingly on science and policy related boundaries, which all have implications for our future public health response for us to respond comprehensively. Starting with man-animal ecosystem barriers, I'm not going to take too much time on it because I'm sure others have spoken on this One Health concept, which is a multi-sectoral and interdisciplinary framework. But we need to recognize that there are many barriers to implementation which are related to boundaries, like ideological boundaries. How One Health is defined may not be clear to potential stakeholders. How it is operationally implemented with poor operational linkages between these verticals of health, environment, agriculture, or veterinary. Technical limitations of people's understanding of the need for collaboration and laboratory capacity or data handling capacity. Policy or political barriers that divide, for example, funding or other aspects of even administration between public health, veterinary, environmental, food safety, and as I said, funding constraints. All of them are barriers. But aside from this, let us look at other barriers, starting with, in a pandemic, geographical barriers are obviously of paramount importance of international boundaries. We do have international health regulations, which is a legally binding framework to deal with many of these issues. However, we recognize that during this pandemic, the whole issue of closing national borders, deciding who will enter the country, and having this sort of criteria which would vary between country to country, who can enter the country, who can leave the country. Similarly, how do we provide economic and financial assistance between these countries are of paramount importance in deciding a comprehensive response, global response to this pandemic. Other important considerations are obviously the TRIPS considerations on the drugs, vaccines availability. We know that vaccine diplomacy as well as vaccine nationalism played an important role in not promoting equity despite best efforts from WHO, and countries made these boundaries mean a lot when it came to distribution of vaccines. Similarly, also happened in the technology access pool. Also, we have to understand the limitations or boundaries of WHO and the international order in dealing with the pandemic. For example, investigations into the origin of the pandemic had serious issues because of these boundaries and international boundaries and national boundaries. If you look at national geographical boundaries, again, we saw India being a federal, having a federal structure. There were a lot of tensions between the center and the states on many of the issues related to pandemic response, both fiscal, health, as well as other aspects. And we know there is a lot of migration occurs in India from different parts of the country, largely from north to either other parts of the north or west or south. As you can see in the diagram, the major migration patterns for work is shown in the one on A, whereas B was the negative migration due to lockdown when people started moving back from their native professional place to native place, in a way also taking infection along with them and converting the increasing the chances of the pandemic spreading to the rural area. We also see that many of the states have imposed restrictions on movement of human beings and goods, and also made testing conditions of a need for an RT-PCR test or need for a vaccine for movements. So again, rather than having a combined response to the pandemic, we had a state-specific response because of a federal structure. Is that the best way to deal with in future pandemics? The answer should be no. While recognizing the federal structure, we need to have a much more comprehensive response which cuts across states. The other important boundary that was breached during pandemic, which generally we allow in a public health emergency, is that encroachment of private space because of public good. The best example in this pandemic was definition of car as a public space or a private space, with people being penalized for not wearing a mask within their car. And despite, and many people went to court, and the court ruled that in this such a scenario, even your car is a public space rather than a private space. Similarly, we had all RWAs or Resident Welfare Association making their own rules within their jurisdiction by creating a boundary, an artificial boundary where they decide what is to be done. Are these things that something we should encourage in future pandemics? Similarly, work home boundaries got disturbed for all of us. And questions related to quarantine, whether these people should be quarantined home or whether they should be quarantined into facility, are also important issues which pertain to future pandemics. Coming to the sectoral boundaries, within healthcare itself, we saw many boundaries crumble during this. We know that most of the hospitals adopted a team-based approach, which was not specialty specific. In fact, almost all doctors who were available across the board or disciplines were co-opted as a team, and they were allocated to different batches, different parts of the hospital. And the disciplinary divisions, boundaries traditionally seen was more or less redrawn when the response within the hospital was there. We also saw patient flows and acute care capacities being more efficiently managed by a closer interdisciplinary and intersectoral cooperation. There is also an issue of boundaries between private sector and public sector here, and the role of private sector and how we deal with them in a more integrated way is something that we should need to be thinking about. We also saw in this a use of combined dashboards, both private and private sector, where you could know which facilities are available, whether it is ICU or beds, which was a good way that we could cut boundaries if needed and provide information to people which is of use to them. Pandemic left no sector of life untouched, because pandemics had a whole of society impact on not just on health, and we definitely needed resources from other sectors to be shared during response. Therefore, pandemics make a very strong case for our response in a multi-sectoral way. But there are a lot of barriers for intersectoral actions, many of which we saw in the example of One Health Action, whether they're political, whether they're capacity, whether they are financial, and also lack of mechanism or operationals. So the same set of barriers keep coming up when we look at why intersectoral actions fail. Another interesting boundaries that were breached is in terms of research. And I'm showing you here two examples of research, one within a UK university where they interviewed the staff, and they found out that boundaries established to set up distinct groups and responsibilities were modified to allow a different ways of multidisciplinary working. New structures and processes were seen that brought groups that were previously worked at distance closer together. Also, a review of research in last 2 decades showed that while during MERS and SARS, there was not much move towards a multidisciplinary approach, COVID in these countries resulted in a much more wider range of research being done, transforming research networks. However, most of these research also leads to a lot of information generation, and we know that in a pandemic, we would need different data from different sources, whether it is from public health, laboratory, clinical, or social, or economic. And we need to have mechanisms that by which this information can be generated. They can be linked if we have to understand the pandemic. And if we don't do that, if we draw boundaries between these sources of data, then we are not going to fully utilize the data for decision making. Information sharing between academia and public also occurred in an unprecedented manner, where normally academia restricts itself to the journals, and those boundaries are very clearly drawn. Public hardly ever getting an insight into the journals. But in this pandemic, we saw public being exposed to host of academia related journals. And in fact, while it was a good thing, it also caused a lot of problems in understanding and responding to the pandemic. Coming to the boundaries between science and politics. Generally, we believe scientists live in ivory tower with clear-cut boundaries, and politicians do what they want in a separate or parallel universe. However, this COVID made these universes clash with each other and resulted in a messy and uneasy relationship between politics and science. However, in public health, we should know that knowledge and politics are intertwined all the time. It is neither good nor bad, but that's a fact. And unless people in public health learn this lesson, that they have to work with politicians, they have to deal with politics, and these boundaries should not exist, we will continue to have this kind of a problem. Largely, we scientists believe, when we discuss between politics and science, we believe that science is more important and politics is of a less important position. Whereas in public health, this may not necessarily be true. Scientific decisions have to be co-produced by politicians and scientists. And that's the way. For example, origin of the pandemic, is it a scientific question or is it a politic question? And can you really differentiate the science and politics of this question? If not, then you have to learn to address them together. So we also looked at how pandemic response were organized. We had in many countries like Brunei, Vietnam, Singapore, ministerial level centralized response. But we also saw in many countries, Indonesia, Laos, a decentralized task force that was more integrated, more cross-disciplinary, including public, private, societal co-governance partnership of different agencies. We should be considering such kind of more decentralized response to pandemics in future. Also remember, it is slightly easier to do multisectorality in a crisis and much more difficult to do in a routine response. However, having mechanisms in place during routine response helps us to respond to a crisis much better. So what are the way forward? I think we know what are the actions. We can easily put lots of verbs there, like co-produce, integrate, decentralize, share, collaborate. This is what we need to do. And we know the mechanisms for this, for example, use of dashboards, use of research consortiums or coalitions, a team-based approach, committees, interdisciplinary committees. And there are generally 4 broad ways that we can do this. Either we can legislate this, or we can put some fiscal measure to combine this, make this work, or we educate and orient different people and create a more enabling environment for these things to happen. All the 4 instruments are available with us. We need to decide which needs to be used for which purpose. There are enough models available, but we need to be clear that right from the way we define the problem of pandemic, it has to be defined as a multisectoral problem, not defined as a health problem. Once you define it in a more broader sense, with inclusion of all other sectors, then only you can design mechanisms and to get multi-sectoral people from all sectors as a part of your team. Then realize this by doing these things with the different stakeholders, look at what can be done, what can be achieved by consensual decision making, and monitor, and then ownership and accountability of action. And depending upon what you find, you drive a change. So these frameworks are available. We just need to do it. There are also enough examples for us to see how health systems can be integrated. Otherwise, we are going to continue to face problems of health system response to pandemics, how we can increase intersectoral coordination via organizational integration, including private sector, laboratories, Ayush. They can either be integrated organizational where different organizations or of these issues work using a single governing structure. We can make functional integration to see how these can work functionally. We can look at service integration where they all combine to provide one single service, or clinical integration where we use a standardized protocol of care, which each stakeholder having a very defined response. Ultimately, public health, environmental sustainability, and equitable development should be the frame from which politics has to be viewed. And there cannot be any scenario where four of these things do not go together. Public health, environmental sustainability, equitable development, and politics will have to go together. And world leaders and economic managers therefore need to rethink how we achieve that and not keep them as a separate entities when we look at a larger global movement of sustainable development. So it comes to the way we are going to frame economic and sustainable societal sustainability and do away with these kind of boundaries that we can really respond to the pandemic in a holistic sense. So in conclusions, there are many boundaries and almost all of them are harmful in dealing with pandemic. These include geographical, technical, sectoral, and many others that I discussed about. We really have a good theoretical understanding of why we should do away and how we should do away with what needs to be done to do away with these boundaries and how to strategize for integrated multi-sectoral response. But we still have not got down to doing it. We are not very sure how to do it because this is inherently social and political in nature and not technical in nature. And we need to master the societal and political approach to solving these problems. We need to get more science into society and politics, and we need to get more society and politics into science so that our future pandemic responses are integrated. Thank you.
Thank you, Dr. Krishnan. It was a wonderful presentation, and the messages are very, very clear that we need to be into multisectoral action mode, both for communicable and non-communicable disease. In fact, I am here in Bhubaneswar today for the multisectoral action plan for NCD. So that workshop is already going on. It was interesting to know that, yes, it is needed there. And we have also learned lessons through COVID that we can be into multisectoral action. I would also like to suggest that if we can think about the social boundaries that were created right in the beginning of the pandemic, and there I mean by the stigma and discrimination, and stigma and discrimination actually has affected the vaccine uptake as well. We learned that through a study, we learned that in fact stigma and discrimination is associated with the vaccine hesitancy. So we need to work on stigma and discrimination and need to have a framework that, yes, we can address it right in the beginning so that we don't have to suffer later for screening and doing other things which are very, very useful for managing the pandemic. Thank you very much. So I now give it to Dr. Garg. Doctor, now I think we have Professor Vasan with us, and you can take it. Thank you.
Thank you, Dr. Manmeet, for talking about social part also. And I'm very happy that Dr. Anand made a mention of that any kind of boundaries are, harmful in dealing with the pandemic. So that is the carry home message, I feel. And then we have to address at all levels, I'll say 360-degree approach and break the boundaries. That is important. And ultimately, behind everything, science is the one which is very, very critical. So thank you so much, Dr. Manmeet and Dr. Anand for a very, very wonderful session. So we have got Professor Vasan, and I believe that, now things are in order. So I introduced you, Dr. Vasan, and we are going to listen to a wonderful presentation. So over to you, Dr. Vasan.
Thank you very much. Can you see my presentation? I'll just
As
share
of now,
this.
no. Yeah. Yeah, now it is there.
Okay.
Yeah.
It's going to be a whirlwind scientific talk, so bear with
Yeah.
me. I'm going to be talking about One Health in high containment laboratories and how we can go in practice from identification to action. So I'm going to start by acknowledging the Vadrang community, the traditional owners of the land, where I'm joining you from today. In the bottom of the screen are the sponsors who are funding different parts of my work since the start of the pandemic. So I work for CSIRO, the National Science Agency of Australia, and I also have a chair at York. So One Health is to ensure that the plant, animal health, and human health are all intertwined, and that any situation like this, we need to look at it holistically. And I'll show you some case study to illustrate the point. The other definition I want to talk about is high containment labs, so variously called biosafety level 4, 3, or physical containment level, essentially to isolate dangerous biological agents in an enclosed facility. The third definition I want to give you is public health emergency of international concern. So at the bottom, you can see the ones that were declared by the WHO. You would probably surprise some of you that polio is still an ongoing public health emergency of international concern. So of course, we have COVID, which is also a pandemic. So with that context, so when we had the new nCoV-19, as it was called, and the world was waiting for samples, we were lucky to be the first to have an imported case here at Melbourne at the Doherty Institute, from where the virus was isolated for the first time outside China, came to my laboratory at CSIRO, and here is where we propagated, and then that led to a number of studies which were on susceptibility of this virus, of ferrets to this virus. Different dose studies which happened at PHE, where I used to work before. And then we were commissioned by CEPI, the Coalition for Epidemic Preparedness Innovations, to do a vaccine efficacy study using this animal model for Oxford vaccine, which is the Covishield, as well as Inaugural vaccine. So this was reported in Nature at the time, as you know, we were then called the Australian Animal Health Lab. And this was probably the first peer-reviewed paper we published in the world on how the virus is expected to evolve. So it involved not only traditional phylogeny, but also alignment-free approaches. So I'll just zoom in on this. So China released the code of the genetic code of the virus on the 5th of January, but we know that the pandemic probably started sometime between 6th October and 11th December the previous year. What is interesting here is that the disease transmission dynamics and the pathogenicity may change as the variants will emerge and re-emerge. And this is what we predicted at that time. What you find here is that the most virulent strain, which is denoted here, need not be the most widely circulating strain. So those two may be different as we move along. Why is that important? Because when you are looking at vaccines, you want to be focusing on the most prevalent strain. And when you are looking at evaluating therapies, you want to be focusing on the most virulent strain. So we were, as I said, commissioned by CEPI to look at both Inovio and Oxford, which were some of the first vaccines that came through their pipeline. In total, as of roughly a year ago, you had 321 COVID vaccines, 288 in preclinical stage. What is unclear from a public health point of view at this stage is that they certainly protect you from getting a more severe disease and from dying, but whether they will prevent the transmission is a question that should emerge in the coming months. This was again reported in Nature India, and where I was talking about how the Oxford vaccine, when given intranasally to ferrets, shows more protective efficacy, and that's now being tested by Imperial College London in human studies. So this is another one of the first variants to emerge was D614G, also known as the G strain. This modeling is our own modeling. So this was published, and probably the first paper in the world to show that this particular mutation will not affect vaccines. And this data was shared with CEPI, Oxford, Inaugural, AstraZeneca, and the regulators. And of course, this was in mid 2020. When you are looking at 2021, you subsequently had these alpha, beta, gamma, delta variants, right? So, so that now resulted in, so for instance, when we were looking at Inaugural vaccines, we were able to show earlier this year. At that time, only alpha and beta were present, so we were able to show that they still are protecting, but the neutralization efficacy has a fourfold reduction, which is comparable to other nucleic acid vaccines like Moderna and Pfizer that you might have heard of. So again, moving on, this is a vaccine which is called Minvax, and you can see that it can withstand up to 37 degrees for a month, and it can also withstand heat shocks of up to 100 degrees centigrade up to 90 minutes. And this was developed by my own alma mater, Indian Institute of Science, and we helped them with this evaluation against live virus. So this on the x-axis you see is the alpha, beta, gamma, delta. These are the old names, and this was reported, for instance, in BBC and published in ACS Infectious Diseases. So the other example I want to give you on One Health, since my talk is on One Health, is how originally the virus which came from Wuhan and even the subsequent G strain did not infect mice. So people were forced to look at transgenic mice and mouse, different forms of developing transgenic mice to infect to infect and develop a model. But subsequently, when the new variants arose, so when alpha, beta, gamma came along, it started to infect mice. So we, again, this is molecular dynamic simulation. So what we were doing here is look at the ACE2 receptor and how that is interacting with the spike protein. And what you see here is a zoom in version. So essentially there are three regions. So this is region 1. Here, an aromatic substitution change in either the 501st position or in a closer position called 498 will result in mouse adaptation. And that's what we were able to find using our model. There are other mutations here, for instance, K417N. This comes up in the press all the time. And then in region 3, you also have the E484K, which also comes up a lot in the press. Now, there were some misattributions of the mouse adaptation to these other mutations, which we showed is not critical. So these mutations by themselves will not result in mouse adaptation. You really need one of these two. So in summary, you need either a aromatic substitution change in 501 to result in a pi stacking interaction, or in 498. Then the question is, what if both happened, right? Does that make it even more mouse adapted? Counterintuitively, our model showed that if you have both, it actually actually will not even co-occur. That's what we found. So in summary, just this will mouse adapt, just that will mouse adapt. Whereas if you have both, it's probably not a very stable form for the virus. Moving on to in vitro, this is a very landmark paper by Starr, and it showed that actually what they did here is in the receptor binding domain, they substituted every possible amino acid configuration. So this is actually quite intensive work. And what they have done is look at the free energy and show and predict that which of those mutations, substitution mutations, will be likely to enhance the binding. What I did with my student Shruti at Monash University is to also look at the key mutations in the receptor binding domain. And what you again and again find is whether you are looking at serial passaging or whether you are looking at these alpha, beta, gamma, delta, you find that they either have the 501Y or they have the 498. But without that, it doesn't adapt to mice. So why is that important, right? Because delta, which we all talk about, does not have 501 or 498. So our model predicts that actually delta will not infect mice, which is actually a relief. So what we did was to put together our in silico modeling with the in vitro studies, in vivo studies that we could find, along with in situ, and I'll talk about that in a minute. And what we found was a consistent pattern where this quadrangulation of data can be quite powerful when you are going from identification to action. So this graph here is pretty dense. Now, every pixel you see here is a day. So it goes in the x-axis from day 0, which is 31st of December 2019, all the way to like a month ago when I did this. So this was done by our team in transformational bioinformatics group, and the molecular modeling I showed you was done by my colleague, Dr. Michael Kuiper, in our high performance computing division called Data 61. And so what you find here is this is a heat map on the right hand side. So the more brighter it gets, it means this particular variant is actually growing faster, nearly twice as fast as the non-variant, right? So which means that in these countries like say Brazil, but also Taiwan, Venezuela, Argentina, etc., these are the countries where the virus is picked up the mutations and it's establishing itself, and these particular variants are likely to infect mice. So if you are going to go and look for sewage systems and field surveillance, then you are likely to find in these countries, and this is another combination of mutations which can again give you a similar result. Now, the other thing I want to briefly touch upon is big data is useless without metadata. So what we did was you have nearly 3.6, 3.7 million SARS-CoV-2 sequences. Okay, so approximately for every 70 COVID positive patient, the swab samples are taken, and then the virus is sequenced from that, the genome sequencing. So, and the problem is, of course, that different countries sequence at a different rate. So some countries like the UK, they do a lot of sequencing. India doesn't do as much. But what you also find is that with time, countries have started doing more sequencing. So like India, for instance. So most of the, we know a lot about the virus and the variant, but we actually, and this goes back to what Anand was saying earlier, it doesn't actually tell you much about the patients from whom this virus was isolated. So 99% of these information on patients, so we don't know if they are male or female, if they are obese, if they have diabetes as comorbidity. There was a talk about NCD from the chairwoman, and these are important, right? So we don't know much about the severity of the case and so on. And even when they do put in some information, they just write something vague. So we published a paper with A-Star in Singapore, with NUS and A-Star, and also with GISAID to define a template with which this information could be collected. So recently there were other variants you might have heard of. One is called Mu, the other is called C12, which was found in a patient, an AIDS patient in South Africa. And these are very interesting combinations. And these are our own data, again, from Dr. Mike Kuiper. And from my ex-employer, PHE, I could find this slide, which shows that some of these, like Mu and Zeta, have some of the highest reduction in utilization, right? So Delta is still quite high. But the reason we worry more about Delta because of its high is due to its very high transmissibility. But if you are looking at Mu, it's not as transmissible. But if it does become transmissible, or it picks up other mutations which renders it more transmissible, then you will soon find that we are landing into problem. So these are mutations we need to keep a close eye on. This is again our own modeling, which shows that Mu is starting to show up on GISAID in these countries, as you can see. And why are all these things important, right? So from a One Health point of view, we have a mouse plague going on in Australia, in New South Wales. It's a species which is very hard to either vaccinate, like we did with horses, with Hendra, or to control, like Denmark was able to control minks by mass culling. And this is, you can't do this with mice. Once you have an additional reservoir, you have new mutations, and then they will then reinfect humans, and that will result in greater problems. So you need enhanced and targeted surveillance, and that's really important. Last couple of slides. In the meantime, we are also focusing on stem cell derived organoid models to evaluate repurposed therapies, because that's one of the easiest things we can do. There is lack of therapies. So far, you only have some anti-IL-6, some limited antivirals, and 2-3 antibody cocktails. I'm developing my own polyclonal antibodies here in Australia, and this is in collaboration with the Indian Institute of Science. And we are also working with the local healthcare system on long COVID, which is another area which is not studied properly. And this is called the Systems Initiative. It's funded by the Medical Research Future Fund with about 1.7 million Australian dollars. And we are using machine learning to make sense of big data, so which is a big innovation for us. And some of the institutions collaborating, you can recognize there's also an Indian institution, Plenary, which is helping us with both the pharmacoinformatics, because they are rated the third best pharmacy department in India, but also with AI, ML, artificial intelligence, and machine learning. And again, recently, I'm very pleased to say, we learned last week that we won another major award worth about $2 million US dollars from the FDA, US FDA, to look at systems biology and machine learning to improve the readouts of ex vivo models, in vivo models, and human studies, not only for COVID-19, but also use the learnings from COVID-19 for disease X. So once again, we have these kind of collaborating institutions working with us. And last couple of slides, I want to talk about diagnostics. So don't forget diagnostics. So these kind of numbers you see here, $125 per test kit, this ain't going to work for countries like India. So we need something like the ones that they developed in Bangladesh, which is like $3. And this is actually a paper by Lord Darcy's group from Kamlini Ramdas. And what they found actually is that, and I'll show it here, if you actually have tests which are not particularly accurate, not particularly reproducible, that's still valuable as long as they are independent. And as long as they are cheap and you repeat 3 tests, you are able to reduce the rate of false negatives considerably, from a high individual value to actually administering 3 together, you can actually innovate in the healthcare system. The other innovation is a pooled testing strategy using the Latin hypercube model. And there is a lot of work going on, including in Edinburgh, where they are piloting that. So this is some initiatives I did in India when I used to work for PHE, including in JIPMA and in Rajiv Gandhi Institute of Chest Diseases. One of the things we need to strengthen is the BSL infrastructure. It doesn't have to be BSL 4. We need more BSL 2, BSL 3 labs in India. And we need to have greater pandemic preparedness. And we laid some of the foundations for this back in 2017, that kind of period. You can see Harish, Dr. Harish from JIPMER being present there. The other thing I did actually with Professor Anand Krishnan at AIIMS, and subsequently we did it in NIMHANS, is Public Health Observatory, right? So we were trying to work with them to see how we can promote a greater surveillance, which will strengthen the infrastructure. Lastly, but not the least, we have been doing some work on wastewater-based epidemiology, so detecting the variants in the sewage system, and which will again trigger early warning systems for better pandemic preparedness. Unfortunately, right, in India, this may not work everywhere because of the sewage system not being present in rural India, but at least in urban India, it can help solve the problem. So with that, my 18 minutes is up. Thank you very much, and I'll be pleased to take any questions when the chat permits. Thank you.
Thank you, Dr. Vasan, for a very lucid presentation and bringing into forefront, various issues like beginning from genetic code to the most virulent strains, which will not be able to circulate widely. It's not necessary. And talking about 321, COVID vaccines, but then we have lack of clarity of prevention of transmission as well. And you talked, rightly from the perspective of the BSL safety, but another thing which you brought out on the forefront was big data is useless unless it is complemented with metadata. So these are some of the important things, and I think you took the topic from a very, very broad perspective, and it gave a broader focus to the whole initiative as well. So thank you so much, and now I'll request, we'll take the question answers towards the end, and I'll request Dr. Manmeet to introduce Dr. Chandrakant.
Thank you, Dr. Vasan. It really was interesting to learn that you have done so much of work, and it really was eye-opener for me, at least, because I'm not from the medical field, but I learned a lot today. Thank you. So back to Dr. Laharia. Very happy to introduce you for this session. He's an epidemiologist and public health expert, and he has 25 years of working experience in epidemiology, vaccinology, immunology, and health systems. He has awards, fellowships, joined WHO in 2008. His key role has been in formulation of National Vaccine Policy of India. And he received Dr. B.C. Srivastava Foundation Award in 2012 by ICMR. He has publications and books, but this one book that Till We Win, India's fight against the COVID-19 pandemic, I learned it from the news channel of TV. So over to you, Dr. Haria. I think that everybody is waiting. Okay.
Thank you very much and good morning. So there is a recorded presentation, but I don't have 25 years of experience. I have around 14 years of experience. That's a typo there. Thank you.
Okay, that's right.
Welcome. Today we are going to talk about whether we are ready for a future pandemic, what lessons we have learned from ongoing COVID-19 pandemic, and the way forward. This is a big question. So what I'm going to do, I'm going to break this into three parts. One is that what we have learned in last 18 months of the pandemic. That's one. Second, we will examine and I'll reflect upon that how things have changed as far as health system is concerned in India during the pandemic period. And third part, we will look at what are the ways forward so we are prepared for future pandemic. Now, starting with what we have learned, and there are quite a few learning. One of the learning is that the health systems which are stronger or better prepared are always able to deal or handle or delay the response or challenge. So for example, the better performing health system can handle the pandemic relatively better in comparison of not so good performing states. An example is that many of the countries across the world, relatively better performing health system. And when I say health system, it does not mean medical care system. Some of the European setups had a medical care system, not the kind of preventive, promotive, curative, diagnostic, or rehabilitative services which are needed to make a health system. So European setup with the medicalized care system struggle, but some of the countries such as Vietnam, South Korea, and Thailand did a very good response to the first wave or initial period of pandemic. And that's the role of good health system, that they can handle and mount an initial response. Now, in the long term, how the response will be is dependent upon what kind of challenge we are going to face. But if a health system is good, it can give sufficient time to a particular setup to respond to that challenge. And that's what a good role of health system is once again proven by this pandemic. Back home in India, we are seeing in some of the southern states, including Kerala, that it mounted a really good response. Even now, if cases are being reported, it's outcome of that it performed really well in the beginning and it delayed the transmission, but the virus is transmitting and that's a different story. So that's one lesson. Second lesson we learned that a health system, which are usually based upon primary healthcare system and not a medical care system, I'm going to the original point, do far better. They are better equipped. They can provide the preventive, promotive healthcare services. That's what they did. And the same kind of state which have a good healthcare system also have the foundation of those healthcare system based upon primary healthcare. Again, same country, Kerala, state in India, Thailand, Vietnam, South Korea, and many others. The third lessons we learned that the community participation and decentralization definitely play a very important role in the process. Now, many of the pandemic-related interventions were dependent upon citizens engaging in those COVID-appropriate behavior. And if health system is stronger and community participation is good, we mount a good response. And that's also linked to the decentralization. If decision-making power is centralized to some individual, it does not work. The fourth lesson is that which emanate from all of these, be it a stronger health system, primary healthcare, community participation, that if we focus upon public health services, if we have a good foundation based upon epidemiology, and if we have a trained public health workforce, we can mount good response. Other learning lesson is that while there is a role of private sector, but when it comes to public health intervention, it is a government health system which is required. So in this COVID-19 pandemic, we know that private sector provided some assistance in testing services, a large part of curative services in second wave, but majority of isolation, testing, quarantine, contact tracing, and even the public health messaging was done by government health system. So there is no replacement for government healthcare system. In fact, a government healthcare system functions well. It can result in improved response to the pandemic. It was only when government health system was overburdened or not succeeded that the role of medical care and treatment came in the private sector. But of course, having said everything, bigger role of government health system, some role of private sector, and both need to work together. Of course, there are other areas where private sector played a major role. For example, vaccine development was public-private partnership, but the production of personal protective equipments and masks and others happened because of private sector. So private sector has a definite role. One of the last learning from this pandemic, one of the key learning, is that to mount an effective pandemic response, we require three-way partnership. The partnership between policymakers, and the technical experts, be it a medical care expert or health experts, and community. It is only when all three works together it will succeed. If a technical decision is taken by policymakers, it might backfire. And there are many examples in this pandemic. So these are the key learnings which we need to remember. Then if we go back to the original question that whether we are ready or India is ready for a future pandemic, then we have to see that how health system of India has changed over last 18 months of pandemic. And what we will do, I would examine this from the perspective of health system function. Each of the health system function, and let's look at it. So the first thing is that what has changed in the governance. In the governance of health services or health systems, we realize that the political leadership has recognized the importance of stronger health systems. There has been a lot of talk on strengthening health systems, development of public health cadre, increased investment on health services. The government also utilized the regulation to cap the pricing of both hospitalization and testing services. So some of these interventions have been done in India and health received some attention. But we also need to remember that we heard a lot of talk about strengthening of health system in the early part of pandemic, but when second wave happened, the situation was not grossly changed, and we had seen almost a crisis in the country. So what we need to remember that while governance function improved and there was some attention, it does not automatically translate into actions at the ground. Now that's a fear here, that if that is a challenge, within 1 year of the pandemic, things did not change, why we should assume that it will change once the pandemic is over. So there is a lot of attention, but if we want to change on the ground, it's important that those are followed through and something need to be done by technical expert to remind policymakers regularly. So that's on governance part. On service delivery, we know that India's health services are really weak in the sense that majority of the people need to go to private sector and everybody does not get services on time. There are many challenges in that. We also know that India mounted a response to COVID-19 pandemic largely because many of the services or many of the providers were diverted to COVID-19. But we also need to recognize that over a period of time, these services, non-essential, non-COVID essential health services were reduced. We know that now the tuberculosis program, non-communicable disease services, other services were reduced. So services have not improved, but COVID-19 services were reprogrammed from the existing services. And that's another challenge, that we don't see much of the change there also. And it also requires additional intervention. Third part is health financing. the amount of money allocated for COVID-19 pandemic response was by many standards not sufficient, but then also it is gone largely to infrastructure changes, but the foundational changes such as policy reforms or change in the salary or recruitment of new staff, that has not happened. So unless you can have an infrastructure, but unless there are changes in the human resources, that does not work. So the financing of health services has not been sufficient. We also have seen that the reluctance of policymakers in providing free COVID-19 vaccine and a lot of dilly-dallying on that is that while governments commit that they will provide services, but when it comes to allocate resources, they do a lot of back and forth and always insufficient. Fourth part is health workforce. We had a lot of talk about strengthening epidemiologists, public health workforce, but if we start counting and doing a detailed analysis, we will know that this has not improved that much. We heard a lot of talk about 300 epidemiologists being recruited by Government of India. But if we examine how many epidemiologists have been recruited, but it's not about recruiting epidemiologists or public health persons, it's also about retaining those public health persons. If you start thinking how many states are talking about public health cadre, the discourse has not moved. It would not automatically move. The question is that if not during the pandemic, when it would move. When it comes to drugs and medicines, we know that even for COVID-19 pandemic, people have to go to different to the private sector, spend from their pocket, even for the drugs, hospitalization. And one of the saving grace because of a lot of discussions and public discourse on COVID-19 vaccine, that now government is covering the cost of vaccines, but other medicines and diagnostics have been paid by the people from their pocket. So even for COVID-19, things have not changed. Final part is of health system is health information system. And we know the data on health, both recording, reporting, before the pandemic was poor, and now we are hearing a lot about the mortality statistics and also actual cases, and we know through sero surveillance that the numbers officially reported is far lower. So disease surveillance system has also been challenged. So if we look at each of the component, governance, service delivery, health financing, medicines, diagnostics and vaccines, human resources and infrastructure, and health information system, all of these have received attention, but they have not been moved to the extent which they should have. So are we prepared for future pandemic? Are we better off in comparison of, let's say, March 2020? To some extent. I would not say that progress has not been made. The issues have been understood. We have recognized, realized the testing services is far better. We have a workforce which can deliver on time. The vaccination program is catching up. But this is very small fraction, and it would not automatically result in the improved situation. It is likely to be soon forgotten. We have seen many such challenges. So we need to remember and keep reminding, once the pandemic is over, that will be the real test of this setup. How this can be done? Well, one of the things is that this can be done mainly, I would say a few things. One of the things is that soon after pandemic, a calm, composed and impartial assessment of India's pandemic response should be done. This should be led by the government and guided by independent technical experts. We need to be really honest in that assessment, that where we had gone wrong, where India had gone wrong, and what we did well, and what should be done. So that kind of calm assessment, not self-praising, not official documents, need to be done. Second thing is that the importance of public health institution has been recognized, but it is also a time that those institutions are strengthened. The National Center for Disease Control provided important guidance, but we need to have and Niti Aayog action agenda had recommended that in the past that we need to have a stronger institutions of epidemiology and public health in every state. So NCDC need to have an NCDC-like institute in every state. So we need to build the institutions. The public health cadre across Indian state need to be established. The epidemiology and epidemiologists, as a training and the capacity, the human resources need to be not only trained well, but also be remunerated well and those should receive attention. Pandemic is something which has reminded us, and we should do that. Third thing which should be done if we want to be prepared for a future pandemic is that all the promises on health, be it a national health policy or other promises made in the last 5 years, and especially since start of the pandemic, should be re-examined. Only the promises which have been made in the recent months are fulfilled, India's health system would be far better and better prepared. Other part is that to prepare for future pandemics, we don't have to prepare for pandemics. We have to prepare for outbreaks, each and outbreak. If we know that how to handle each outbreak, if there is a capacity at every level to handle outbreak, it will prepare us for the future pandemic. If we can tackle outbreak, we will be better prepared for epidemics. If we are better prepared for epidemics, we will be better prepared for pandemic, and it will take care. And we need to build that kind of capacity at all levels. The learning, as I said earlier, is the three-way partnership. The partnership between the policymakers, technical experts, and community need to be established, strengthened. If that kind of partnership can exist at all levels, where there is a trust, where the technical advice inform the decision-making process, and where communities are involved in that process, that's not pipe dream. It happens in Thailand, it happens in many countries, and that will prepare us for future epidemics and pandemic. One of the key learning in this pandemic has been that India need to do a little better on science communication. We all, especially public health expert, but technical expert, health policymakers need to learn how to communicate science. Soon after the second wave, there was a lot of misinformation about that third wave would affect children. It was not effectively tackled. It created the fear of the mind of people. By the time it was tackled, it was too late. So science communication had to really emerge. The impact of those misinformation has been that today India has schools closed in majority of the schools, majority of the states. Now, science says that schools should be open, but schools are not being opened by majority of Indian states. Science says that primary schools should be open first, but very few states have opened primary schools. This shows that one, the science communication in public health is weak. Second, that policymakers do not use science always to make decisions. So, and of course, the communities are a little reluctant, people are a little reluctant. So the three-way partnership between the technical expert, policymakers, and community could have addressed all of these challenges. So we need to strengthen the science communication in coming period. Then what should be done is the One Health approach. The majority of zoonotic diseases, which were in the wild and animal are coming to human beings. The reasons are that the climate change, the pathogens which were not able to survive earlier in the particular temperature are now surviving new settings. Then also deforestation. People are cutting forests. We are coming human and animal interaction or forest interaction, wild interaction is happening too much. And this means that more zoonotic diseases. This means new diseases are emerging or old diseases are re-emerging, and that require a better One Health approach, which need to go beyond the academic discourses, but the ground reality. The capacity need to be built and two need to work together. And final part, if we want to prepare for future epidemics and pandemics, say that this need to be ingrained and integrated into primary healthcare system. The training in public health, the principles of epidemiology, all of those need to be given to the primary healthcare staff. And of course, there are upward linkage and the linkage with the medical college, all that need to happen. But somebody sitting in district hospital or medical colleges and epidemiology and public health will not work. We need to have this reach to the community level, to primary healthcare level. And that's how the public health will strengthen. So there are many role and many learning in this. I discussed a few parts that what we have learned. I discussed that how health system of India has changed or not changed. But then the key that fortunately, when we are talking today, the situation of COVID-19 pandemic in India is improving. We might have a seroconversion of something like 80% as of now. The vaccination coverage has increased, and with the more than 2/3 of India's adult population received at least one shot. The daily new COVID-19 cases have stabilized at a relatively high baseline. We hope that if COVID appropriate behavior is followed for some more time and if vaccination coverage can be increased, we can overcome this pandemic unless something major happens. But the success or victory against this pandemic would be incomplete unless we derive lessons from this the challenge which we faced. Unless India commit to strengthen healthcare system, that's very much possible. That's possible, and that can happen if we can have such kind of dialogues, and those dialogues and learnings are effectively used for policy making. It will not happen in 1 year, but it can happen with a sustained engagement and policy commitment in few years. If India is prepared for future epidemics or pandemics, not at present, but it can. Thank you very much.
Thank you, Dr. Laharia. It was interesting, and I think the message is very loud and clear that we need to go for structural changes, which means that we need to change our policies and ensure that those policies are implemented, especially which is something which is related to human resource, because human resource probably is the key to manage all the pandemics like COVID-19. The second message again is very important and very clear that all the three, the scientific community, the political system, and the community, all the three need to work together actually to fight such pandemics. So these two messages are very, very clear, and we have the lessons with us, and we need to really work on these lessons. Thank you very much. And over to you, Dr.
Can I just add one point before we take questions? Chandrakant is the person with whom we discussed about this plenary, and because of his busy schedule also, so we had a lot of exchange of ideas. How should we plan it, and how it can help the flow of the sub theme that we have done for the COVID effect of COVID-19 on the health system. So thank you, Chandrakant, and thank you, Professor Vasan, for joining from Australia. I know that you are super busy there, but thank you so much for your time. And over to you, chairpersons.
Yeah, thank you, Dr. Garg. And I am now, it's over to you. And I may need to leave also. Thank you, everyone. It was really interesting.
Thank you so much. And I think, Dr. Chandrakant, the whole talk was very practical, and we need to really draw many lessons from this. And one more thing, that where you talked about public health workforce, the document has been recently submitted to the Ministry of Health, Government of India. We prepared that, 5-member committee was already appointed, and which we prepared it, and 2 days back, I think we finalized the document. So that is there, but then a lot of things are there in terms of learning from the pandemic, and you really pointed out that this has to be really dissected from the perspective of, I'll say that from the policymakers, from the providers' perspective, from the perspective of the community. And, we definitely, what you pointed out was also very, very important, that how we utilize the, resources which were meant for COVID pandemic. We should have, kind of created a workforce which was sustainable, and that is another important thing. So if I was to look at the chat box and look at some of the questions, Dr. Can we have this? I can't see any questions. Are there any questions? Are there any questions the participants can ask?
There aren't, ma'am.
Yeah. It's only the comments are there about themselves and all that, and good oration and all of that. Yeah. Okay.
There is one question, ma'am. One second.
So, Dr. Chandrakant, will you like to say something in the end, and then we close off the session?
Ma'am, the tech team says there's a question from the viewers. So he will just forward those questions to us now.
There? Okay.
Yeah, there are viewers on the conference platform who have a separate way of asking.
So, can you forward us some questions?
Yes, the tech team is just forwarding those questions to us now. Are you able to see the questions, ma'am?
This one, COVID-19 is going to be endemic in our country soon. So what should be the strategies, and same or any specific strategy we need to practice? So we can start from Dr. Chandrakant, and then we'll go to Dr. Vasan. Dr. Chandrakant, can we take this question from your end?
Sure. Thank you. Thank you very much. So what we need to remember that this virus is going to stay with us, and the level of transmission will be low, and that point of time, the disease will be considered endemic. So COVID-19 becoming endemic is a reality. The only thing is unknown is that when. So what we need to remember, two things. One, till the world is in the mid of the pandemic, India would be in the mid of the pandemic. So the decision on whether pandemic is over or not will be taken by international health organizations. And until then, we should consider ourselves in the pandemic. Once the pandemic is over, then the endemicity will be decided in each country by the local country authorities. So for some settings, the endemicity will be a different stage, and for India, it will be a very different stage. But one thing is given, that India would be in the endemic stage and the world will be in the endemic stage of this disease.
Thank you so much. And I think probably, our states will also decide, according to the extent of the disease, because our states are also so varied and they're equivalent to many countries. So that is overall also the, at the country level, we'll be able to decide that. Any other question?
No, ma'am. As of now, that there was only one question, but I need to tell you that around 600 participants have viewed this plenary session. So that's a great number.
Yeah, that is true. That is true. So I'd like to thank Dr. David, Dr. Vasan, Dr. Anand Krishnan, and Dr. Chandrakant for bringing into forefront many issues, and issues that are of varied nature, and we need to kind of compile, I think, the lessons from this session itself, and maybe we can submit it to the government, Dr. Sitanshu, because this is going to be a real practical recommendation based session. So I feel that that will be much more important in terms of how did we we are looking at the pandemic now, what are the lessons drawn, what can be if we were to look back, what could be, or if I was to redesign the strategies, in what way will be different, so that these lessons need to be kind of drawn from this pandemic. So with this, I really thank you all, both the coordinators, Madam and Dr. Sitanshu, and plus Professor Vasan, I can see, Dr. Chandrakant, I can see, but I can't, Dr. Anand, I can't see, he probably dropped out, and Dr. David also. So thank you so much, and it was a lot of learning from this session, and I'm sure this will make a lot of difference if we share the lessons learned from this to the Government of India. Thank you so much.
Sure, ma'am. We'll do that, ma'am. Thank you so much. Thank you to all the panelists and viewers.
Thank you, Chandrakant. Thank you so much for your time.
Thank you. Thanks, Dr. Sitanshu.
Now the next session will start at 2 p.m. There is a lunch break now. We had IPHA award papers that is going on in Hall A. So if someone is interested, they can go to Hall A to view the proceedings there. So in the main hall, we'll reassemble at 2 p.m. Thank you so much.
Thank you.
Sir, good afternoon, sir.
गुड आफ्टरनून।
सर खाना खाने गए थे सर।
वो सेशन कैसे हुआ पिछले वाला? मैं तो लॉग किया, मेरे को किसी ने अंदर छोड़ा ही नहीं पिछले
Really,
वाला
sir?
सेशन। आई लॉग इन एट 12:30 और सो।
Oh, no, we are there, but it went on very well, sir. Your talk was appreciated. So questions के लिए time नहीं थे ज्यादा, तो इसलिए question answer हुआ नहीं सर। सर मुझे एक बार log मतलब ये कर देते सर, थोड़ा सा indicate कर देते
मैं 2 अदर मीटिंग में साइमल्टेनियसली था, मैंने कहा चलो नहीं हुआ, बहुत अच्छी बात है।
That's true. Hello, Dr.
Hi, good afternoon. Hello, Dr. Karan. Good afternoon, Dr. Anand.
Good afternoon.
So I'll be here for 2:30, and then I'm going to steal away from 2:30 to 3, and I'll try to come back from 3 to 3:15, which is when I think Q&A is.
Yes.
By that time, we'll
नहीं गलती से लग गया सर, आ जाता। Sir, we are 1 minute away. We'll start the session on time, sir. So initially I'll introduce you, sir, then you can take over, and then we'll play the video. Anand sir?
हाँ हाँ बोलो।
हाँ वही plan है sir.
हाँ, you tell me. I just say that we have already fully recorded it, so and you then start the record, right?
Right, sir.
Yeah.
Okay. Good afternoon, everyone. I welcome you to the post-lunch session of the 65th IPHA Conference 2021, Day 2. Today, in the morning sessions, we had 2 plenary. Now we are coming to the 3rd plenary of today's day, which is on the excess mortality due to COVID-19. And this session will be handled by Dr. Anand Krishnan. Sir needs no introduction, but to complete the formality, we have to introduce Sir. So Sir has been there with IPHA Con for such a long period, and all the guidance that I have received from you, Sir, I'm very thankful and grateful to you for your time and guidance. Thank you so much, Sir. So please share the screen. Not to you, Sir. Thank you. So, Dr. Anand Krishnan, as I told, needs no introduction to the community medicine faculty or our and public health specialty. Sir is a professor in Center for Community Medicine, All India Institute of Medical Science, New Delhi, and also heading the WHO Collaborating Center for Capacity Development and Capacity Building in Community-Based Strategies in NCDPC. Sir has got around 30 years of experience after MD at a PhD level to international level. There are significant awards, fellowships, and contributions that are there. We had to cut Sir's CV drastically to fit it into a single slide. So I'm not going to go into the details of each one of us, but Sir is a role model for many young public health professionals, and I personally learn a lot from his approach and his systematic way of thinking about an issue. And it's a great pleasure always to work with Sir and learn from him. We are also collaborating with so many other things with AIMS New Delhi under Sir's visionary leadership. So with this, I hand over the session to you, Sir. The floor is yours. Thank you so much for joining us.
Thank you, Sitanshu, for that maybe too generous an introduction. But I'm sure many of you would be interested in this area of excess mortality due to COVID. We have tried to do justice for that in this program, focusing not only on the numbers or the epidemiology part of it, but also on the other aspects of the excess mortality. All the participants are well known, but you will hear them. We have recorded the whole session. Therefore, I'm going to just ask Sitanshu to run the video, and we'll come back at the end to answer your questions, if any. Thank you. Back to you, Sitanshu.
Thank you, sir. We are going to play the video right now from our end.
So welcome delegates to this Iphacon session on excess mortality due to COVID-19, which is being sponsored by Minerva, which is currently run by Center for Community Medicine at the All India Institute of Medical Sciences, New Delhi. We'll shortly see a film on Minerva to introduce to all of you what is Minerva all about. But as we all know, we all have been grappling with mortality due to COVID, either at both at personal and professional level. And we would all like to see some numbers emerge out of this exercise as early as possible. But there are a lot of challenges there. And today we will have a discussion on COVID mortality. And one of the ways that we do it by assessing or estimating the excess mortality due to COVID. To do that today, we have a very interesting session ahead of us. And to share the chairmanship burden with me is Gautam Menon. I am Dr. Anand Krishnan, professor at Center for Community Medicine, who runs the Minerva network and have more than 300 publications to my name. And Gautam is a professor of physics and biology at Ashoka University, Sonipat, at the Institute of Mathematical Sciences. He is also an adjunct professor at the Department of Biological Sciences at the Tata Institute of Fundamental Research and currently the director of Center for Climate Change and Sustainability at Ashoka University. His interest is in modeling of infectious diseases and its implications for public policy. He is also interested in making science accessible to the public. So I see there are a lot of interests that I and Gautam share. So now I request Maheshwata to run the film on Minerva.
Welcome to Minerva, Mortality in India established through verbal autopsies. Why do we need Minerva? Reliable statistics on the causes of death in the population are essential for setting priorities in the health sector. In India, where adequate medical facilities are not available, most people do not die in health facilities, so cause of death is unknown. Data based on the medical certification of cause of death is insufficient to represent the whole country accurately. However, the sample registration system is an important source of data on annual demographic indicators, including causes of death in India. It is based on a system of dual recording of deaths in fairly representative sample units spread all over the country. The field investigation consists of a continuous enumeration of deaths in selected sample units by part-time enumerators, who are generally Anganwadi workers and teachers. This is followed by an independent retrospective survey every 6 months by SRS supervisors to fill the verbal autopsy forms through the interview of caregivers. The information gathered through verbal autopsy forms needs to be coded by the physicians to ascertain the underlying cause of death. It is here that Minerva comes to play an important role. All India Institute of Medical Sciences, New Delhi, partnered with the Office of Registrar General of India to accomplish a common goal: reliable estimate of cause of death in India through Minerva. Who are we? The Minerva as a network comprises of AIIMS Technical Support Unit, network institutions, physician coders, and technical advisory group. AIIMS Technical Support Unit, located at AIIMS New Delhi, include faculty members and project staff. It closely liaises with Office of Registrar General of India in implementing the program and provides technical support. Presently, we have 25 reputed medical colleges across the country as partner institutes to ATSU in the Minerva network, and it is an ever-expanding process. Through Minerva network, we provide introductory as well as refresher training to supervisors regarding the verbal autopsy. Physician coders are the heart of the Minerva network. Technical advisory group includes experts in the field of epidemiology, clinical sciences, demography, and statistics, and has an advisory role. The entire process of information collection from the verbal autopsy, data quality checks, and assignment of ICD codes by physicians is done through a web-based application developed by the ATSU. The web application of Minerva has 3 platforms. The QA platform for quality assurance of verbal autopsy forms. Training platform provides an online training to the physicians regarding the assessment of cause of death based on verbal autopsy and guide them to provide most appropriate ICD-10 codes for the same. Online coding platform enables the physician coders to visit the verbal autopsy form allocated to them and provide the appropriate code. From the humble beginning, the Minerva network has grown rapidly and expanded to its present avatar. Today, the network is functioning smoothly. Causes of death have been assigned for over 1,25,000 deaths enumerated by the SRS between 2015 to 2017, thereby fulfilling an important public health function. With the constant support of the partners, we have set our long-term goal of each and every death being counted and cause of death ascertained, death within the hospital as well as outside. We strive to accomplish this by strengthening medical certification of cause of death with collaboration of medical institution, National Medical Council, as well as private hospitals. The other aspect is to increase the coverage of verbal autopsy to cover the entire non-hospital death in the country through expansion of SRS and including verbal autopsy as a part of the health system at all levels. Both these actions will provide us with substantiate data and help in making policies regarding health and its infrastructure. We take this opportunity to invite you to join in this public health initiative. Thank you.
So that was about Minerva. And to take the session forward now, I request Gautam to introduce the next round of speakers and take it from there.
Thank you, Professor Krishna. Thank you, Professor Krishna. And welcome to all of you. As you know, there is probably no single number as controversial as this question for COVID-19 as how many people died since the first COVID case was recorded on the 30th of January of the last year up to the current date. And there are numbers that span a range of 1.5 million, 1 to 1.5 million, all the way up to 6 or 7 million. And to piece this together has been the job of many people, participants in the Minerva study, as well as many people outside the medical system, people who write about health, people who investigate civil sources of this information. And the hope is that this session will help us make sense of this number from multiple points of view and see what it is that we can do, at least in the future, to improve our understanding of what really happened in the past and how we can set better benchmarks in the future. So this session will have 2 talks, one by Dr. Rakesh Kumar and one by Harshal Salve. Dr. Rakesh Kumar will talk about challenges in COVID-19 mortality estimates, and Dr. Harshal Salve will talk about COVID-19 mortality estimation, the Minerva experience. Let me briefly introduce both these speakers. Dr. Rakesh Kumar is an associate professor at the Center for Community Medicine at AIIMS. He has extensive experience in epidemiology, in training and teaching in public health and community medicine, in ops research, program management, program development, and policy in India as well as South Asia. He is a member of the AIIMS Technical Support Group, which supports the Registrar General of India in the SRS. He is interested in epidemiology with a special focus on tuberculosis and respiratory infections, as well as in mortality surveillance. He has more than 70 papers to his credit. Briefly about Dr. Salve, I'll introduce both these speakers and then have them speak one by one for about 10 minutes each. Dr. Salve is additional professor at the Center for Community Medicine at AIIMS. He has 13 years of experience as a physician, teacher, and community-based researcher at AIIMS Delhi. He's worked with the Ministry of Health at the national level, state governments, as well as the WHO on expert committees, research projects, and technical reports. He works in non-communicable diseases, climate change, air pollution, mental health, and health system research. He's a member of the WHO Collaborating Center in Minerva at AIIMS. He's also contributed in generating awareness regarding COVID-19 among the general public, both on TV and on print media. He's worked in multiple funded community-based research projects and is coordinator for the collaboration on air pollution health effect research in India, funded by the Health Effect Institute in Boston. Dr. Kumar first, and then Dr. Salve. Would you please go ahead?
Thank you, sir. Thanks for giving me opportunity to present my talk. So I'll just start sharing my screen. So the topic of my talk is what are the challenges in COVID-19 mortality estimation. And my focus is not to critically examine the estimates that has been generated so far, but to see that what are the challenges involved in generating them. Why do you need mortality estimates? And obviously we need, because for a novel disease like say COVID, we don't know that how lethal is the disease. I mean, so that is one of the key requirement of mortality estimates, that just tells us about the disease lethality. It also tells us about what is the impact of a disease on various populations, especially among the vulnerable groups. What is the effectiveness of mitigation measures? And somehow in this whole COVID-19, that seems to be the major focus of monitoring all these excess deaths. How has mitigation measures performed? Then what is the trend through the years in the various mortality disease and also mortality? And last but not the least, that it also contributes to the global. These are some of the uses of mortality. And coming to the mortality due to COVID, so we have so far around 4.6 million officially reported COVID-19 deaths. 0.44 million are from India. So if you just look at the research gone into generating excess deaths, like any other aspect of COVID-19, and that is totally understandable because it has been an unprecedented, never seen before, at least last 100 years, this pandemic. It has generated immense interest among the researchers, and there are a lot of research and a lot of work going on generating excess death estimates. So it is an over-researched area, and just looking at some of the databases tells us that a lot of data, a lot of researches already exist on the excess estimation. So it informs the policy, it informs the kind of discourse on around COVID-19. At the same time, it generates lots of confusion as well. And so if you just look at the various publications, the various peer-reviewed publications, as well as from the news media or other media, there are a lot of cacophony on what is the number of excess. So every day it keeps on coming that, okay, this is the number excess deaths. What is the kind of extent of excess deaths? So official COVID-19 death counts have been hotly contested. There is a near unanimity that it is a significant undercount. But what is the extent of that undercount? That is what is debated. I just discussed in my subsequent slides that why generating a kind of very robust estimates is a challenging proposition. So when we look at COVID-19 excess mortality estimates, there are a lot of uncertainty. These uncertainties doesn't arise from not only from the methods that have been used, but also from the data availability and how does what kind of data is accessible. Is the data is accessible and complete or not? So various estimates that have been generated, there are a lot of uncertainties around that. So I'll just give the three examples and three of the more credible estimates that have been generated from So first is coming from a group. They just looked at Iphacon et al. And they just tried to look at three different approaches to generate excess. Why I'm seeing these numbers again, as I would emphasize again, is not to critically analyze those numbers, but just to see that and just to kind of present that what are the challenges actually, what are the uncertainties in those numbers. So there are three, they use three approaches. One is using the civil registration system from 7 states. The second approach used was based on the demographic structure and the seroprevalence data and applying the international age-specific infection period. So there is a meta-analysis done by Levin et al. Published in European Union. in December 2020. So they have generated the best estimates for meta-analysis. So that has been taken as the best estimates for infection fatality rate. Based on that, they have generated some mortality estimates. And third is the consumer parameter household survey, and that is a longitudinal survey of 170,000 households, wherein they follow them. So what I just want to emphasize in this, that there are three different data source from which these numbers have been generated. Broadly, though, convey that the excess deaths are in the range of say 3.4 to 5 million. I'd like you to look at the kind of CI of the first estimate that is quite wide. So it is 3.4, but it could be anything from 1.1 million to 4 million. It's a quite wide CI confidence interval. Similarly, if we just look at the kind of trend or impact of wave 1 versus wave 2. So from two estimates or from two approaches, we see that wave 1 was more lethal, whereas if we apply the approach of seroprevalence and infection fatality, we see that the wave 2 was more. So from the same, if we use the three different data sets, use three different approaches, we are getting some different results. And that just points to what the uncertainty. Similarly, Ramchandran et al., they use the same consumer pyramid household survey data to arrive at a cause of death. They got a bit different data, and what their conclusion was, wave 2 had significantly higher excess mortality. If you just look at the analysis of Avinav Anand et al., we see that wave 1, I mean, looking at the same data, they concluded that wave 1 was more had higher excess. And we look at the data from IHME. So there they estimated excess COVID-19 deaths as around 700,000. So different approaches, different data set used, or maybe even same data set used. If approach is different, they can give a very different estimates of excess deaths. That's what is my conclusion, and thus that a lot of uncertainties involved in generating these estimates of excess deaths. And this is not the problem only with India, where we know that there are limitations of data, but other countries also, say United States or UK, where much better data is available and accessible. There also we see that different agencies, they generate data for the same time period, and they get very different mortality estimates. So I just here I would like to emphasize and to set the context. As I just say a story of it was 6 blind men of Hindustan to learning much. Right? So I just want to focus on the last line, and that is that each observation might satisfy. So we want to see what we want to see. What we observe is not the nature in itself, but nature exposed to our method of question. That is important, is that what we see, what we are trying to see, and that's what we see. And that is a whole issue with this COVID-19. Different people are trying to look at it from different perspective, getting different numbers. So the whole truth is different. We are just looking at the part of the truth. So what to count? That is a very important consideration in generating the excess death estimates. We want to count the direct COVID deaths, or we also want to count deaths, indirect deaths, which are occurring because of the impact of pandemic, not necessarily because of COVID-19. So they are also important because and in my view, that is more important estimate, because that just tells us the overall impact of the COVID. So what we are trying to measure, whether we are trying to measure direct deaths or we are trying to measure the overall deaths, both direct and indirect. So you just look at what are the factors which might impact the estimates of COVID-19 deaths. So what is the source of data? What source of data we are using? Many places they use the death certificates. Death certificates, what is the cause of death? In our countries, because medical certification is very low, I'm not sure that that is a very good approach to look at it. COVID registries, wherein all COVID positive patients are followed up, and mortality, anybody who dies in that is, and we know in our countries that most of the COVID-19 patients are followed up for 28 days. If anybody dies in that period, then that is taken as a COVID-19 death. Then whether the deaths are from the hospital deaths, or we also include out of hospital deaths, care home, or kind of home deaths in our country, or we use the indirect methods, like say the application of infection fertility rate to the zero prevalence. So what data we use has a major bearing on what kind of excess deaths we are doing. So we have to choose our data very carefully and look at the completeness of data and how robust that data is. And we see in the case of UK, they use the 3 different approaches and they got very different results on the daily death counts. Second is how do we classify COVID-19, whether it is, I mean, some places COVID-19 is only confirmed if they are lab confirmed, either by RT-PCR or rapid antigen. Other places we have clinical diagnosis or radiological diagnosis. In our country, there are, and most of the states what they follow is even among the COVID-19 patient, a panel of experts sit and look at what is the probability of dying from COVID-19, even among the COVID-19 positive. Different places have got different criteria for classification as deaths. And that has got a major bearing on what death count we are doing. Performance of diagnostic. So if the focus, and we have seen that rapid antigen was employed in large numbers in earlier stages of the pandemic, the low sensitivity. So what is the sensitivity of the test that also decides that what COVID-19? There always is a kind of chance of misclassification and window of detection. So if the person is tested too early or too late in the disease or in the course of the disease, then this chance of him wrongly classified as non-COVID case and subsequent deaths is much higher. And there are health system factors like what is the testing capacity of the system, or what is the reporting and recording capacity of the health. Burden of the health system is how much. At the same time, if the burden is too high, and then we might miss too many cases.
Rakesh, we're a bit over time. Could we summarize?
Yeah, I just missed. So again, I mean, I'll just skip this because it just tells us what is the kind of excess deaths are a kind of is being quite commonly used, and that comes from our and that has been routinely used in flu death estimation, wherein we look at the all-cause or respiratory mortality. So the drivers of, and I just want to focus on this, what are the drivers of all-cause mortality, excess deaths? So excess deaths can be because of increase in deaths due to COVID-19 per se or quality of COVID-19 care, reduced access to care, comorbidities, and mental health issues, wherein people with mental health might have depression or suicides that might lead to increase in death. At the same time, because of injuries or reduction in influenza or other transmissible disease, that might lead to decrease in deaths during that period. So, what proportion of excess deaths is COVID-19 depends entirely upon the interplay of factors. Levels of underestimation of excess deaths and different phases of the pandemic is likely to be different. So earlier phases where we have more testing, restrictions, etc., there is likely to be higher underestimation. Peak, we are not sure because even with high testing, but the delays and many left out or overwhelming of system, we might be not very sure about the kind of level of underestimation. But when the later phases of pandemic, when the maturation of testing system or the system copes up, so there are less chances of underestimation. So extrapolation of excess deaths estimated during a particular phase might lead to erroneous measures. These are some of the estimates generated by Institute of Health Management, Health Metrics and Evaluation. We see that the underreporting factors, they are something from 1.5 to 13 or even higher in certain countries. WHO has also generated some estimates, but because of limitations of data, they have not yet generated reasons except AMRO and European reasons. So what are the sources and what are the limitations of that data sources? Generally, we use a civil vital registration system, longitudinal household surveys, health and demographic surveillance sites data, crematorium and burial ground surveys, and a very innovative method of column in newspapers also been used for excess estimation. And I'll just skip that. Generally, we collect the data based on the historic death count. We forecast the expected deaths, and we kind of deduct that from observed deaths and generate the excess deaths using various statistical methods. But that is very challenging in the sense that what we see is that there's a very incomplete coverage of civil registration system. Then there has been some increase in number of deaths because systems improve over the years with increase in coverage, and mortalities are known to have seasonal and secular trend. So if we don't adjust for that, and what we see in this figure is most of the big states in India, especially in northern and eastern region, has poorer coverage with the death coverage. And as has been seen, and some commentators have kind of projected that if you use only the civil registration system, average of historic deaths, and look at the excess that might lead to erroneous estimation of. There are other challenges that, and there is a measure that data are not routinely available or accessible, even that is not being released, that is not being given. Timeliness of data collection, and that is a major problem with the sample registration system, where data comes much later than when it is required, and representativeness of the sample. So one is if sample registration system, if done in time, or if the data is made available in time and autopsy conducted under it. Sample registration system, as we know, is a representative sample of most of this country, which gives the data on vital events. So if that data is made available in time and autopsy is conducted in that can provide a more robust estimate of excess death and COVID-19 specific deaths. So to end, my take-home messages are that COVID-19 has taken a heavy human toll. However, the magnitude of it is still being debated. Official death count is an underestimate. Extent of it is hotly contested. Stage and context of pandemic is an important driver of underestimation. Availability and access to data are key barriers. Any estimates of mortality must be conveyed with the uncertainties around point estimates. That is the most important message, that most of the estimates have got significant uncertainties on the point estimate. While conveying that message has to be that this estimate has significant uncertainty. Thank you.
Thank you, Dr. Kumar. Let's switch immediately to Dr. Harshal Salve. Dr. Harshal, please go ahead.
Thank you, Dr. Gautam. And at the outset, let me first thank Indian Public Health Association and organizers of Iphacon 2021 for giving Minerva opportunity to host this very important plenary session. Like Dr. Rakesh said, that people see elephant from their different perspectives. So we also made our effort to see the elephant and estimate the excess, all-cause excess mortality in India in year 2020-21 in the selected district using our approach, using CRS data, that is Civil Registration System data. So in the Minerva, as I said, we have a 25 network partners. So with the help of these partners, we tried to attempt this study. So design of the study was a secondary data analysis of civil registration system. The pilot of this study was done in the district Faridabad, 2 blocks in the district, where total deaths registered in 2020 was 6,922, which was 7% higher than the average annual deaths of 2016 to 19. And it was, as expected, it was higher in the fag end of the age, that is more than 60 years of age. And 3 approaches, the historical average, forecasting, and linear regression was attempted, and all showed excess mortality in that particular pilot study. Then we decided to scale up this study in the entire country. So these particular graphs also showed in that pilot study that the weekly deaths were corroborating with the pandemic, in terms of the pandemic, how it is going on with respect to the cases and the mortality in particular blocks. So that was clearly visible in these graphs, which is again stratified by the age, stratified by the sex. The trend is visible. So in the current study, as mentioned in the introductory video of the Minerva, The chief registrar, through the chief registrar birth and date, director economics and statistics, the letter were sent through the network partners for acquisition of the data for almost covering all the states in the country. But so far we have received only data received from only 11 states and UT, and data cleaning and analysis was done. So these are the states which were covered in our analysis. So, and if you see, look at the CRS coverage in the selected states in our study, there it shows a fair amount of coverage except in the state of Nagaland. So these are the possible district level determinants which we have sort of compiled by doing a literature review and also by generating which is evidence which is available, and we are trying to get the information at the district level for all these parameters. We are attempting time series forecasting using analysis, using average deaths, linear regression, negative binomial regression, and ARIMA modeling. The upper bound and lower bound of expected deaths in 2020 will be established for non-injury deaths, and determinants of district level mortality rate will be identified and used to estimate national mortality. It is important to have information about the cause of death to really assess the non-injury deaths. That's what we have attempted. I will briefly show the preliminary result. It is still, let me put it at the outset, this is still a work in progress. And as mentioned by Dr. Rakesh in his presentation, there are a lot of challenges in the data itself and as well as the interpretation. So we are working on that. So we have received so far data from the 144 districts, and we have received a variety of level of data. For example, the detailed line listing of the deaths were reported only from the 27 districts from these states. The month-wise data we want from 28 districts, and year-wise we want 89 districts. So ideally, to have some robust understanding about the deaths, at least a line listing of the data set is desired, so that the daily sort of variation can be captured with the other parameters. So these are the 109 districts from 6 states we have analyzed in this particular study from the CRS. So this graph shows the comparative reported deaths from the CRS. The blue one, this is, we can see it, there is a, in all districts, almost the number reported in 2020 in the CRS was higher as compared to other deaths. We can just make out by the snowballing. So in this analysis, we have calculated the average mortality for last 5 years, that is from 2015 to 2019, and the excess mortality on the annual basis was calculated by sort of subtracting the average mortality from the observed mortality from the CRS. So this graph clearly shows that there is an annual excess mortality in the year 2020 in 143 districts, which we have done the analysis so far. And the quantum of it varies from district to districts. It is more to be seen in the districts which is reported from the state of Andhra Pradesh, followed by state of Jammu Kashmir, Punjab. So as I said, this is a preliminary analysis. The further analysis we are currently undertaking. Just to describe few challenges, there's a difficulty in acquiring desired data from the state authorities, as I've mentioned before, as well as there's a delay in availability of data. We are pursuing this exercise almost from last 5 to 6 months. There is a delay in getting the data, and obviously there's a questionable quality of data received. In the CRS, there are 2 parameters which are available as far as the death is concerned: the date of death and the registration of the death. So we know after working on the ground that there is a delay in the registration of death in the most of the places. So and for the most of the district, we do not have the actual date of death information. So we have to do with the registered death for the particular districts. So these are the major challenges which we are facing when we look into data of the district level. As I mentioned before, this is a work in progress. So we are attempting a regression analysis for understanding factors for excess mortality estimates. And also, as I said before, we do not have the information from all the districts in the country. So by using the information from these 100 odd districts, we are planning to estimate the state level and national level excess mortality in the year 2020-21 due to COVID-19. Thank you so much.
Thank you, Dr. Salvi. Thank you for that very nice summary. And I had actually just one quick question. Is the data complete prior to 2019? You have reporting from all districts before that period. The problem is only with 2020, 2021?
No, actually, there are two levels of problem. One is the process of acquiring data. It's a very sensitive data in the current context also. And we do not have any sort of year-specific issues. There is issues with the data collection, compilation, and the sharing itself. So as I said before, out of almost say 120 districts, we only got a line listing of the 25 districts. So line listing means we got each and every parameters for the particular person in that district. So this is the ideal data set which is required to do a sort of robust analysis and to really attempt a factor analysis for determinants of the excess mortality. And second important thing is the time component. As I said before, we are attempting a daily, monthly, and the yearly. So yearly is more a sort of crude way of analysis because there is a seasonality involved, as mentioned in the previous presentation, that pandemic also progresses over the year. And so there is actual seasonality that we are trying to also do analysis. So we need a data at least at a weekly or a monthly basis, though we are not able to get it successfully from all the districts. So these are the major challenges for the CRS data we are facing.
Thank you very much. So let me pass it over to Professor Krishnan to take over the second part of this.
Thank you, Gautam. Thank you, Rakesh and Harshal, for your presentation, which focused on how do you arrive at a number, right? At the end of those exercises, we would have got a number, or we would get a number sometimes in future, if not now. And as already Rakesh said, there are a lot of people who are trying to get some number there, right? But I think there are issues beyond numbers also. So in this next panel, we are going to discuss issues on what is termed as beyond the numbers, the politics of COVID-19 mortality. And to do that, I have three panelists with me. So let me introduce them first. The first panelist is Dr. Pradeep Kaur. She is a scientist at ICMR, National Institute of Epidemiology, and training in internal medicine and field epidemiology. She has done a lot of work. You can read what is written there. She's obviously an epidemiologist and a number cruncher, but she also works closely with the chief ministers, the state government, on COVID-19 control and also on other diseases. She's a principal investigator of the India Hypertension Control Initiative, which is trying to change the scenario for hypertension management in the country. She's also a member of the WHO Global Cervical Cancer Elimination Expert Group and a course coordinator for Field Epidemiology Training Program, NCD Track Fellowship of Epidemiological Intelligence Services, EIS, and she's a faculty for MPH. The second panelist is Rukmini. She's a postgraduate diploma in social communications media from Sophia Polytechnic, Mumbai, and MSc in developmental studies. She has won LICO Awards for Excellence in Media, as well as Chamili Devi Jain Award for Outstanding Women Journalist. She is currently an independent data journalist based on Chennai, and her work focuses on socioeconomic issues, including gender inequality, health, crime, and politics. Earlier, she was working with the Hindu as a national data editor, and currently columnist for Mint, India Spend, and occasional writer for other publications. She also hosts a pandemic podcast, The Moving Curve, and has written a book called Whole Numbers and Half Truths: What Data Can and Cannot Tell Us About Modern India. So she is very appropriate for the discussion that we are having today on data. And we are also joined by Dr. Anand Bhan, who is based at Bhopal and works with Sangat Bhopal as a consultant and mentor for the hub. He is also a physician with a master's degree from University of Toronto and a researcher in global health, bioethics, and health policy, an adjunct professor at NAPOI at University in Bangalore and Kasturba Medical College, Manipal. He's an immediate past president of International Association of Bioethics, and that's the area that he works on: ethics and equity in health, mental health, digital health, public health ethics, community engagement, and ethics of professionals as well as communities. So we have a very exciting panel with us, with very diverse and experienced, all working in this area. So let me start by, as I said, we will end up with some number. So what do we do with that number? How do we interpret that number? How do we understand that number? Before we go there, we all know that all pandemics would result in excess deaths. There's nothing so unusual about it, or for us to be really worried about it. And especially in a pandemic of this magnitude of COVID would result in excess death and far excess deaths, right? And knowing our health system, we expect that to happen. We also know that even before COVID, there were serious issues with our mortality surveillance system of arriving at cause of death, and both of these are very well known. Yet we seem to have a lot of controversies which are surrounding these areas of arriving at a cause of death. So my question to you, and I'm going to start with Pradeep, is that all these data issues, I think even Harshal referred to it as well as Rakesh referred to it in their discussion. Are this data access issue more of a systemic problem, or there are political sensitivities which are making us difficult to access the data? So Pradeep.
Yes, thank you, Dr. Anand. Thanks for the opportunity to share my thoughts on this very complex and difficult topic. I think as far as COVID is concerned, there is a combination of problems which have made it really difficult for us to understand the real picture of mortality. And as the speakers before this panel told very correctly, that there have been systemic issues. But what has happened during COVID is it's as though they all have now been exposed. For nearly, let's say in the last 2 decades, no one worried about it. No one cared whether we were collecting data in time, whether we were putting it out on a portal, whether we were sharing it. These issues were not so actively raised, either by the public health community or by the other stakeholders such as media and so on. Of course, there are few researchers like you who might have been working very hard, but if you say broadly, this was not a priority. So what happened during COVID is suddenly all these neglect, which was there for decades, came in front of everyone. And then we were surprised that why we are not getting good quality data. It wasn't a surprise at all if you have been working in public health and if you have worked on mortality. So I think I would say this not being able to get good quality data during COVID was not only COVID specific. It was a much broader issue, but it was further complicated by the fact that not just mortality data, but everything about COVID, whether you wore masks, who should get admitted, which hospital should be COVID or non-COVID. Somehow every decision related to COVID pandemic was either bureaucratic or politicized for various reasons. And mortality seemed to be just another one, which also got politicized. So I think what we should have done in the times of peace before there was a pandemic, we should have put a system in place where the officials have complete freedom and as part of their role as a district or state level manager, they put out data in the public which has basic characteristics such as age, sex, or district. And this particular activity should not have any interference from either politician or bureaucrats. If such a system was in place, it would have made life much easier for the officials to do it during COVID. So we really have a long way to go in making sure that we can draw a routine health system versus what should be determined by politicians. Thank you.
Thank you, Pradeep. That seems almost to be a dream, maybe, if you have a system like that. But we do hope that that dream is achieved. But Rukmini and then Anand, you have any comments on this?
If I can go first, you know, all of us who've interacted with Dr. Kaur would say definitely find that she's, you know, one of the bright spots and one of the exceptions to the sort of frustration that we feel sometimes with data sharing. Just broadly, I'd like to say, you know, and this is something I'll have more to say on later, which is that there has been an unnecessarily adversarial atmosphere, you know, a lot of defensive behavior, and perhaps similarly in peace times, if a culture of openness and you know, pushback against opacity could be established in peace times, then this won't be an entirely new sort of democratic exercise that we need to begin during pandemics. So you know, even this sort of discussion between the medical, scientific, journalistic community, even these, of course, the next step being the bureaucracy and governments, it would be great to establish these in peace times as well. And just, you know, about the word politicize, I think there can sometimes be, you know, politics is often seen as a bad word, you know, which muddies everything and spoils everything. But I do also feel that a lot of the positives and the, you know, the most brave and novel steps that came out during the pandemic have also come out as a result of politicians taking decisions as well. Bureaucrats, those in the scientific community, but politicians as well. So, you know, politicize can mean good or bad things. It's not necessarily a bad word in this context.
Thank you, Rekrumin. I will take that up again subsequently. But before that, Anand.
Yeah, thank you, Dr. Krishna. Pleasure to be on this panel. So, you know, just maybe taking on from what we have already discussed, one of the things which is something that we should keep in mind is if we all recognize that there were problems with the data and there have been historical issues, we've also landed up in a situation where at certain times we seem to celebrate data when it is politically expedient to do so, and yet at the same time we don't recognize that there are problems with the data. Right. So I think part of being honest and transparent is to say, yes, we have a certain data set, but it might not be perfect. But we seem to celebrate data when it suits us, when it's showing a certain positive lens to the pandemic response, and discredit data when it is not doing that. So I think that is where that dissonance clearly becomes possible. You know, it is something in public debate also you start to see, and that is where I think the problem is. If, you know, if we all acknowledge that there are problems with the data which are pre-pandemic in nature and we're trying to fix it, then I think there would be certainly a more nuanced understanding of what the issues are and how we're trying to sort it out. So again, it goes back to that transparency question that, you know, can you leverage data to suit political needs at any level? You know, this is not specific to a particular government. This has happened at both central and state level and perhaps even at sub-state level. So I think that's certainly something as public health professionals we need to reflect on, because in the absence of good quality data, how do you take decisions? You know, that's going to be extremely difficult.
Yeah, thank you. I think we come back to politics, but public health cannot be diverse from politics. They have to go hand in hand, right? And originally, at least, we used to feel that science and data is when we compare science and politics, we all are scientists. We feel that science is more important than politics. But perhaps for public health, politics is more important than science. But coming back to the issue of politics, and as Anand said, it is not just, it's all governments. Politicians are of similar nature across the globe. It's not even just an Indian issue, it's across the globe issue. But are scientists and journalists guilty of fanning the fire in a way that we come up with so many estimates? Rakesh showed there are different estimates. Everybody gets confused with those estimates, and we don't necessarily have to blame politicians for it. If you give so many estimates, each of them, then they are going to choose what is convenient to them, right? And so have we muddied the waters? And to some extent, I wrote in many of the newspaper columns about this estimation of excess mortality, and that got picked up. And then we had a almost statewide or district-wide publications in newspapers on mortality. Have we confused the two things? Have we confused politician, or have we unnecessarily sensationalized because the issue, which makes the politicians more defensive on this score? So Rukmani, why don't you start with this, and then we'll go to Anant and then to Prabdeep.
So typically, I'm first in line to criticize my profession and many of its practitioners. But on this specific issue, I'm largely going to push back against the contention that journalists erred in putting out mortality estimates, while acknowledging that a lot could have been done better. I also want to reiterate that I come from a place of not intending to be adversarial for the sake of it, but when it comes to a point that the media questioning the government or pushing back against a narrative results in the government being defensive rather than choosing to engage, that is not on the media, in my opinion. Lastly, I do want to touch upon how different stakeholders can come together in cases where collaboration is warranted. So if we just start with why it is that the media began to come up with mortality estimates at all. As has been mentioned before, India went into the pandemic with a death registration system that captured only 92 of every 100 deaths. And in states like Bihar, just half of all deaths even now are captured. So we knew going into the pandemic that many deaths will be missed, whether from COVID or not. That's sort of where the questioning began. Of course, some of the questioning or some of the issues are not are new to the pandemic and are specific to the pandemic. So we know, for instance, that while the Indian government's official guidance for recording COVID deaths says that even if a person dies without being tested for COVID or had tested negative but displayed symptoms, it should be classified as a suspected or probable COVID-19 death in line with the WHO codes. But we know for a fact that this did not happen. Suspected deaths were not officially registered in any state at all. We also know that these state audit committees were set up in various states, and the issue of discounting comorbidities and filtering these numbers, we know that this is one of the things that came up. So I just want to reiterate that this sort of questioning and skepticism came from very real instances of what we were seeing on the ground. Despite this, the focus remained firmly on case fatality rates. And this number was then used to repeatedly make the claim that India was doing much better than other countries. And while there should have been some questioning around why we were seeing exceptional data, instead a narrative was sort of built that India was exceptional. And then from sero surveys, again, there was early indications that something unusual was truly going on, because we knew that the infection fatality rates that were coming up through looking at the Indian data sort of defied belief. And then the second wave hit. When the second wave hit, the disconnect between what was going on in homes and communities and between what the official data was saying just became too stark to ignore any longer. So journalists who knew their cities or their communities well began to push back against these official death tolls by looking at crematoria, at burial grounds, and what they were reporting was that several times the number of the official counts was what they were seeing on the ground. Journalists who went to rural India were finding a sort of spate of unexplained quote-unquote fever deaths that were being reported, that were people who were untested, often untreated, often dying at home. And all of this gave impetus to journalists to think of ways to come up with better data that could do a better job of capturing what these journalists were seeing on the ground. At the same time, journalists began to see the work of journalists and the scientific community in other countries, including in the UK, in South Africa, and in Peru, and we began to first sort of pay attention to excess mortality. Now, I, for example, had assumed that the civil registration system was closed and that this was not going to be possible to access at all. But when I realized through sources that state-level portals could be accessed, this is what I began to do. And I'd like to think that my reporting was clear that this data was not perfect, that this is what the data could and could not say, what the shortcomings of the CRS are, and how these are not direct estimates of COVID mortality, but of excess mortality. And I think what happened after that is a sort of domino effect and a very sort of public-spirited, collaborative environment in which journalists from across the country tried to do similar work in their own states, in their own districts. I'd particularly mention journalists from the Hindu newspaper who've really, taken the baton and run with this, getting estimates from across the country. I also looked at indicative data from the NHM, which could indicate excess mortality from rural India potentially, although this is not a typically used source for COVID mortality. The national estimates on the whole came from the scientific community, as has been shown previously. Most journalists would not consider themselves equipped to come up with national estimates. We reported what we saw. And similarly, other estimates from the scientific community came by using surveys like the CPHS or C-Voter. So why was there this big range of estimates? Because in the absence of definitive national CRS data or a definitive national survey, there will be as many estimates as there are approaches to estimating mortality. Unfortunately, the government did not engage with these estimates and instead got defensive and pushed back while still not offering any data of its own. Throughout the pandemic, except for some notable exceptions, the media has been hamstrung in its reporting by a severe lack of open data. As you know, even now, 20 months into the pandemic, we still do not have an official website with data, and we rely on a volunteer-run effort.
Padmini, we'll have to go ahead in this last couple of minutes of maybe one more minute.
Sure. So we have been hamstrung by a severe lack of open data. A first step towards creating trust between stakeholders would be greater openness, especially in quote-unquote peace times. In the case of mortality, if the government is able to take into confidence journalists, those in the medical and scientific community, to present the data that exists alongside its shortcomings, we too will be better equipped to report it in its proper context. Certainly, journalists can and should do much better. They can talk to experts to better contextualize their data. But whether presenting too many estimates was a problem and muddied the environment, I would say not presenting data was the problem. Too many estimates was the sort of collateral damage.
Okay, thank you there, Padmini. Anant, you want to give your thoughts on this?
Sure. So I think, there's a lot of professions which are guilty of excesses during the pandemic, and maybe the media profession is one of them, but certainly not the only one. That also extends to probably all of us in public health, politicians, and a whole lot of other professions. I have to say that, we have to be very proud of our media colleagues. I mean, they're a fundamental pillar to our society, and they have been extremely brave in their reporting, and also at great personal risk often. It's also true that many journalists often function independently without even access to basic risk protection, and yet have brought us stories which show us the real face of the pandemic. In public health, we talk usually at sort of macro level numbers, but every single death matters. It matters to the family. To understand what is the true human face of the pandemic, the indirect deaths which Rakesh was alluding to, we certainly need our media colleagues to step up. But of course, it could have been, we can always do a post-mortem of even the way reporting was done. Should it have been more sensitively portrayed? Was there a need to be as inclusive as sometimes the portrayal ended up being? Of course, those are all things to think through, but I don't think without the kind of coverage that we had from the media, we would have had truth play out. And that's the important role of the media, speaking truth to power. And we should certainly learn from that in the public health sphere as well. Thank you.
Thank you, Anant. Any thoughts on this, Prabdeep, on how to improve trust and transparency? That seems to be the crux here.
Yes, I think going back to what Rukmini said, I mean, there was definitely a kind of race in various journalists trying to get ahead of each other and publish some sort of estimates. And although few pieces were done with a lot more technical understanding than others, what possibly could have helped the quality of reporting is better interaction between media and public health experts. And if that did not happen, again, I think both sides are equally guilty because these relationships need to be built in, again, times of peace. You do not expect people to suddenly start trusting each other if you are interacting for the first time during a pandemic. In my personal experience, since I did a lot of media interactions all through the pandemic, I felt that every time I got a call from journalist I already knew, I was more comfortable sharing my real ideas than somebody whom I was interacting for the first time. So I think there was a mix of problems. If public health community would have come forth and said more openly that, look, excess mortality is happening all over the world, it's not something unique to India or unique to this pandemic, then there would not have been so much of sensationalism around it. There would have been a sense of acceptance that, okay, it's going to be there. We don't know how many times. The problem is because there was no effective communication, I would say, from the public health community, which told every other stakeholder, which includes community, politicians, and everybody else, that look, this is a problem, and we do not have answers, but we do know there is going to be excess deaths. And then also maybe a little bit more information could have been shared on why this is a challenge, even for the health system. We know that there were panels being set up, and this whole process could have been a bit more transparent, saying that, look, we have set this panel up and they are reviewing this kind of data. However, we do understand that, we may not be able to come up with the very perfect answer. Then things would have gone in a different way. However, I think now we can discuss and do a postmortem of all of that. But I think going forward, I would say that much more structured interactions between the health departments, public health experts, and media on an ongoing basis, not only at the time of pandemic, and maybe a culture of publishing and sharing data, not just because it's a pandemic, but even in other times, on other issues which are of public health importance, because we know even when there is no COVID, there are many other health problems which are causing large number of deaths. So building this into a sort of a more open culture would really help us going forward, and it would have avoided a lot of problems which happened in this time. But I would like to conclude by saying that media did play a very important role in making public aware that this was a pandemic or this was a disease which could cause deaths, which could cause excess deaths. Otherwise, I feel there was a very low risk perception among many people, and they felt that COVID was nothing. It was just a cough and cold. People were not willing to get tested or not willing to wear masks. So this data did definitely increase awareness among public about the serious nature of this pandemic.
Thank you, Prabdeep. And I apologize to Rukmini. I think I called her Padmini somewhere along the line. So my apologies for that. Going next, I think we all have been obsessed with getting some numbers there, right? We'll end up with one number, maybe with a range, as Rakesh said. But does that number really matter? Unless we really look at how that number is distributed among various subgroups. How many men, women, and as Anand said, a human face to that number. Look at equity issues without understanding equity. And I personally feel that equity has to be a center stone for any public health activity. So in our obsession with the number, did we really not use those numbers for promoting equity? And I'm going to ask now Anand to start with this comment on this, and then to Prabdeep, and then Rukmini.
Sure, no, I totally agree with you. I think equity is fundamentally important. I mean, you can have a set of numbers, but how you interpret those numbers is what is finally important, right? Because you could you tweak the same data, you can massage the same data in many ways. But what is really important to understand is how does any event, including an ongoing event like a pandemic, impact communities and population subgroups as well? Because it's likely that if you have an equity lens, and if you truly look at the data from that lens, that you would better understand how does any such ongoing pandemic impact those who might be particularly at higher risk. So, for example, also from a time constraint period, if you look at lockdown and what it meant for communities which were probably more informal in nature from a socioeconomic perspective, then it would help us better know from a policy perspective, how do we better prepare so that the next time if such an event happens and we decide to go in for a public health measure where there is a liberty restriction, then what do you need to do to be able to meet their needs so that you don't see the kind of a human tragedy we saw early in the lockdown period where there was mass migration for economic reasons. It's also important because at the end of the day, policymakers want to make decisions based on gross numbers, but also data. So unless you tell them that the pandemic is impacting certain communities in certain ways, that kind of a change is not going to happen. They're not going to believe you when you say that a lot of people who are of a particular kind might not be able to access, say, vaccination. because they might not have identification papers. But then you show them the actual numbers, and these are all people living in the country for whatever reason, then perhaps they would take it seriously and try to help facilitate ways of making vaccination available in an equitable manner. Because at the end of the day, it shouldn't matter what person is there, because from a public health perspective, we want to maximize our coverage. And so everyone should be having access to vaccination, just as an example. You know, we've been working with now for a few months with the transgender community, and our own understanding of the challenges that they faced pre-pandemic, during the pandemic, with accessing vaccination, and already with the with the ongoing issues they have with stigma and lack of access, availability, and how it gets compounded during a pandemic, has been a steep learning curve for many of us. And it just shows you that if you have an equity lens, and when you actually have those conversations with the communities, you better understand why that is important. And at the end of the day, I think one thing I've learned in my own professional growth is something from the disability sector, which is nothing about us without us. And that means that this is not something for us to think as experts. You know, we really need to get those communities on board in those conversations. They need to be co-creators of some of that knowledge. They need to be involved in the way we dissect the data, and they need to be on board in terms of a transparency perspective as well, in knowing how we are going to plan to respond to those. So that if we really look at it from a public health perspective, when we start talking about prevention, promotion, access to treatment, support for people to be able to adhere to either public health measures or treatment measures, then you truly need to work with them. And that is where I think, at the heart of good quality public health is that trust and bond that we create with the communities, and that would require us to work with them. So I totally am with you that equity is important, and I hope that we can create those spaces within the public health profession, and hopefully IPHA can keep that as one of the centerpieces in the way it takes its way forward as an association. Thank you.
Prabdeep, you want to go look at mortality data and how disaggregated is it or not disaggregated it is?
Yeah. It's a very important issue, and I completely agree with you and I mean everybody else on this issue. And if you look at data that was coming from many other countries, it clearly showed that deaths were higher among people from certain racial groups or people living in certain parts of the cities. And even in our own experience in the early parts of pandemic, as you know, I was in a metropolitan context. I'm saying metropolitan city context. We saw that actually the epidemic was not equally affecting every part of the city. The earlier hotspots were slums. There were people who had relatively poor access to care or poor awareness, or were not willing to always reach out for help for various reasons. And if we could have, from the early stages, looked at our data by all these variables, stratified by like the deaths, where they were occurring, and who were the people who were affected more, we would definitely have got much better understanding of where we should be focusing. And in that, one important thing which I observed during my field visit was also, we have really not understood COVID pandemic in the rural India at all, because we never disaggregated our data, whether it's case or deaths. And a lot of the COVID which happened in rural India was never diagnosed as COVID. And if you talk to health workers at the grassroots level, or if you talk to even clinicians, they will tell you that these were the patients who were coming to them much later in the course of disease with the respiratory symptoms or fever. And many of them tested negative, if at all they reached the hospital, or even if by the time they came, it was sort of too late to test them. So I definitely agree with you that, we should have actually looked at data beyond just COVID deaths or, just COVID. We should have looked at, as we say in epidemiology, time, place, person, and going into that place and person characteristics of this information might have even changed our narrative about this pandemic and the way we managed it over time. And one thing I want to just end up saying that, what I found most difficult to cope as a public health professional was the fact that we talked so much about deaths, that people were actually becoming numb about it. I remember having conversations with people, and there was a point when people just didn't make sense of those numbers anymore. So I think that was maybe the one of the most worrisome things, that we just completely, lost understanding of what we were going through. And as there's a famous quote that single death is a tragedy and a million deaths is a statistic, I think we must remember that these were lives we lost. And whatever learnings come out of it, we should make sure that such a thing should never happen again. Thank you.
Thank you, Pradeep. Last thoughts, quick thoughts from you, Rukmini.
Yes, I'd just like to, add to what Dr. Pradeep is saying, to also bring back the point that rather than think of the equity lens as something that is beyond numbers, I'd actually like to think of numbers as a way to bring equity back into the conversation. So just as the sort of, research that Dr. Salve mentioned that they are doing, bringing in other determinants, including age and sex, into the disaggregation of mortality. Similarly, better data would be able to tell us the true cost of the pandemic that, just as Dr. Pradeep was describing, we might well have missed. And once again, I feel that the mortality numbers were in a way able to bring the equity conversation back. When we had district-wise data for states like Madhya Pradesh, for example, that data was able to push back against the narrative that COVID largely only affected urban areas, because we saw huge increases in excess mortality in the rural districts as well. So, I see data as a way to bring equity back into the conversation rather than something that needs to be moved past to bring in the focus on equity again.
Thank you, Rukmini, for that. I agree with you. I did not mean that equity. I'm a strong proponent that data should be used to promote equity. But we are over time now. Gautam, your remarks on whatever we discussed during this last half an hour or so.
It's been a fascinating discussion with sort of multiple perspectives on this. I personally think that the journalism around excess deaths was very important to me personally, just to get a sense of the scale that was involved. And as Rukmini pointed out, exactly the difference between rural and urban India, how large that could potentially be, in the fact that there was serious undercounting going on, was very significant to us. As a modeler, many of us made a mistake of assuming that you cannot really undercount deaths because these are, after all, bodies in crematoria, etc. But so the extent to which they could actually have been undercounted in the data-driven journalism that many people, the Hindu, the Reporters Collective, Rukmini, etc., many other groups did, was actually an eye-opener from that point of view. One last point relating to something that I think that Rukmini said about the importance of politics. I mean, politicization, we look upon it as a bad word, but political activity and political involvement is in a sense fundamental to our society. And to understand what drives political processes, to understand what drives politicians to do the good that they can in the position that they are in, I think is important. And I would sort of hope for more clarity, more data. I would like governments to hold data transparency at a high level, and for state governments to compete with each other on the quality of their data. I think that would be a good end. We should not have to file an RTI to get information that really ought to be in the public domain. So that's all I had to say. Go ahead, Professor Krishnan.
Thank you, Gautam. Thank you, all the panelists. I think we made very clear that the data transparency is perhaps the most important thing, and we should be investing in that. Government should be encouraged to make data more transparent, so that scientists and journalists can use it to tell stories and be more forthright in your communication, build that trust and transparency. I think we come to that as key issues on any public health matter. COVID mortality is just one issue, but for any public health matter, we need access to data, transparencies in communication, and trust between all of us. On that note, I thank all of you, and it has been a wonderful experience having this discussion and having both science and politics and social sciences as a part of our team. Thank you very much. Bye-bye.
Thank you.
Thank you. So now we will take up some questions, and I see that there is a question in the chat box, which is aimed at you, Rukmini. Are you there, Rukmini? It's asking about.
I don't see Rukmini joined in, sir.
Okay, newspapers publishing about vaccines harm. And should newspapers be more responsible, socially responsible when they publish anything? There is no other question here. Are there any other questions which anybody wants to ask?
We have not got any questions from the chat box now, sir. I think we are 3 minutes over time, but we started on time. We'll wait for 1 or 2 quick reflection from the chairpersons. Otherwise, we'll close the session with your permission.
Sir, there is a question in chat box. Please check.
No, that was taken. That was not those 2 questions.
Yeah, so nothing. I think I enjoyed the talk, the questions and the way the people responded to it. Overall, it's a very critical area, and I think the points that were made about all being socially responsible, but also the need for data transparency, access, and more communication between all parts of the government as well as communities and scientists. I think that's the crux in getting whatever issue you're looking at. If you want to get good results which are used for policy making, these things are prerequisites. I think with that, I will close my comments. Thank you for giving this opportunity. Minerva is very happy to partner with IPHA on this. Thank you. Back
so
to you,
much.
Satanshu. Yeah.
Thank you so much, sir. The session ended in time, and we thank the chairpersons, Dr. Anand Krishnan and Dr. Gautam Menon, for conducting this session very efficiently. I also thank the speakers, Dr. Harshal, Dr. Rakesh, and the panelists, Dr. Pradeep, Dr. Anand Pan, and Rukmini for doing such a fantastic job. Thank you so much. Now we'll move on to the 4th plenary session. Thank you so much. I now request Dr. Stuti to come over and take it over from here. Thank you so much.
Hello, Dr. Rakesh, and I can also see Dr. Gagandeep there. Hi. Just my hello to both of you.
Yeah.
Hi, Anand.
Hi.
Long time no see.
Yeah. I think we'll end it back to Stuti. I think we are not, we can have our own chat later on. Yeah.
Yes, very good afternoon to everyone, and welcome to IPHACon 2021. So now we move on to a rather pertinent topic of discussion in today's era. So that is allocating scarce COVID-19 vaccines based on cost effectiveness evidence in India. And I'm very pleased to invite Dr. Hiral Shah and his team for this plenary session. So Dr. Hiral Shah is a senior policy analyst at the Center for Global Development, London. Can we have the screen? So Dr. Hiral Shah has completed his master's from the London School of Hygiene and Tropical Medicine and holds a doctorate from the Imperial College London. And he's a health economist by profession and is interested in areas like cost effectiveness of pharmaceutical products, medical technologies, universal health coverage, environmental and economic interventions. Prior to working with the CGD, he has also worked as a scientific advice program advisor at the National Institute of Health and Care Excellence, and has also been affiliated with institutes like PHFI and Sigma in the past. So with this brief introduction, I am very pleased to invite Dr. Shah and his team to take over from here. Over to you, sir.
Thank you very much, Stuti, and thank you very much to the conference organizers and Dr. Sitanshu. And a warm welcome to all of our delegates to the conference and plenary number 4. I'm just going to share my screen, and Stuti, please let me know if you can see my screen.
Sure. Yes, I'm able to see your screen, sir.
Yeah, and
yes,
you can see the presentation. Yeah.
Yes.
Fantastic. So just bear with me. So as Stuti mentioned, we're going to be focusing today on allocating scarce COVID-19 vaccines using cost effectiveness evidence in India. And this is a multidisciplinary sort of collaboration that's been generated between the Center for Global Development, which is the Secretariat for the International Decision Support Initiative, the Indian School of Business, and Imperial College London. And for those of you who don't know what IDSI is, it's a global network working to increase the value and impact of health spending. And the idea is that we believe everyone should have fair access to health, receiving the right treatment and the right medicines at the right time. So the aim of the session is really to focus on a welcome and introduction by myself. We'll be then presenting novel results for a study we have conducted, and then we'll go straight into the panel discussion with a Q&A afterwards. There are some Twitter handles over here, and so please do tweet away if interested or if you find anything relevant as well. And so I'd like to warmly welcome our discussants to this towards this plenary as well. I mean, many of these are distinguished speakers already, and many of you who will know who these speakers are already. And for those of you who don't, we have Dr. Rakesh Agarwal, who is the director of the Jawaharlal Institute of Postgraduate Medical Education and Research, and who will be chairing this session. Dr. Rakesh is a leader in many different disciplines, including vaccination, epidemiology, biostatistics, health economics, and is also elected as a fellow to 4 different national academies. We also have Dr. Gagandeep Kang. She's professor in the Department of Gastrointestinal Sciences at the Christian Medical College. And she also directs CMC's Wellcome Trust Research Laboratory. Dr. Gagandeep is the first Indian woman to be elected as a fellow of the Royal Society, and throughout the pandemic has been a voice of reason and science. We have Dr. Javier Guzman, who is the Director of Global Health and the Senior Fellow at the Center for Global Development. He's been previously a technical director at the Management Sciences for Health and played different roles within the Colombian government too. His main interests are in global health challenges such as COVID and how it can offer a window of opportunity to improve the efficiency and effectiveness of global institutions. Fourthly, we have Dr. Rajesh Kumar, who is a technical advisor to the government of Punjab and previously an executive director too. And he previously held positions as head and dean of community medicine in PGI-MER in Chandigarh. Professor Rajesh has a vast experience in epidemiology and public health, apart from being an academician. And finally, we have Dr. Debashree Bhattacharya. He's a senior program officer and lead for state health systems at the Bill and Melinda Gates Foundation. He's been a focal contact for the COVID-19 response in Bihar, and he was previously chief operating officer and corporate treasurer at Access Health International. His main technical specialities include healthcare policy and health financing and public health management. And so the last session obviously provided a fantastic backstory towards what's been happening with regards to COVID-19 in India. And so, you know, everyone's seen these curves before where we have the first wave and the second wave. But you can also see that vaccination rates for India in comparison to other countries is actually much lower than what it should be. And, you know, there's potential reasons for this. You know, the potential reasons, obviously, there's a low supply of vaccines, there's potential resource capacity constraints, you know, transport, cold storage, vaccinators, but also how feasible is it to achieve 75% coverage across the Indian population? And so, you know, there's a pressing need to vaccinate those most at risk, but until today, there's only been around 15% of the Indian population that is fully vaccinated. Now, across the world, many people are coming up with potential solutions to this. We've heard talks about fractionated dosing, you know, where you half the doses, dose stretching, so you increase the time between the first and the second dose, using seroprevalence to inform vaccine allocation. So, you know, do you allocate vaccines to low seroprevalence areas or high seroprevalence areas, or do you do uniform vaccination, the same across both areas? And of course, other ideas are welcome as well. But there's a problem of scarcity. So there's obviously limited resources within a government, and there's unlimited wants. You know, which do you prioritize? Do you prioritize the vaccine A over vaccine B? Do you prioritize urban areas over rural areas, high seroprevalence areas over low seroprevalence areas? You know, how do you choose between what wants you want at the end of the day, but given your budget? And that's where cost effectiveness analysis comes in. And this is a central tenet in health economics, which looks at two choices, an intervention and a comparator. And it calculates the cost of the intervention and comparator and the health gain of the intervention and comparator. And it calculates what's the cost effectiveness of the intervention in comparison to whatever's happening right now. And the sorts of questions that can be answered for cost effectiveness include, you know, should you be rolling out the vaccine to the elderly or to school children? Basically, which risk groups do you vaccinate first? Another one could be, do you use the Pfizer vaccine or the AstraZeneca vaccine to cover the population? And the one we're most interested in at the minute is what's the most cost-effective way of vaccinating or conducting a vaccine program. It's the modality, what's the most cost-effective modality of distribution? Do you target urban areas or rural areas, hotspot areas or low immunity areas? And what about the supply and capacity constraints involved with the supply chain? Do you need to buy more cold storage, or do you need to mobilize resources or not? And so with that instance, we came across this research question and study and developed this novel collaboration, which focuses on quantifying the cost effectiveness of seroprevalence informed COVID-19 vaccination strategies in Punjab, India. The speakers today are Dr. Shripad Devarkar, who's an associate professor of operations management and research director in the Indian School of Business. He's interested in operations and supply chain management in emerging economies. And with this interest and substantial experience, Shripad has been a focal lead on COVID-19 supply chains in India. And we also have Dr. Nimilan Arina Minpathy, who's a professor in mathematical epidemiology at the MRC Center for Global Infectious Disease Analysis at Imperial College London. And his major focus is at the interface between health and economic systems and infectious disease, and has conducted extensive work in tuberculosis and also now in COVID-19 in India. And the main research question of our study is what is the cost effectiveness of vaccination strategies that are dependent upon known seroprevalence in urban or rural areas after the first wave in order to reduce the magnitude of a second wave in Punjab, India. The approach we take is we integrate supply chain modeling with epidemiological modeling to estimate the cost effectiveness of different modalities of distribution. And without further ado, this presentation will be based upon this sort of theory that we have, this approach, where we will first focus on the supply chain results and modeling, and then we'll focus on the epidemiology and cost effectiveness modeling. And so without further ado, I would like to hand it over to Dr. Shripad to begin.
Thanks, Hiral. So as Hiral said, there are two components to the overall study. One is the supply chain model and the other is the epidemiological model. Just to underscore the need for a supply chain model, let's consider, let's say, implementing a low seroprevalence first strategy, in this case, for Punjab, given the seroprevalence measured at the end of the first wave, that would be the rural areas. Now, implementing such a strategy would mean directing the available supply first to the target population in rural areas before using that supply to vaccinate urban areas. However, having a given amount of supply of vaccines available does not necessarily guarantee that the rate of vaccination will be the same as the available supply. And this is because delivering the vaccines requires various resources, including cold storage resources, human resources, as that is the vaccinators and others. And how many of these resources are available and in what manner they are used has a big impact on the rate in which the vaccination can happen. So consider, for example, the case where the resources are currently deployed according to a certain configuration. For example, the resources are deployed according to how the routine immunization supply chain works today, in which case you would have a certain rate at which these vaccines can be used. And that rate may or may not be equal to use up all the supply that's available. Now, one could also think of using these resources in a different fashion, which is you might have varied usage of these resources, varied availability of these resources across different parts of the state. So for example, you might have more resources in rural areas compared to urban areas, in which case, if you were to implement a rural first strategy, then after the rural areas have been vaccinated, it might be better to move some of these resources from rural areas over to the urban areas to increase the capacity and therefore make use of the supply at a faster rate. Now, one could extend that idea to not just within districts between rural and urban areas, but also across districts if there is a considerable variation in the availability and utilization of resources across districts. And to be able to figure out which are the resources that are constrained and which resources need to be moved and what's a cost-effective way of moving these resources, having a detailed supply chain model is helpful. And again, just to reiterate the resource constrained nature, having a detailed supply chain model doesn't have much of an impact or a value if we were considering a scenario where they were abundantly available. But given what we know, which is the cold chain and the supply chain resources available for routine immunization in India are what are being used for delivering the COVID vaccine. And not just that, the routine immunization activities, at least the essential routine immunization activities, are continuing in parallel with the COVID vaccination campaign, means there is very limited resources available. And therefore, understanding how much of these resources are available for delivering COVID vaccines and what would be the optimal way of using resources becomes even more pertinent. So as part of developing the supply chain model in this study, it's broadly in two phases. The first is to estimate the total resources that are available and how what portion of these resources are utilized in the essential routine immunization activities today. And for this, we used publicly available data on the resource deployment and also discussions with key officers involved in the immunization programs, and developed a supply chain model to estimate the utilization of these resources today and the cost of delivering a dose of routine immunization. We validated the model that we developed by sharing these results with immunization officers who are involved in the implementation of both routine immunization as well as COVID vaccination, and also comparing our estimated costs of routine immunization delivery with the estimates published in the literature. In the second phase, we developed a supply chain model for delivery of COVID vaccines using the unutilized resources from the routine immunization supply chain structure. And with this model, we estimate the rate at which vaccines can be delivered, which is the number of doses that can be delivered per day, and the cost of delivering these vaccines under the different strategies and scenarios that I just described earlier. And some of the key assumptions that we make as part of developing the supply chain for the COVID vaccination is that in every session, one vaccinator can deliver up to 100 doses. And the target population is 75% of the total adult population in Punjab, which is about 2.5 crores of adults. So when we use our supply chain model to estimate the utilization of resources, what we find is there is a significant variation in, one, how the resources are deployed across districts today, and to what extent they are utilized for essential routine immunization activities. So for example, if you consider the ILRs that are deployed at urban cold chain points, you find that there are some districts where up to 80% of their capacity is utilized, while on the other hand, you also have some districts where they are utilized only up to the extent of 20 to 30%. What this suggests is if ILRs were to become a bottleneck resource, then there is potential benefit in moving some of the ILR resources from the less utilized districts to the higher utilized districts to increase the rate of vaccination. On the other hand, what we also find is across the various resources involved in the delivery of vaccine, there is considerable heterogeneity in the utilization of these resources. So what might be a bottleneck resource could be very different across different districts, and which districts need extra resources and of what kind is essential to try and improve the rate of vaccination and be able to get the best in terms of health outcomes in each of the vaccination strategies. And in addition to the vaccination resources, the other key determinant of the rate of vaccination is the supply, which is also constrained. And for our supply chain model, we used estimates that were publicly available and that we gathered in our conversations with policymakers. And what we understood was that in the months of April to June, there was constrained supply, which gradually relaxed. And since August onwards, there's been higher supply available. We assumed that the national level supply of vaccines would be allocated to individual states in proportion of the population in those states. And based on this, we estimated about 20 lakh doses to be available in each month between April and June. And starting August, that would go up to 40 lakh doses. And what we see here, the dotted line here represents the actual vaccinations that were conducted in Punjab in the months of April to August. And we see that our estimates track what the actual vaccinations were fairly closely with some temporal mismatches. And that's possibly because of the fact that there would have been a delay between when the vaccines were available versus when they actually got deployed. We also estimated the baseline vaccination capacity, that is using the RI resources that are currently deployed and are unutilized in the RI activities. If one were to consider the maximum possible rate at which vaccination can be done across all rural areas, across all districts in the state of Punjab, then one could achieve a rate of up to 43 lakh doses per month. And as you can see, this rate is higher than the estimated supply that's going to be available for the foreseeable future, which means when one were to implement a rural first strategy, it is unlikely that one would need to move resources from urban areas to rural areas. On the other hand, the urban vaccination capacity is fairly constrained, and at most about 17 lakh doses per month can be delivered. And in that scenario, if there are spare resources available in the rural areas, they could potentially be moved to urban areas to increase the speed of vaccination in the urban areas. A few caveats in terms of these vaccination capacity estimates that I'm showing here. One, our supply chain model is a fairly deterministic model. And what I mean by that is we do not account for variability in either in the availability of these resources or in the demand for vaccination, both of which would reduce the effective capacity. The other thing that we don't capture in our supply chain model are demand side factors. So for instance, we do not model vaccine hesitancy or effort involved and the same resources, potentially vaccinators, ANMs, having to undertake demand generation activities, all of which would end up affecting the actual vaccination rates and the actual vaccination capacity that might be available. Using these estimates of vaccination capacity and supply, this graph here shows the rate of vaccination over time, or the vaccination coverage over time under the rural first strategy. So the solid red line that you see here represents the percentage of vaccinated people over time, and the solid black line represents the percentage of vaccinated people in urban regions over time under the baseline scenario. That is, without resources being moved across different geographic units, how would the vaccination progress?
3 minutes left, Shripad. Yeah.
Sure. So as you can see, because there is enough capacity in rural areas, it is able to use all of the supply that's allocated, and we finish covering the rural population sometime in October 2021, if we assume that vaccination started in April of 2021. And the rural vaccination starts, urban vaccination starts after the rural population has been covered. And because capacities are constrained in urban areas, it takes up to May of 2022 to finish covering the urban population under the baseline scenario. And with aggregation, there is no benefit in terms of increasing the speed of rural vaccination. However, the urban vaccination can be speeded up by moving some resources from rural areas to urban areas to take advantage of the higher supply that's available, which reduces the time taken to cover the urban population from May to January of 2022. Similarly, when we look at the urban first strategy, again, you find that there is considerable speeding up of the urban vaccination because of augmenting the resources in urban areas. And instead of covering by October of 2021, we can cover all of the urban population by August of 2021 if we allow resources to be moved around. While aggregation or using the resources as they are does not affect by when the rural population gets covered, it does affect when vaccination of rural population begins, even under the urban first strategy. Without moving resources, because not all of the supply can be used in urban areas, you do find some rural population getting vaccinated alongside, whereas with aggregation, all of the supply is dedicated to urban areas first, and the start of rural population vaccination is delayed to August of 2021. And finally, under a uniform strategy where we allocate supply to both urban and rural areas, that is, high seroprevalence and low seroprevalence areas equally in proportion to their population, aggregation doesn't really make much of a difference because overall supply is constrained. And both of the entire target population is covered by February of 2020. The last thing that we estimate using the supply chain model is also the cost of implementing each of these strategies. And the key thing to note is there isn't a significant difference in the cost of delivery of vaccines. And we find that without accounting for the cost of the vaccine itself, the cost of delivering and covering the urban and rural populations is of the order of about little less than 100 crores. And aggregation adds a little bit of the cost in the urban and rural first strategies because of requirement of movement of resources, but that's about 3% of the cost when we do not allow resources to be moved. This concludes the presentation on the supply chain side. I'll hand it over to Nim to discuss the epidemiological model and the results.
Great, many thanks, Sripad. Can I check that you can see my slides and hear me as well?
Yes,
we can. Thank you. Thank you. So I should apologize first to everyone for having to leave the session a little bit early today. Unfortunately, I had an urgent commitment come up this afternoon, but very grateful to CGD for the opportunity to take part in this work and also to join you for today's meeting. So just taking off from what Sripad just presented, you saw some very nice scenarios just now for the potential supply of vaccine in urban versus rural settings. And so what we'd like to do is to take these findings and ask, what are the potential epidemiological implications of these different scenarios? And so specifically, we're interested in incidence and mortality reductions as a result of the vaccination program. But also when we include information about cost data, we can start to address questions about cost effectiveness as well. So I just wanted to remind you, in Punjab, in around August, September last year, the seroprevalence surveys that were done around the country, but also specific to Punjab, suggested that in the state, the urban areas had a seroprevalence of around 30% and rural areas a bit less at about 21%. And so these kinds of findings in this state and elsewhere, they kicked off a lot of discussion around how should vaccination efforts best be focused? I mean, should we be concentrating vaccine in future in rural settings, which have had less exposure in the past and therefore may be more vulnerable to a future wave? Or instead, should we focus vaccination efforts in settings with high transmission intensity, like urban areas? Because the argument goes that these are areas that have seen very large transmission intensity in the past, and in future, they may also be disproportionately affected. And so in this context, we brought together the scenarios that you just saw presented earlier and looked at the epidemiological impact of these different possible strategies. For example, if you were to prioritize rural areas because of low seroprevalence, or instead prioritize urban areas because of higher transmission intensity, or indeed just ignore seroprevalence strategies altogether and pursue what we call a uniform strategy, where you cover both urban and rural areas together with the same level of priority. So just briefly for those participants who are interested, this is a kind of model structure that we used. It's what's called a compartmental deterministic model. And basically here you see a model structure that's capturing the natural history of the virus. I won't go through it in too much detail, but the main thing I wanted to mention is that this is basically stratified by urban and rural settings. And we also take account of different age groups, the children, young adults, and the elderly, because of course, as we know, there's very different severity of infection across these different age groups. So just to show you some results very quickly, this is going back to the second wave and asking in the second wave, what might have been the effect of different vaccination strategies? And so along the vertical axis here is the daily symptomatic incidence per 1,000 population. And in the blue curve, you can see basically, this is a baseline scenario. This is what might have happened with no vaccination. And the colored curves basically show you the incidence curves under the different vaccine scenarios that I just described. And you can see, by and large, there isn't that much difference between them. And moreover, they're not actually exerting that much impact as well. So in the table here, what I'm showing you is the percent burden averted. So for example, a rural first strategy would avert roughly around 11.2% cumulative incidence, but with rather large uncertainty intervals. And overall, all of these strategies, they have roughly similar impact, around 10 to 11% incidence averted, and around 14% mortality or the cumulative deaths averted. And if you're wondering why the impact is relatively modest, it's useful to think about when the vaccination program actually began in earnest, and that's marked by this dashed line. And as you can see, because of the vaccine supply, the actual supply wasn't available until relatively late. And so the second wave of the pandemic was already underway by that time. And so whatever vaccination coverage we had was able to have some meaningful reduction in burden, we think. But clearly there could have been a more strong impact if the vaccine program had been able to start earlier. So this being a model, we can do the theoretical kind of exercise. We can ask, well, what would have happened if the second wave was timed later? If there were an additional month before the timing of the initiation of the vaccine campaign and the timing of the second wave peak. And this is a scenario that you see here. I won't go through all of these numbers, but just to take an example, the uniform strategy, if you compare the mortality that was averted, then having an additional month of vaccination before the epidemic could get underway, it would roughly double the impact that could have been had through the vaccination program. Now, when we want to compare the different strategies, this is rural first, urban first, or uniform, it helps to look across this whole spectrum of intervals between the vaccination start and the start of the epidemic. And so in this graph, what you're looking at is basically the different scenarios for the interval between the vaccination initiation and the epidemic. And so the further you are to the right, the earlier the vaccine is in relation to the second wave. And the vertical axis basically shows impact. So the larger this is, the more impactful the vaccination program is. And so these different colors are basically showing you the different strategies. So a red is showing you an urban first strategy, and blue is a rural first strategy, and a green is a uniform. I mean, if I were a policymaker looking at this, I would certainly favor the uniform strategy, because I would see that, if I were vaccinating early enough in advance of a future wave, certainly the green curve is having a higher impact than any of the other curves. If, on the other hand, I had a very late vaccination program, and that is down on the left-hand side here, all of these strategies are pretty comparable in terms of their impact. Any difference there is quite marginal. Sripad also mentioned the potential for aggregating resources. Here I'm calling it mobilization. And you can see here we can incorporate these as well, and they have some modest impact, but perhaps not a really driving impact in these results. So very briefly, Hiro mentioned at the beginning about cost effectiveness, and that's a quite important consideration. So what we were able to do here was to incorporate the costs of the vaccine program, as you saw in the earlier slides, but also including the cost of healthcare utilization, because for every case that you prevent of COVID-19, potentially you're also preventing the, excuse me, the costs of hospitalization, intensive care, and so on. And so we incorporated those in a simple way in this model too. So if you look at this slide here on the left-hand side, the vertical axis here is showing you an incremental cost relative to no vaccination. So everything that is on the positive axis is an additional cost. Everything that is in the negative axis is an averted cost. It is saved. And so this is these 5 bars are basically showing you the different strategies. And the blue is showing you the cost of vaccination. This is what Sripad showed earlier. Now you can see here these different colored bars that are pointing downwards. These are basically the averted healthcare costs. And remember, this is of hospitalization, intensive care, and so on. And so these are broken up by the different age groups, less than 18-year-olds, 18 to 64-year-olds, and over 65-year-olds. And it's quite interesting. This is for a vaccine scenario that's relatively late in the epidemic. But what we see here, and remember, this is around 10% reduction in incidence. What we see here is if you add up all of these costs averted, they're actually more than the cost of the vaccination program. And so overall, even this vaccination program with a relatively modest impact was able to save overall costs in terms of averted burden. And so you can imagine if you had an even earlier timed vaccination program that had a higher impact, the cost savings would be even greater than what we're showing here. So just in concluding, I should mention, of course, as we know, whenever we see model findings, there are limitations. We should never look at model findings as predictions, but really only as projections. They are basically projecting the best available evidence that we have, and of course, some assumptions as well. So a couple of factors that we haven't included here are, for example, vaccine hesitancy, that this was mentioned briefly earlier, but also, as we saw so tragically during the second wave, there were very real constraints on the hospital and oxygen availability. And these are not things that we're including in the current analysis, because we want to explore the full potential benefit of a vaccination program with a view to preparedness for future possible epidemic waves. But in principle, these factors would have tended to increase the lives saved by vaccination. Excuse me. And the other important thing is all the findings that I've shown you are really Punjab specific, and there may very well be other states where urban or rural settings might well be prioritized in a different way to what we've shown here. But really what we demonstrated is that it's not necessarily the case that we always have to protect the low seroprevalence areas. And in this case, a uniform strategy really worked best. So I'm just echoing myself here in the top point. But interestingly as well, mass vaccination could well be cost saving, even if it's implemented relatively late during a resurgent wave. But of course, early vaccination really pays dividends, and an additional month may have doubled the impact in this particular circumstance. So I just wanted to take a moment to acknowledge all of the different folks that were involved in this work, and perhaps we can bring the slide up again a bit later. But finally, thank you all very much for your attention, and I look forward to the discussions.
Thank you very much, Nim and Shripad, for fantastic presentation. And I think before we call on panelists, there's just one question that was posted in the chat, and it's asking about that obviously urban areas had a higher density and more cases and mortality. But is there a potential cutoff for seroprevalence where you can then postpone vaccines or not? And what are your thoughts on different seroprevalences in different areas? And I guess this question is directed to Nim.
Thanks very much, Kiran, for the question. So I would caution against this idea of cutoffs because I think every different setting will be rather different. What I would suggest is that there would be a need for a systematic modeling analysis, quite similar to the type that we've done for Punjab, but for different states, to be able to say, when you look at a certain circumstance in terms of the combination of urban and rural seroprevalence, what would be the potential optimal strategy going forward? So in short, I don't think there's a single cutoff that would apply across the country, but this kind of analysis could help for individual states. I hope that helps answer your question.
Thank you, Nim. I now call on Dr. Rakesh. Warmly welcome you to begin the panel discussion with our discussants, and kindly request if discussants can turn the videos on as well. Over to you, Dr. Rakesh.
Thank you, Dr. Shah. So I think we all heard the results. These are basically looking at two variables for vaccine coverage. One was the capacity of the health system in the urban and rural areas to store and deliver the vaccine, and the other was based on seroprevalence. Though, as has been said, just looking at seroprevalence doesn't mean anything, because with the same seroprevalence, what matters is the force of infection operating at that particular time. But let's look at these results and see what they mean. May I call upon Dr. Rajesh Kumar, because I think he was a part of the whole group, and he has been active in guiding the response of the Punjab state, what he feels about this and how this would have been helpful if we had known this in advance. Dr. Rajesh, please. I don't see him. It seems he's dropped off by maybe. Oh, I see him there. He's there. Dr. Rajesh, please. Okay, if we don't have Dr. Rajesh, Gagandeep, would you like to take up this question, Dr. Kang? What do you think? How this data you help?
So thanks very much for both of the presentations. You know, actually, we were involved with Dr. Rakesh Kumar in deciding a strategy for Punjab. And the strategy that we came up with when there was a limitation in the supply from 18 to 45-year-olds and a separate set of vaccines available for the over 45-year-olds. The practice that we adopted was actually to look at the mortality that had occurred in urban and rural areas of different districts of Punjab. And then we looked also at the number of cases that were being reported from each region. We didn't have access to seroepidemiology data. It was a much more urban focused strategy because that's what we were going with in the absence of modeling data. And unfortunately, it has not been possible to measure the impact. Otherwise, looking at the data that has been, or the approach that has been presented now, we could have had a validation of the predictions of the model, because post facto, seroepidemiological data from Punjab are available. And I see that Dr. Rajesh Kumar has said in the chat box that he is on and he needs to be allowed to speak and unmute.
Thanks, Dr. Gagandeep. Yeah, Dr. Rajesh needs to be allowed to unmute himself. Can the organizing team please do something?
So we have granted access from our side. Could you please retry?
Dr. Rajesh, please.
I send him message to on video and sound, but I think he's not available on seat.
No, he's okay. So in the meanwhile, Dr. Devarshi, can you say, how you would look at these data and how these would be useful to you in terms of prioritization?
Thank you, Dr. Agarwal. And I will take the perspective of, or rather, an operational perspective to this, and typically how the bureaucracy and the political leadership or the policy makers would look at it. And again, from a vantage position of a state like Bihar, where not only the vaccine supplies, but even the regular infrastructure and human resources are scarce as well. So from that perspective, I think there is some merit after all in an otherwise negative sounding adage, which is when you have a hammer in your hand, everything looks like a nail to you. In this case, states like Bihar, I reckon even other states, other North Indian states, which have poor infrastructure, don't actually have a choice of prioritization. And I think the idea with the policymakers has always been to go with a uniform strategy. It is that choice really is not there for the policymakers to make. Having said that, I think this kind of analysis would help the policymakers to prioritize areas based on perhaps a few other kind of filters, not necessarily just urban, rural, or age-wise. And one of the things is also not to look at the population in a static manner, because these poorer states always have a more moving population, a migrant population. So just if we can actually foresee where the population would be or where the people would move seasonally or because of other reasons like the seasonal disasters which keep happening in places like Bihar. We all know that, either it's a drought in the summers or it's always, a full region is almost always flooded every year. So there is even intra-rural movement. People move out of places like Bihar to go to other states, etc. So can we actually model out where people will be in a few weeks or months and then decide the vaccination strategies accordingly? In states like Bihar, again, we see even the private infrastructure, public as well as private infrastructure, is also concentrated in certain pockets. It is not divided or distributed uniformly. So can we actually, the policymakers have that perspective or have at least that choice to make on which regions to prioritize based on what are the facility infrastructure available should things lead to such a higher or more serious levels. So I'm sure that, while at the end of the day, there aren't too many choices available to the policymakers, but at least analysis like this helps them to prioritize populations or pockets or regions within the state to design their vaccination strategies.
Thank you, Dr. Rajesh. Please, I see he is logged in and he is traveling. Welcome, sir. Please go ahead.
Yeah, can you hear me now?
Yes, sir. Loud and clear.
Okay. Yeah, I think this is very interesting exercise which has been done. We had discussion earlier, and now we can see that the uniform strategy is better. But we really were in a dilemma to begin with when vaccine was in short supply, which areas to focus initially, urban or rural, high intensity potential or low intensity potential. And we constituted a state vaccine expert group because it needed a lot of consultation. And Dr. Gagandeep Kang was our chairperson. And we decided on that we take density of the district rather than focus on rural and urban, and rank districts, and then we distribute vaccines. But science apart, we have to take into consideration many other factors. Very quickly, we came across this political choice, which we can't discriminate between areas, between rural and urban, because demand is there between both the areas. So politically, discriminating one area from another area became very difficult. This was one point. Second point about this calculation of capacity and how much one can immunize. I think the capacity which has been taken into consideration is which was available for routine immunization. I think additional capacity was created by the state, and the capacity was to vaccinate like 5 lakh doses per day, quite high, but that much number of doses were not available. So I think this type of exercise, one can give some direction, but it has its limitation also, as has been pointed out. And cost effectiveness of vaccination is, I think, not under question. Even for routine immunization, vaccines are cost effective. So these are my thoughts. Thank you very much.
Thank you, sir. You emphasized a very important point. Health economic analysis can provide us a framework, but they cannot help us make decisions because there are issues such as legal issues, there are issues of acceptability and equity that become paramount. Let me go slightly on a different track. So if we see, some of the slides, the different strategies had a lot of variability. And actually, if you see the confidence, the uncertainty intervals around, they were quite overlapping. So do we really think that we should go by the central estimate, or do we really need to look at the uncertainty intervals overlapping also? Maybe the groups that did this can try and answer this, and then we'll go to another set of questions.
So maybe I can request Dr. Javier to come in here, as Dr. Javier was also overseeing the study, and then Dr. Shripad as well can come in.
Thank you. Can you hear me?
Yes, we can.
Yes.
Okay. Well, thank you very much for the invitation. It is a pleasure to be here with you all. I think it's very interesting what we just heard, because it is clear that time is of the essence, and sometimes at the beginning, policymakers do not have the time to do cost-effectiveness studies, the ability to incorporate evidence. But I find this study very insightful in terms of we were really thinking that zero prevalence could actually play a very interesting role in terms of maximizing the benefit. And we didn't find that. And you clearly saying that well, the numbers are very similar, and the confidence intervals are, do give us, certainty from these results. But I wanted to, emphasize the interesting part about, even though we heard that, vaccination is always cost effective, we were very surprised to find that it could also save money. So it's not just about value for money. It's not just about, that the investment is actually, gonna prevent cases and deaths, but it's also gonna save money, which is also a case that is important to make to, the finance minister and to other policymakers, because sometimes investments in health are seen as, investments that are not basically giving you a return on investment money-wise. And that was not what we found. So interestingly enough, when you say, it's not, if you actually invest into vaccinations, it's not that it actually prevent death, prevent cases, but saves money. I think that's an interesting, powerful message. The other, I think, point I want to make is how we were able to combine three different elements that before COVID were not really combined on a regular basis. So the epidemiological model, the supply chain model, and the cost effectiveness model all together, we basically provide a very interesting approach to consider all the possibilities. So it's not just about, what vaccines do you procure, or how much, should you pay for the vaccines, or, what different, procurement negotiations you could get into. It gets into the distribution. And that is, I think, very interesting what we heard about how the state was able to increase capacity. Because I think the way you design the rollout implementation can be informed by modeling that, like the one that we just presented. I mean, we clearly saw how the biggest constraint was vaccine supply, but now, which is when it's not the case, other elements could actually be incorporated. And we were, alluding to the importance of maybe, expanding and engaging private sector to increase capacity in terms of vaccinators. So other elements that could actually help in terms of the vaccine delivery. I guess, just to finalize, evidence is just evidence. And as you said, Dr. Rakesh, is for policymakers to inform decisions based on this evidence. And I think this study contributes to that effort. Thank you.
Dr. Javier, while you are there, let me ask you another question. We looked at two issues in this modeling. Do you think prioritization based on urban, rural, or zero prevalence was more important? Or do you think based on age, something that we didn't do, that would have been more important? And, would you have liked to include that in your analysis if you were to do your analysis like we have done here?
I think you're right. I think, different elements at this point could be seen as more important. At the time, there are just many different possibilities to and options to decide on. So one was zero prevalence, and there has been a lot of evidence about, how you could maximize the use of the vaccine with zero prevalence data, and that's why that was decided. Now, other elements like age groups, as you said, it is of vital importance. So yes, I would agree with you that age groups could actually be an interesting way of looking at this. I think we do have the ability to use the model for for the future, and that's not just for Bihar. That's also for other considerations in terms of age groups, as you just said, or other vaccination strategies. I guess the important point here is how we use the modeling, combining epidemiological data, supply chain data, cost effectiveness data to inform policymaking. But I agree with you, that's a very important consideration.
Dr. Shripad, you want to say how you would like, compare analysis based on operational factors, epidemiological factors, and economic factors? What do you favor?
I'm not sure if I would say I would favor one over the other, but I think it's important to look at all of them together in a model, not necessarily saying that the model that we have developed here or presented here is the best, but they all interact, right? So for instance, being able to implement any particular vaccination strategy, be it prioritization based on seroprevalence or prioritization based on other consideration like you just mentioned, which is age-based or comorbidity-based, vulnerability-based, being the impact of implementing any such strategy is also dependent on how well it can be implemented on the ground. And so to that extent, having an operational model inform how fast the strategy can be implemented, what the rate of vaccine coverage would be, and consequently what the health outcome would be, I think is important. And ultimately, of course, there are costs involved in implementing any of these strategies and costs that are saved because of avoiding mortality and hospitalization. So looking at all of, so I would think of the cost effectiveness as an outcome of including both an operational lens and operational or supply chain model as we've done in this study, plus overlaying it with an epidemiological strategy informed by seroprevalence or age prioritization. So just to quickly respond to your earlier question, Dr. Rakesh, about the confidence intervals, I agree that in this case, at least the confidence intervals overlapped, and part of it, and I wish Nim were here to answer that in more detail, but I think part of it was also because we were using aggregate estimates of the seroprevalence. So if there was more granular data available, we potentially could have had different results where there might have been a clear distinction between the performance of the different strategies and would have made a more convincing case. The other thing which we haven't considered in this model is uncertainty and variability on the supply chain side, which should have also added to the confidence intervals on the final outcomes that we're seeing.
Dr. Gagandeep, do you think seroprevalence would be acceptable to public health people in the field and to the politicians as a way to determine where the vaccine should be supplied more and where less? And what do you think also as with your epidemiology and experience in the field of vaccinology?
I think in terms of looking at seroepidemiology or prior exposure to the virus, it can certainly influence virus circulation and could have a potential public health impact. But in terms of how the program views it and how delivery would be implemented, by first testing people for antibodies and then making a call on whether to vaccinate or not, I think that would be very challenging for the public health system because it has all kinds of potential communication problems in terms of stigmatizing individuals that might have been exposed or in terms of people feeling like there is a service to which they are entitled, which they are not getting. It could, there has been a lot of discussion about modeling around seroprevalence that relates not only to the speed of delivery strategies, but also looking at whether people who have in areas that have high levels of seropositivity, whether you could give the first dose and then delay the second until you could reach everybody with the first dose. Again, implementation becomes a key stumbling block. So while you might be able to demonstrate that you would have greater impact if you were to go with a single dose strategy in places that have high levels of seropositivity, I don't think it would be necessarily a practical solution. The other question is, how high is high enough to make that decision? Clearly 60% seropositivity is something that we blew past a while ago. And in many places, we are now in a situation where we likely have 80% plus through a combination of infection and vaccination. So again, when you look at a modeling strategy that's serology based, then what stage is it relevant to have that strategy? There are lots of considerations and no one happy solution, unfortunately.
Thank you. So I thought that in Punjab, when we were looking at rural versus urban 21 versus 31, that difference was relatively minor to be able to allow us to make a difference. So let me go to Dr. Rajesh. Dr. Rajesh, as we are trying to vaccinate larger proportion of our population, there are questions about boosters, or let's say first the children. What do you think about childhood vaccination and how we should be deciding on that?
Yeah, we were discussing about serology. We recently did a sero survey among children in Punjab, and about 60% children have the antibodies. It ranges from 45% to 80% in some of the districts. So very high seroprevalence in children also. So we have to keep that in mind, as Dr. Gagandeep was saying, that in view of our, we don't have enough vaccine. So we have to keep in mind that how to utilize it. And your point about, whether we can give vaccine to children. I think we still do not have vaccine right now for the children. But I think whenever we have it, then we can use it for children also. But booster is a very tough question, especially in our case, where vaccine supply is limited and even first dose people are not getting. I think our first priority should be to give vaccine for at least first dose to everyone. We have seen in Punjab, we try to do a vaccine effectiveness also, and even first dose give a lot of protection. So I think that should be our priority. But definitely some age groups like 65 plus or immunocompromised, it should be very specific for booster, not as a general for the whole population. That is what I feel right now.
Yeah. Dr. Debarshi, can you try and be short because we have limited time now? What is your view on that, Dr. Bhattacharya? Okay, Dr. Gagandeep, children and boosters.
I think we don't, at least for India, we really don't have data that inform us at a population level what disease is in children. We know infection. We know that infection was about 60% in June and July of this year. But we really have very little information on disease because all of the reports that we have, all of the publications that we have on disease are only single center studies that focus mostly on children with comorbidities, and they demonstrate that the potential for severe disease is there, the potential for mortality is there, but how much of the population they reflect as a rate, we have absolutely no clue. So in that situation, should we be thinking about vaccinating children? I have no data to base this on. And given that we haven't covered a lot of remote areas, despite what the government says, we have not covered remote areas and the elderly very well. So I would wait on children at the moment. I would put pressure on the government to get more data. Boosters, same story. You know, the rest of the world can jump on boosters. They have adequate supply. They have data that shows that that at least for some vaccines, there is reduced protection against infection and disease. We have no data. So if we are talking about evidence and we're talking about modeling, well, modeling also needs to build on data that we actually do not have at the moment.
And boosters, there is another issue that comes in India when you have 70 to 80% seropositivity, a lot of it because of actual infection, then the effect of vaccine may be very different. Dr. Devalkar, you want to add anything on this?
No, I think I agree with Dr. Kang's assessment that a model is only as good as the data on which it is built on. And given the paucity of data, it's at least, and the current situation on supply, there is at least no strong impetus to start either administering boosters or think about vaccinating children.
Dr. Guzman?
Yeah, well, I guess it's all about, the data and the ability to use it to inform decisions. And my plea is, to use robust data and, produce different scenarios about the value for money and also, the health benefit of different strategies. And, models like the one we presented today could actually help inform those decisions. Of course, this is on the basis that the data is there, and I would agree with the previous panelists. We haven't seen that yet.
So let me go back to you, Dr. Shah. I think we are towards the end of our panel discussion. So yeah.
No, and it's been a fantastic discussion, very, very interesting insights from all of our panelists. Thank you, Dr. Rakesh, Dr. Gagandeep, Dr. Javier, Dr. Shripad, Devashri as well, thank you, and to Nim as well. And a warm thank you to IPHA and Dr. Sudhanshu and Jitma University for hosting such an excellent conference as well. And if you are interested in hearing more about the study, please do visit the CGD website, the Center for Global Development website. We'll be posting a blog on there as well, so please do visit and have a read. And warm thank you. And again, we keep on fighting against COVID. And as Javier and Dr. Rakesh, Dr. Gagandeep, everyone said that evidence is key. And so I urge the public health community to keep on generating the evidence needed for policymakers. And thank you very much, everyone.
Okay, thank you.
Everyone, thanks for the opportunity to present this work.
Thank you.
Thank you.
Thank you so much, everyone, for being here today. So we have heard a lot about vaccination in resource-constrained settings like India and how cost effectiveness comes into play. I would like to thank all of you for taking the time out to be here with us. Dr. Rakesh Agarwal, Director JIPMA, Dr. Hiral Shah, and our other speakers and panelists, Dr. Rajesh Kumar, Dr. Gagandeep Kang, Dr. Nimilan Arinampati, Dr. Javier Guzman, Dr. Shripad Devalkar, and also Dr. Devashri Bhattacharya. So it was a highly informative session, and thank you all for being here and being a part of IPHACon 2021. Thank you.
Thank you.
Thank you.
So with this, we come to the end of the scientific program for today. And this will be followed by the IPHA general body meeting. And we request all the IPHA members to join us for the same. Thank you.
A very good evening to one and all. We welcome you to the 65th Annual General Body Meeting of the Indian Public Health Association. Now I request Dr. Sanjay Kaira and Dr. Sangamitra Ghosh to take over the proceedings.
Thank you very much. Very good evening
My most valued member of Indian Public Health Association, attending this 65th annual general body. Attending this 65th annual general body meeting at 65th annual national conference. What is happening? Why there is a disturbance? No, it's not because really it's a great honor for me to say something is happening here.
That has to be on off the
Okay.
Yeah, now it is.
Really, it's a great honor for me to share this special occasion of an annual general body with all of you. On behalf of Indian Public Health Association, as a president of IPHA, I welcome you all in this annual general body meeting, 65th annual body meeting. This time, it's an extraordinary situation, so this is a hybrid type of meeting, both physically, our majority of central council members are here, so they are physically here, and majority our general body members, they are attending virtually. So first time in the history of Indian Public Health Association, we are organizing this type of conference, and so it was a difficult time, and I must congratulate organizing committee of JIPMER for organizing this type of conference in this difficult time, especially thanks to Dr. Gautam Roy, organizing chairman, and Dr. Sitanshu Kar, organizing secretary, and his entire team. So they deserve a big applause. Really, they deserve a big applause. Since last 1.5 years, we are facing a lot of difficulty. But we are proud of what IPHA have been able to achieve in this time, and capability we have built during the last 1.5 years through various our activities. So I will request Dr. Samitra Ghosh, our Secretary General, to share the various activities done by us during the last 1.5 years during this difficult time, and also share her experience of last 1.5 years, and start the proceeding of annual general body meeting. So thank you very much. Thank you.
Thank you. Very good evening to all of our members, those who are online and those who are physically present here. We are really grateful to JIPMER Pondicherry State Branch for organizing this type of conference, and this is hybrid conference, and for us, for this AGB and ACC, it's a hybrid conference, so it is really difficult, and this is the first time our president has said, really this is the first time we are facing this type of situation, and we overcome it very successfully, which that's why a big applaud for the JIPMER team and Pondicherry State Branch. First, I have to call Dr. Shashikant and Dr. Maushumi for giving the medal to President and Secretary.
All right, this is a wonderful opportunity to honor you, richly deserved. Thank you.
I'm going through the agenda. The agenda of the meeting, agenda 1, election of the chairperson of the meeting. It's not necessary as president is present and he is presiding the meeting. Agenda number 2, confirmation of the minutes of the previous annual Senate Council meeting, which is in the yesterday meeting. So, Shobhik, have you distributed minutes to everybody? So please go through the minutes, and if it is possible, please show it in the online. Okay. Yeah, I cannot see. Any Central Council members are here in the online? Okay, we have extensively discussed the meeting. Just go up.
My name doesn't seem to come here.
Okay. Who? Dr. Gautam Roy. What is?
My name is not here.
I wrote your name. Okay. Because I told the spelling to Kaushika. So actually, it's at 1 o'clock I was making the all editing in the minutes, and I told this Kaushik. Huh? You wrote na Dr. Gautam Roy, President. G-A-R-G-O. But it's not there. Please add Shobhik. Please add Dr. Gautam Roy here. Anybody left? Okay. Any more add? Members who?
Number 2.
Page number 2. Oh, okay, yes, sir. Dr. Rajkumar Mukherjee. Actually, all these members except Dr. C.M. Singh did not inform also about the absence. They did not inform headquarters that they are not coming or they are not attending. I'm going to the 1, 2, 3 annual report already on annual. I need to go through annual report for the other members little bit. Otherwise, these minutes will have the annual report. Yes. Some members are not. Okay, they are not. Technical team, please. They cannot hear. Okay.
Actually, some of the 50 member is not able to join. Other
Okay. And some of the members are CC members or other members also? CC members. Okay. Should we wait for them? Okay. So our annual report, any other except CC members, any other members are there in the online? How many members are here online? That cannot be seen, no?
Who can speak?
Okay.
That number we can see.
Okay.
Next time that number will be and we have to take.
Okay. Fine. So annual report already we have discussed yesterday, and it will be on our website with this minutes. So I'm not going through all the annual report, but only we have association activities during this pandemic situation. That is 4 statements on COVID-19, which are government advisory actually. we have published, and we have different national level workshop and public health quiz. So webinar on finding the way forward in COVID-19 situation, pandemic, Spotlight India, that we have done. And we have done some online certificate course under the leadership of Dr. Sanjeev Kumar, Indian Academy of Public Health. He's the chairperson. And we did some workshop on zoonotic reference, e-workshop twice, and IPH psychometric workshop twice. I'm not going through all the annual report.
Most posted every
every time
on the website. So all these activities are already there.
Website, mail, everything is informed to the members. So have you finished up the minutes of the annual yesterday's ACC? Any typing mistake or any omission? Correction.
Agenda number 3. It was decided that the audited budget,
corrected budget. Audited revised budget. Yes.
Revised audited budget.
No, audited तो होता नहीं, budget audited होता है. Audited account statement. Revised budget will be presented on AGB meeting. Okay, that will come. I will be present. Okay. Discussion on the IAPH current health program. Show it. Dr. Pradeep, just show it. We are coming to the award papers in the agenda. We have already declared the awards. Proposal for date, venue, theme of the next annual conference. Have you received anything? Send a mail. Where? IPH. IPH. Please open.
This award paper, ma'am, I would like to bring your notice that for year 2020, Olivia Mary Jacob, her tuition has been cited as the Inaugural
It's last yesterday also I corrected. Yes. All India Institute.
And some typographic error again on page 1, serial number 25, Dr. Pankaj Ralo. It's written Jodhpur West.
He is vice president. He is vice president West.
So it's not Jodhpur, maybe Jodhpur.
CC member, na? CC member West. Joint Secretary Kolkata Headquarter. Joint Secretary Headquarter. Dr. Sharmila Mallik. Okay, I think.
Or is it Chitta 15? It says Secretary General on the telegraph.
No, it's Secretary. Dr. J. Venkatachalam, who was he here? I think, Dr. Gautam, I actually corrected here, number 16. I wrote, I have not seen Dr. Venkatachalam actually. I wrote Dr. Gautam Roy here. Okay. I have corrected and I'll give it to you. Yeah. No problem. Okay. So it is accepted. Accepted. Is it accepted, this SSA minutes? Has it been accepted? Okay, thank you. Accepted with correction.
Minor correction.
Minor correction. It will be written, Shobik, in the AGB minutes, okay? And this minor correction we will do. Okay. Adoption of annual reports. Should I read this annual report again, or you will see here? You all know already. I have just, so I'm just omitting this. Adopted. I had only one voice.
Adopted.
Okay. Adoption of the audited statement of account. Now, Dr. Amol Sinha Roy, our treasurer, please present the audited statement of account. Okay, Dr. Sinha Roy is now presenting agenda 4 and agenda 6. Agenda 4 is adoption of audited statement of accounts, and agenda 6 is consideration of budget estimate for the year period April to March 21-22.
Thank you. Good evening to all of you. Now, first page is consolidated receipts and payments. Now, this is the budget. Actually, this is the budget for the periods of 2021, where all the things have gone away and TDS was deducted. Tax is also returned, and total amount of receipt was 1,76,93,162. That is from the membership fees, lots of symposium, and the bank interests and other things. The payments is also 1,76,93,162. We have already done by the accountant, and it was cleared. Now, the amount that have been taken here from 3 sources. One is from the Bhavan, one is from the journals, and one is from the associations. The income, expenditure, and the income. Later on, I am coming to the first part, that is from the. That is the balance sheet, actually. If you go through this first page to second page, then you will see total amount that have been received is 1,76,93,162.08. And the payments is also, there is 1,76,93,162, but here actually the payments, most of the amount, that is 1,57,076,802 is kept in the bank, and 2,933 is actually kept in hand. That is the budget that already proposed, and already TDS is done, in tax is returned, all procedures are finished. Now it's GB will decide whether we'll go for audit or not. So if you go through the balance sheet, now the amount for the amount for the account as well as all the assets, that is from the lands, that is from the furnitures and other assets, those who have air conditioners and other things, cameras. The total amount that have been asserted there in the budget for the year 2021 is 4,19,15,186.27. And this year balance is given here, out of which bank, most of the amount is kept in the bank. So total amount in the bank is this year is 32,923, 1 crore 68,3,917 and 1 crore 57,076,802. These are all kept in actually in bank. So this is the part. Next year, we can go for the expenditures. Now, if you go through the receipt and payments in expenditures here, for the year 2021, here total amount that has been expended, actually receipt and expenditure goes to Vobun is 90,660. And if you go through the Zanna, it is actually 30,70,261. And if you go our association, it is 24,60,770. This is the total amount that have been actually asserted, that have been kept in the budget, and that was actually I go through most of the amount is kept in the bank. Okay, so this is the budget for the year 2021. All work has done. Now AGP will decide. We'll go for audit.
AGP will not decide about the audit because audit is mandatory. We have to do the audit, and this is actually prepared by our auditor, and it has not been signed by auditor because of the COVID pandemic. Everything is delayed, so it is not done till date, but it will be done within next few weeks, and then President and Secretary General will sign on it. And I'll just add few things here. That is, first thing, Amal has said that all the money is in bank. Yes, in my tenure, I made sure that no cash transaction. For the petty cash, wo chhod ke, ek pin or alpin chhod ke, there is no cash transaction. All membership, everything online, either by check or by net banking. We are not collecting cash, and we are not transacting by the cash. Okay, so we are that no cash transaction. We just give some petty cash. Yes. We are trying, actually we are trying at we made our main bank is State Bank now. Yes. So we are trying to have our one payment gateway at State Bank. I already spoke to manager and they are ready without any charges. As we have big fixed deposit there, and in this tenure we have increased some fixed deposit, that is 50 lakhs in this tenure, and my last tenure another 50 lakhs. So 1 crore added. And for journal, he has said that 30 lakhs almost expenditure, but we are getting royalty, don't worry. So royalty is quite high for journal. So we are getting royalty for that. So that is almost nullified. So we are spending like 2 lakhs per this issue. So this is my addition.
Thank you. Now I'm going to present the budget. Go through the budget. Start with the budget. Sorry. Any comment or question? regarding the account.
Last AGB was on, I think, 1st or 2nd of March. Am I audible? That time we have produced 18-19. This year we were supposed to present 19-20 because this conference has been delayed because of COVID. Otherwise, it was supposed to be held in the month of February or March. A completed budget duly signed by the State Secretary as well as our auditor. That has to be produced in the general body. This will go to the next general body because this is for the year 2021.
Okay, and I agree with you. For the COVID pandemic, everything is delayed. But whenever budget is always an advance proposal for the expenditure for the coming year or for the present year. So 19-20 we already have spent, so we cannot say any budget for the 19-20. Actual expenditure, yes, but audited statement, yes, audited statement. Audited statement, we have taken care of that. Audited statement, Shobit, last audited statement which you have given to me yesterday, you can give it.
No, I don't.
No, miss, we can give it to members.
We should not commit any mistake by.
No, sir. No, sir.
It is for 19-20, we can approve.
I understand. Actually, we are not just writing audited statement. Actually, it's account statement. We have given. It's account statement.
We'll go next. Can I go to the budget? Yeah. Yeah. Accept it. We will go for it. Accept. Now next is the proposed budget for the year 2021 and 21-22. 2021 is now running. Now yesterday there was a query regarding. Yesterday there was a query against for a comparison with the 2019-20. So we give you the proposed budget. Go for this. So here we proposed a budget for 2021 on the basis of 19-20. Now here 19-20 first come to the Bhavan. Now Bhavan there was a expenditure of budget of 2,29,200. Against which we have a proposed budget. This year is 6,56,500. Basically, actually the budget was extended. We have proposed for the maximum amount goes to the assets because there is a very much depreciation and very much renovation for the bhavans, buildings and other materials like ACs and other rooms. So that's why the budget is actually increased this year for this asset renovations. Otherwise, more or less same. The miscellaneous office expenses, if go for this, the conveyance expenses, we actually there is 5,000 conveyance for the things that we are planned to. Conveyance expenses. We have planned basically the alternate day office will be go to Bhavan. That's why the conveyance expenses is high. But otherwise, only the depreciation charge and the asset renovations, we increase the budget for this 2021 and it is kept same for the 21-22. So this is actually budget for 6,56,500 and 6,70,000 because electricity expenses is more. That's why budget is something increased. So this is for the Bhavan. Now next page is for the Zana. Zana, there is a budget, audited budget for journal in the year 2019-20 was 31,21,086, against which the 2021 budget is proposed at 35,055. That was the proposed. And most of the things that journal subscriptions, journal subscription members, processing fees, these are actually proposed budget. We are thinking of more journals, so that proposed budget is increasing here. And the royalty receipt is here is 23,40,000. Journal sponsorships, okay, due to pandemic, it was reduced to 10 lakh, 1 lakh. So actually the proposed budget is based on the 1920 and it was increased only about 5 lakhs, nothing, 36 lakhs, 55,000, which is against in 2021-22, it came to 41 lakh 50,000. Now if you go to the 1920 expenditures, you can see that there is an increase in, actually in the journal publications expenses. It was 17 lakh 84,057. Now it's come to 27 lakh 50,000. That's why the budget that is due to COVID-19. And that's why issues, special issues, there are 3 special issues. So that's why the budget was a little bit high in 2021. Now regarding association account, if you go through the budget, in 1920, it is around about 35,99,159. And the expenditure is here, and against which a proposed budget was done 42,30,000, and 21-22 it will be 44,17 based on the previous the actual expenditures. And the expenditure here, if you go through this, the budget is performed. Only expenses that was increased is public health day celebration CME. We actually increased it 2,62,000 to 5 lakh. And there is a World Congress expenses meeting will be there. We think so, 2021. We kept it 4,50,000. And that is also fixed for the 21-22, that is 4,50,000. And IPHA 21, we have a seed money for that 1 lakh. So this is actually the measures we are taking in the proposed budget 2021. It is running, current year is now running, and it is the proposed budget for 21-22. So this increase is actually increased against these WPA PHA members and that of Public Health Day Celebration or CME. This is all for me. So this is the proposed budget. Where is it? Okay. Yes. That is actual 1920. So we got 15 lakhs from the journal, 15 lakhs 79,000. Where expenses is 17.
I just told him that you just point out that we have income from royalty that is 15 lakhs, almost 15 lakhs, and we spent for the publication it's 17 lakhs. Okay, so that I was telling treasurer. Okay.
So this is the proposed budget. AGB will see all these things and accept it. Okay. A suggestion. Okay, first.
The account statement at some places gives value up to 2 places after tax. And at some places there is nothing.
Nothing is.
And therefore comparison becomes very difficult.
Fine.
It is better to put it in
0.00. 0.00. Yes.
Okay, so that's one. And secondly, you decide whether you want to put comma as per English or English. Whether you want into millions or you want to put it into lakhs.
No. Only rupees is 1 lakh. This is 14 lakh. So he said that
I just want a uniformity.
Oh yeah. Fine.
There is ease of understanding.
No. Sure. No, sir.
Account budget of headquarters. The postage, printing, and certificate delivery.
Okay.
Actual expenditure in 1920.
9,462.
1920 was 9,462. Your proposed budget was 35,000.
Next year will be 40,000.
And next year you are keeping 40,000.
So actually, it is correct. The postage, printing, and certificate delivery. Now, 2021, so much conferences are there, so much. This is so much conferences are there, and all the participants are given actually the certificate delivery plus medals. Yes, yes.
Okay.
Extra medal. That is.
Initially,
Separate issues, postage printing, and another will be certificate delivery, certificates, and certificate and medals. That's why the amount is increased. Actually, certificate medals plus medals. That's why the budget is increased.
Next, World Congress registration and PA 4 lakh. Again, it is mentioned WSPHA meeting expenses 4,50,000. But there are no actual expenses in 2019 to 2021. So this can be
excluded.
Okay,
fine.
So the excess of income over expenditure will be increased from 1,21,000 to 1,30,000. If you exclude this.
If you don't budget it, for the pandemic, nobody has gone to any conference, international conference. But if you don't budget it, then how a person, or secretary or president can participate in the conference?
In two headings.
Oh, it is in the two headings. Membership. No, membership fees is always fixed. It is this time 8 lakh.
Registration, but one is
This is
registration and PA. World Congress registration and PA 4 lakh. Again, you have second WSPHA meeting.
This is duplication.
We'll go for this. So the budget will be less. 4 lakh.
4,50,000.
Anything else? So it is accepted or not? No.
Please go through and take your time. If it is accepted, please say yes.
Yes.
Or if it is not, have you gone through?
Yes.
Arun is still searching. Okay.
Accepted with suggested correction.
Suggested correction 1. Please remember. Dr. Shashikant also. Okay, budget can be adopted. This budget. Okay. Thank you. Anything written here in the online chat box?
No. Any honorable member?
Any honorable member, they are writing anything?
No, that is for previous.
So we have finished 2 agenda at a time. Agenda 4 and agenda 6. So now coming to agenda 5, IGPH related issues. IGPH related issues. Dr. Indranil, are you there? Dr. Indranil, are you there? Will you present? He is not there.
Is not there. Yeah, Dr. Dilip can.
Dr. Dilip Dash, editor IGPH, Dr. Dilip Dash, sir. Are you presenting? I'm just reading this IGPH related issues we discussed yesterday. Most of you know everything. It's for those who were not present, the other members. For them, I'm just presenting this few lines. Dr. Inaugural Shah, Managing Editor, IGPH, has presented the report to the CC. Total 5 editorial board meetings were held after the formation of the new editorial board in 2019. All the editorial board members have already received user IDs and passwords. Most of the editorial board members are being actively participating in the article review process, excepting very few. Huge number of total 1,090 articles submitted till 4/9/21. 3 special issues were published. One is rabies, another one that is with Iphacon, and I think Iphacon spelling there is a mistake. And HIV/AIDS with ICMR, NICED, and NACO. These are sponsored. And epidemic and epidemiological studies on outbreak investigations, surveillance, evaluation, and epidemiological studies. That is with CDC, India office. And a special issue was published on 2nd June 2020 on COVID-19 with guest editor Professor Anand Krishnan and Professor Rajiv Dashgupta. And this issue is not externally sponsored and paid by IPHA headquarters. There are mentioning of 2 things in minutes. That is, one, RPI has been filed against a paper titled Contraceptive Behavior and Unmet Need Among the Tribal Married Women aged 15 to 49 years, a cross-sectional study in a community development block of Paschim Bardhaman district of West Bengal, authored by Ananya Mukherjee, Niladri Banerjee, Somnath Noshkar, Dilip Kumar Das, and Shutopa Mondal, published in volume 65, issue 2, regarding very short review time of this particular article in contrast to long review time for other research articles. The RTI also seeks the information about the number of original articles authored or co-authored by Dr. Dilip Kumar Das and published in IGPS during 2019-21. Another email regarding this same article has also been received by IPHA headquarters from another member of IPHA. That letter, which has highlighted the average time from submission to publication is 322 days, whereas the time span for the concerned article is 126 days. It has been decided to send these emails and RTI to the editorial board members and CC members for their opinion in this regard. Dr. Shashikant suggested to seek legal advice before replying the RTI. The chief editor and managing editor have submitted their resignation, citing personal reasons before the ACC. All the resignation letter has been accepted principally by President and Secretary General before this ACC. These decisions have been ratified by the annual Central Council. Dr. Rajiv Dashgupta, presently editorial board member, has been selected as managing editor for the rest of the term and the extended term. The decision has been ratified by the Central Council yesterday. The issue selection of a new chief editor has been raised. Dr. Sanjay Rai, President, recommended the name of Dr. Sanjay Chaturvedi for the post, and Dr. Shangumitra Ghosh, Secretary General, agreed with him. This has been ratified by annual Central Council. It is decided that editor will be selected from any of the editorial board member. Name of Dr. Major General Atul Katwal has been suggested by Dr. Colonel Arun Yadav, which is acceptable. Necessary acceptance from the said member will be accorded. This was the IGPH discussion and minuted ACC minuted minutes. Okay. So any suggestion, any omission, any commission, please. Through accepted. Okay, accepted. So we've finished.
Any comments on virtual? Those
who are attending, please see the chat box.
No.
Chat box is, there are people, no?
Yes.
Huh?
We are checking.
Okay.
Silence.
I'm really suspicious. They are here listening to thing, no? Okay. IGPH, okay. Okay, then next is agenda number 7. Haji? Will be accorded necessary acceptance. Dr. Arun suggested the name, and we have thought about it. So I think he is ready. He is ready actually. Yeah.
As we discussed earlier, to select the editor from only this build committee, existing committee. So he's ready. I discussed with Dr. Sanjay Chaturvedi also. He's ready.
So we'll send the required letter to them, and officially they will accept. Otherwise, unofficially already accepted. Okay. So coming to the next agenda, number 7, discussion on Indian Academy of Public Health. Chairperson Dr. Sanjeev Kumar is not here. I think he's not online also. Is he? No. So I have already presented his report. That is, we had a certificate course that was a 5 weeks course. First time it was 5 weeks course, and after that 4 weeks course. That on public health leadership in June and September 2020, and it was a very successful certificate course, and we are actually discussing about another certificate course next. So after the conference, most probably in the next CC, we can give you the idea. So anything about the academy, anything about this agenda, any input from your side? No input? Okay.
If something is there in chat box, we'll discuss later.
Okay.
We have only 15 minutes.
Okay. Okay. Agenda 8, discuss the policy.
Yeah, we should increase our academic activity because every time income tax are telling us that we are.
I fully agree with you.
We are giving them undertaking that the amount money lying with the banks will be utilized for the upgradation of the knowledge of our members and all these things. So we should be exempted from income tax. Every time we are giving this, but actually we are lagging behind in this regard. So we have to increase our academic activities.
Actually, we had physical activities, physical academic activities, offline activities in the last year. But this year, we had income, but we could not spend the amount because this is virtual. So this year expenditure is very less because of we have Karsi Pradeep, so we have the Google Meet, we have Zoom. We are planning to buy the Zoom also.
I have also specific key academic. Actually, we have already discussed. That is there should be one platform which can be used for the virtual workshops, and many other organization is using the eConnect for the different academic activities. So EIPHA platform should be developed for the future academic platform. That is my proposal. So that was not discussed here. That should be discussed for the
Please give mic to Rigu also.
Okay, so the thing is that the last year we were organizing around 6 to 7 workshops. Okay, and the event was huge. Okay, and there was absolutely no costs involved because the Google Meet was already there. So, I think it's already on the process of going for an e-payment gateway. So, in that way, if we buy a Zoom and if we can format people from all around India, that will be very good because in that way, many persons will have different ideas. Like they can have different case studies of public. Several topics can be there. So, first, let us start with the like WhatsApp group, and then we lead over to have many activities one by one. Maybe an academic calendar is not possible now because let us see how this works out. But we can have the all India ownership also and have diversified activities for that as an academic activity.
Good idea. I just introduced Dr. Ribu Basu, who was who with his team, Kaushik and Sanjeev, they actually arranged Anirban. They actually arranged all this workshop, and those are very successful, and they worked with Dr. Sanjeev Kumar for the certificate course. And Dr. Sanjeev Kumar was very happy with them. So this time also they are arranging this quiz, and that is the All India National Public Health Quiz. Last time it was very successful, and this time also Dr. Ribu, Sanjeev, and Dr. Kaushik, Abhishek, he has not come. Dr. Abhishek De and Dr. Anirban Dalui, they have worked very hard with some other. You can give the name also, Sharon, and I just remember few names. You can give the name, we will recognize them. Okay, and as I'm saying all these things, yesterday I was showing some PPT and something, so I must recognize Dr. Anirban Dalui also, who is very particular and very sincere chap, who are very helpful, and doing my young brigade are really sincere. The young brigade of Chikmad, including the HOD. Cut of age, no?
WHO says 60 years and also young.
I'm so happy listening to that. So I'm also in that category. Okay. Discuss the policy of the IPHA regarding the current health programs and policy for the national importance. Already we've discussed it, and we had during the COVID pandemic, we had 4 joint statements, and where Dr. Sanjay Rai already spoke about it, and we are going to have another 5th joint statement within a very short period. And the mastermind and the organizer इनके पीछे जो है वो डॉक्टर संजय राय, our president. They are already. He is in the committee. And if you say Dr. Shashikant is our member, he is in the national task force. And Jo Bolna, they are saying everything. And whatever IPHA has said in the first joint statement, they have adopted in their second step. So we are ahead of it. Consideration of resolution brought forward by the individual member of the association. This should come within the September. Last September, no resolution has brought forward. So I'm not discussing on agenda number 9. Agenda 10, the most awaited thing, conferring fellowship, awards and prizes. Okay, Oration, already Oration medals have been handed over to Jipmar, Dr. Shitangshu. About so I'm just reading out the Oration orator. Dr. B.C. Dashgupta Memorial Oration, orator Dr. D.K. Srinivas, former Dean Jipmar, consultant Rajiv Gandhi University of Health Science, Bangalore. Dr. J. Park Memorial Oration, orator Dr. J.P. Mulyal, need no introduction. Still, former principal CMC Vellore. Dr. K. N. Rao Memorial Oration, Dr. Thiagarajan Sundaraman, former executive director of NHSRC and Dean TIS Mumbai. Dr. I.C. Tiwari Lifetime Achievement Award proposed by Dr. C.P. Mishra, award conferred to Professor V.M. Gupta. He is very aged and he is in Benares, and we have sent the certificate and everything to Dr. C.P. Mishra, and he will confer the he will reach Dr. V.M. Gupta, Professor V.M. Gupta. Award of appreciation to the branch first for the highest membership in 2018-19 conferred to Puducherry State Branch, which was actually given last time. We have brought the Puducherry State Branch, Dr. Gautam Rai. Please come. Please. I'm showing a show.
आप भी थोड़ी देर में Thank you so much.
Next award of appreciation to the branch for 2019-20 is AIMS New Delhi Institutional Branch. I request Dr. Shashikant.
Yeah.
Okay, there is one of Presidential Award of appreciation conferred to individual for the individual effort for membership towards the contribution of highest number of membership in strengthening the association, Dr. Ribhu Basu. Fellowship Award. Fellowship Award, total 4 applications were received. So 3 were screened. Dr. Pradeep Agarwal, Manish Kumar Singh, and Dr. Sharaj Haldar. So for 2 candidates secured more than 50% of casted fellow vote. Their names are Dr. Pradeep Agarwal and Dr. Manish Kumar Singh. Dr. Pradeep Agarwal, please come. Congratulations. Dr. Manish. Take the boxes to them. Research articles for 2 categories have been received duly screened. SD Gold Base Paper Award on Environmental Health Practice. This year, Dr. Anirban Dolui. Where is Dr. Anirban Dolui?
On the beach.
On the beach. Who will receive Dr. Anirban Dolui's? On behalf of Anirban Dolui, Dr. Ayan Ghosh has come. Second, Dr. PC Shen Best Paper Award on Rural Health Practice, Dr. Ribhu Basu. Dr. Aryan Roy Best Paper Award for 2019, which is given to original article published in IGPH, Dr. Anuj Mundra. Dr. Anuj Mundra is not here. We will send the certificate to him. Dr. Aryan Roy Best Paper Award for 2020, that is Dr. Olivia Mary Jacob, and second author was Dr. Shashikant. So I request Dr. Shashikant to receive the award. Oh, sorry. It is just charged. So we will send you the certificate and the award. So this name will come to the journal also. We'll send email and certificate to the LEMs. Yeah. So should I say quiz prelim, the finalist team 1 FMC and team 14, 4 teams have been are in final. So team 1 is FMC, second is JIPMAR, and third is Purnul Medical College, and 4th is IPGMER SSKM Hospital, West Bengal. So on 26, the final round will be there, and will announce the name, winner and runners up. And winner and runners up, there is winner trophy, rolling trophy, that was with Bhubaneswar AIMS last year, and they have sent back to headquarters. Whoever will be the winner will send the trophy to that Institute. And last time, Iphacon 20 was very generous, and they have given the prize money of 25,000. President sir, how much? You give 20,000. So
last time it was 21.
20 and 10 last time, and 20 and 10. So okay. So you announce the thing on the whatever.
So we consider that.
You will consider, and you give it on the valedictory session. Okay. Okay. Thank you.
Just to inform that there are 505 people who have logged into this mail all for this GVB.
Oh, that's very good. That's very good. We're so happy. Coming to the agenda number 11, it is already confirmed. Confirmation of appointment of auditors. It is confirmed by ACC. Is it adopted by AGB? Okay, thank you. Thank you. Agenda number 12, proposal for date, venue, and theme of the next annual conference. I know Dr. Ashok Bharadwaj online, and he has sent already a mail to us from Himachal Pradesh to the Secretary General IPHA Kolkata, West Bengal. Subject is organizing 66th Iphacon in Himachal Pradesh. Madam, as per the discussion with you in March and also in August 21, we hereby offer our platform to organize 66th Annual National Conference of IPHA in Himachal Pradesh in 2022. We will organize this conference in physical mode if the situation is amenable. The venue will be Manali, District Kulu, Himachal Pradesh. There are many tourist spots in and around Manali, and the main attraction is Atal Tunnel. You are requested to please consider our claim in AGPM. Thanks in anticipation. With regards, Dr. Ashok Bharadwaj, President, Himachal Chapter of Indian Parliament. So Himachal State Branch, they are on the process of making. We will send their recognition, and I think all the members are very happy to learn that it will be in Manali. So we can send this acceptance to Dr. Bharadwaj. We'll just ask him about the time, date, and time.
He's already there.
Okay. So can he? He can speak. Okay. Dr. Bharadwaj.
Can I speak, madam?
If you want to say something.
Yeah. So am I audible? Am I audible?
Please the pin. And voice. Yes.
Please go ahead, sir.
Yes. Am I audible? Am I audible?
Yes, sir. Yes, sir. You're audible.
I lost you.
I think there is problem with the internet. Here or Himachal? So we can accept this. We can accept this, and जो भी whatever to be done, I'll do. No problem. So agenda number 12. Okay. Agenda 13, amendments of rules and regulations. Already Dr. Deepika Shur has told SCC that whatever the next SCC meeting, she will present whatever the consideration of the rules and regulations. Agenda number 14, any other matter with the, okay.
We didn't get the date from him for the next.
No, we didn't get the date from him. We didn't get the institute. So we can suggest from the conference, na, you can suggest, you can send it to the IPH headquarters. We'll talk to Dr. Marutaj. If it is
come from them, because they would know best.
Everything can be considered. This COVID pandemic situation, everything can be accepted.
Yes, that's for sure.
Because it is it should not be virtual, but
We need to block this.
okay, we'll do it within next few weeks.
And next year, 2022. So they will get almost 7 months time also for the preparation.
Okay, any other matter with permission of the chairman? I think no matter.
Any other matter?
No matter. Okay, so we are in hurry also for the inauguration. Ki baki ache? Okay. It's my fault. I forgot that last conference was beautifully organized and it was very successful. Iphacon 2020, and we must record our appreciation and a small memento from IPH headquarters for Iphacon 2020 organizer, from the organizing secretary president Dr. Sanjay Rai to Dr. Shashikant. Please, sir, please come. फोटो में तो वही होता है ना.
सारी फोटो ऐसी होती है.
So from my side, thank you very much. Thank you all members who have traveled to Pondicherry and spent hours with us, and those who are online could not come here and attend this conference physically, and those who are online, our other members, those we cannot allow them to come. So thank you very much for being with us. Please support us and make IPH stronger. Long live IPH. Jai Hind. I'm handing over the mic to our president.
Yes, ma'am.
I'd like to place on record that we are extremely happy to have a Secretary General like Amit, who has given all her time to make this. I mean, all the progress that has been made in IPH has been totally her achievement. So I think she deserves a big clap. President is there.
No.
He's always there.
Thank you very much. So thank you all the CC member, all the general body members of this 65th annual general body meeting. And with this, we conclude this meeting, 65th annual general body meeting. And now we'll proceed for the inaugural function. Thank you. Thank you very much.
Very good evening. A very good evening to everyone present here today. I take this opportunity to invite you to the inaugural ceremony of the Iphacon 2021, the 65th Annual National Conference of the Indian Public Health Association, being organized by the Department of Preventive and Social Medicine, JIPMA, the JIPMA International School of Public Health, in association with the Pondicherry State Branch of IPHA. So to begin with, I request you all to stand for the Dhanvantari invocation.
धन्वन्तरी स भगवानमृतत्वदाता यो वैद्यकस्य गुरुरादिरनादिकालात् यो हार्तदेगमन आत्मसुखावहस्य नैरोग्यतस्य निदरां च नृणां हितस्य तस्यारणास्पदमहर्षिवरस्य शिष्य ये त्रेवयं प्रमुदिताननुभाग्यवन्तः देन प्रतीबितचरं सुचिरात् शुभायुः वेदस्य दीपामिह तत्पुरदोतरामः येन प्रभां वयमिहस्य विदध्य दिक्षु ज्योत्स्नां रुजातिशमनी प्रभवेम दातुम् व्यादिव्यकात हृदयाय इमानवाय देयं द्वितं भुवि कलापि च न किलैषः देयं द्वितं भुवि कलापि च न किलैषः देयं द्वितं भुवि कलापि च न किलैषः.
Everyone, please take your seats. I would now like to invite Dr. Gautam Roy, the organizing chairperson of Iphacon 2021, to welcome the gathering.
Thank you, Dr. Good evening, ladies and gentlemen. On behalf of the Pondicherry State Branch of the IPHA, the Department of PSM, JIPMA, and other departments of community medicine in the various colleges in Pondicherry, the JIPMA International School of Public Health, and also personally, I welcome you to Iphacon 2021, the 65th Annual National Conference of the Indian Public Health Association. Of course, specifically, I would like to invite Dr. Soumya Swaminathan, and all of you know who I'm talking about. She could not be here because she is abroad and being a busy person, but she has sent a recorded message, which we shall see subsequently. I would also like to invite personally Dr. Sanjay Rai, our President, our Secretary General, Dr. Shangamita Ghosh, all the esteemed members of this association who are here in person or who have logged on. And of course, since I belong to the Department of PSM, I would, without being told, they are also welcome here. I'm not sure whether this forum is an appropriate one to do so, but I place my gratitude and heartfelt thanks for all the hard work they have done, all the faculty, all the residents, and of course, Dr. Sitanshu. I won't mention the other names because they are very humble. If you look at it, this pandemic has not taught us anything new. If at all it has done is, it has reiterated and strengthened
our notions of common sense health practices, like cover your mouth, don't go too close to another person, wash your hands, because 60 to 80% of all infectious disease are spread by fingers. That is all it has done. And that is why we felt this theme, public health more than ever now, becomes very important. Be that as it may, it does not mean that we cannot learn something new, so that we are prepared for what is to come. And that is why we have done, and you can see what the result of the hard work put in by our people in this conference. With that, I welcome all of you once again. Thank you so much.
Thank you so much, sir. With this, we move on to the lighting of the ceremonial lamp. Thank you, everyone. I now invite Dr. Sangamitra Ghosh, the Secretary General of IPHA, to say a few words on this occasion.
Dear members of Indian Public Health Association, all the dignitaries on the dais and on the floor, warm greetings from Indian Public Health Association and JIPMER 23. It's a privilege to have all of you with us on the inauguration session of Iphacon 65th Iphacon, and I convey my earnest thanks to the organizers of this conference. You have really done a commendable job in these hard times. Thinking of hard times, I cannot but recall the last 1.5 years that has been a challenge to the world, and more so to our discipline of public health. We cannot forget our fellow martyrs who have lost their lives in the battle throughout the world, fighting for a cause and not surrendering their battles to the threat of COVID-19. They have held their heads high, and it is them and all our members who have worked in various capacities to mitigate this disaster. We are winning. Yes, we are winning the war. It's a matter of time before it becomes official. And we are happy to say that IPHA has played a pivotal role in this work. It was a clarion call for us, and we rose to the occasion with all our armory. Our members have supported the COVID control in many ways, consulting the states, working in the field, helping in vaccination drives, treating patients, and we published joint position statements at regular intervals to help the governments take evidence-based decisions. We sincerely thank all our stakeholders for contributing to those statements and also bringing out a special issue on COVID-19 by our which is our phase, the Indian Journal of Public Health. Yes, there have been hurdles, both internal and external, but like a mature organization, we were able to tackle this. And here we are, with all of you enjoying 65th Iphacon on the eve of the foundation day of this association. With great power comes great responsibilities, and we have tried to live up to them. We found opportunities in the pandemic via the ever-increasing online modes of communications. We are quick to jump and grab the opportunities. Even in the face of adversities, we have regularly organized capacity-building activities like psychometrics in public health, reference management softwares, quality assurance public health for our members at very nominal price. Indian Academy of Public Health also organized and operate the various public health events like World Population Day, World Health Day, and organize symposiums at regular intervals. We have brought radical changes in our governance, like registrations, fund transfer, and we proudly announce that another 1,800 esteemed members have been added to our ever-growing family. Now, most of the jobs can be done by a single click from our website. So do continue supporting us, do continue contributing and help us grow with you. We will continue our journey to become a bouquet of public health specialists in India and abroad. Once again, thank you for joining us in this program. Be safe, be productive. Jai Hind.
Thank you so much for those inspiring words, ma'am. So now we have Dr. Sanjay K. Rai, the president of IPHA, to share his thoughts with us.
Thank you. Very good evening, dignitaries on the dais. Dr. Soumya Swaminathan, Chief Scientist, World Health Organization, Geneva. Dr. Rakesh Agrawal, Director, JIPMER. My colleagues and Secretary General of Indian Public Health Association, Dr. Sanmitra Ghosh, Chairperson of this 65th Annual National Conference of IPHA, Dr. Gautam Rai, Organizing Secretary, Dr. Tansukar, other dignitaries and his entire team, other dignitaries, my Central Council members, my most valued member of Indian Public Health Association, all the delegates attending this 65th Annual National Conference, members from our partner agencies who are supporting this conference, all the speakers, ladies and gentlemen. Really, it's an honor for me to share this special occasion with all of you. On behalf of Indian Public Health Association, I once again welcome you on this 65th Annual National Conference. Dr. Gautam Rai and Dr. Sitanshu and his entire team deserve really a big congratulations for organizing this conference in a very difficult time. And they deserve a big applause. Friends, as you know, the Indian Public Health Association is one of the oldest professional organizations of this country. We are working for the public health since 1956. The beauty of this association, the strength of this association is a diverse membership profile. More than 10,000 members we have. So it's just like a multidisciplinary team. And that's why during COVID time, we all played a very important role in this COVID-19 situation. The COVID pandemic has been a difficult time for us, but it has also shown us the unprecedented velocity at which research and its implementation can move if one really wills it. Many of our members in Indian Public Health Association have contributed to this vast purpose of research. We participated in various research like vaccine effectiveness trial, vaccine safety trial. Our members participated. Then safety clinical trials, not only clinical trials, even after vaccination, effectiveness study also. So many members participated. So we generated a lot of evidences for our country, for our community. But during this time, really, we have also come face to face with our limitations. The need of public health leadership in India has never been felt more acutely than it has been felt now. A strong public health leadership is really truly the need of the hour. In today's day and age, every individual has an opinion and every individual has the platform to voice that opinion, either it's wrong or right. We're using various media, either social media, print media, electronic media, so they are there. However, that opinion is not always based in evidence and not always voiced in good faith. So it becomes our responsibility to ensure that we develop ourselves to be well-informed, rational public health professionals. Each young professional here should be confident to voice their opinion, with the caveat that it is based on evidences. we must ensure that there is no vacuum which can be filled by misinformed and ill-intentional voices. Many times, even it's a not they are not calling for say misinformation. This is the only way to ensure that the science wins above all else. The theme of this conference, public health more than ever now, is very relevant in current scenario. Really, the importance of public health was never felt like the current time. The IPHA took the responsibility, as mentioned in my secretary, and also mentioned that since the beginning of this epidemic, we issued the first advisory on COVID-19. It's still relevant. And you go to and during March 16, if I recall correctly, 16th of March 2020, before this lockdown. So it's already there. Then our consensus statement with the various other associations, public associations. So since beginning, we are involved in this. We also supported government during this time. Various some member participated as a central team member. Many states supported many state government for the containment measures. Our members participated very well. I have already said. We are proud of that. We have been able to achieve in this time and the credibility of IPHA bill. We approach research as a public good and are guided by our mottos of independence. This is the really important independence. So without any fear, honesty, and with a lot of impact. Majority of media, not only Indian media, even in New York Times covered our statement, the Gulf News, they also covered our joint statements. The past year gave us due notice that the world needs to reimagine and realign its policy priority. To this end, IPHA and other policy think tanks can essay an important role by bringing informed, non-partisan analysis to policymakers. At our most ambitious, this is what we aim to do: identify the key challenges that face India and the world and offer new actionable solutions for progress. This conference is also covering a lot of issues related to public health, current public health challenges, including COVID-19. We have sessions on vaccination, then there is issues related to COVID-19 also. The deliberation and recommendation arising out of this conference will be keenly observed, and I have no doubt that they will be an important input in future policy making. I wish this conference a great success. Thank you and Jai Hind.
Thank you so much, sir, for your words of appreciation. Now we have a few words by Dr. Rakesh Agarwal, the director of JIPMER, in the form of this message.
Good afternoon. Dr. Soumya Swaminathan, Chief Scientist, World Health Organization, Geneva. Dr. Sanjay Rai, President of the Indian Public Health Association. Dr. Sanghmitra Ghosh, Secretary General of the Indian Public Health Association. Professor Gautam Roy, Chairperson of the Organizing Committee of the current IPHA Annual Conference. Dr. Sitanshu Kar, the Organizing Secretary. Faculty and delegates for the 2021 IPHA Annual Conference. Friends, ladies and gentlemen, I am extremely happy to welcome you to the conference of IPHA that the Department of PSM at JIPMER and the Pondicherry State Chapter of IPHA are organizing. Public health is the field of medical science that's possibly the most important. As is said, reducing the blood pressure by 1 millimeter of a population saves many more lives than reducing the blood pressure of 10 to 20 millimeter for all the persons that a physician would come in contact with over a lifetime. In that sense, public health makes the biggest impact on the lives of people and their health. The last 2 years, the years of the COVID-19 pandemic, have made us acutely aware of this important facet of public health, and that is on which the current conference's message is focused, and it is public health more than ever now. In the last 2 years, public health experts have played a major role in our dealing with the COVID-19 pandemic, in testing, in screening, in prevention using non-pharmacological measures, and now prevention using vaccination. They have also helped us better understand the non-medical consequences of the pandemic, the economic effects, the migration, the increase in non-communicable diseases, and problems arising because of inability to care for diseases other than COVID. I can tell you that the organizers of the current workshop have worked very hard. They have drawn up a very interesting multidisciplinary program, and they have got for you the best speakers from around the world. And therefore, I can say with confidence that this particular conference will be remembered for years, not just because it happened during COVID, but also because of its content and the academic feast that it will provide. Surely, we are somewhat sad. We would have liked you to be here with us in Pondicherry and partake of the a lot of things that this city has to offer to people. We have a beautiful architecture, we have very different cuisines, but unfortunately that was not to be. However, on behalf of the organizers, I can promise you that we at JIPMER will surely in the next few years organize another conference when the effect of pandemic is gone, so that we can make up for this deficiency. With this, let me end here. In the end, I once again welcome all of you and hope that the conference would be a success and that each of you would have gained a lot by the end of this conference. Thank you.
Thank you so much, sir. We now move on to the release of the Iphacon 2021 souvenir. I request Dr. Sanjay K. Rai, Dr. Sangamitra Ghosh, Dr. Gautam Roy, and Dr. Sutanshu Sekharkar to please do the honors.
स्लाइड में भाड़ा ज्यादा हो जाएगा,
इसलिए आपको नहीं दे रहे। और
अच्छा आपने ज्यादा बताया
One student, she is actually telling all this that I was coming from there. I think we will having some medical textbook. Virtual में किया ना फिजिकल वाले को दो इशू
वर्चुअल में ज्यादा होता है, फिजिकल में
कम। Very good, good to get out. And besides that, that is also very nice.
Thank you so much, sir and ma'am. Now I take great pleasure in bringing to you the address from our chief guest for the day, Dr. Soumya Swaminathan, Chief Scientist, WHO Geneva.
Hello and greetings from the World Health Organization. It's indeed a great pleasure and an honor to be speaking to you all today, the Indian Public Health Association. And it's a very important moment to have this conference and to really think about the future of public health in India, but also around the world. It's clear that we all live in an interconnected world. I think the pandemic has made it very, very clear, even if we had not recognized it earlier. We recognize it today with still the latest data for this week is telling us that there are about 3 million new infections happening every week around the world and still about 60,000 deaths. This has come down over the last 3 weeks. We've seen consistent declines in cases and deaths around the world. But these global figures, they really hide the data which is at national level, the sub-national level, the district level, and below. So big picture data really hides what's happening at the local level. In India, clearly there was a huge second wave, a surge of the Delta variant that is estimated to have infected over 60% of the population if we go by ICMR's National Severe Survey, it includes children as well. And with the vaccination coverage picking up to for at least 60% of the population to have had one dose so far, the level of immunity in the population is definitely increasing. However, we know by looking at other countries that vaccination alone, or what we consider as population immunity, is not enough to stop the virus, particularly highly infectious, highly transmissible variants like Delta. So you need the other public health measures that all of you know so well that have been shown to be effective, like mask wearing, the maintaining of distance, the importance of good ventilation and hand hygiene, etc. But these are very difficult. In addition to that, of course, we need still the testing, the surveillance, the detection of cases, the tracking of the contacts, quarantining, the prevention of clusters, the prevention of super spreader events, avoiding of mass gatherings. It's a lot to ask of people, and this is why people have been getting into what is sometimes referred to as pandemic fatigue. People want to get back to normal. And of course, there are economic imperatives. One cannot tell people to stay at home, and a lot of people need to go back to their livelihoods, need to go back to work in order to earn and feed their family, particularly in countries like India, where we have a large number of people who are socioeconomically very vulnerable. I would like to share a few lessons from the pandemic, particularly as they apply to public health. I think the number one lesson is that all health systems were severely tested by the pandemic. They were put under strain, and I don't think there are any health systems in the world that did not at some point or the other over the last 20 months really reach almost breaking point. In terms of even the very high-income countries which have good facilities for care, for tertiary care and treatment of severely ill people, even in those countries, it was the public health system that was under strain because of the lack of investment in those systems. And so it was the community level engagement, the surveillance, the tracking of people who were in contact and the follow-up, and also the community engagement where people public health authorities could earn the trust and communicate with people. These elements were put under strain. So lesson number one is that every country in the world needs to invest in its health system, particularly focusing on public health and on primary health care. Because without the primary health care being strong, having the tertiary health care alone is not going to be enough. Second is that we need to invest really in prevention and promotion of health. So we have to look more upstream at the risk factors and determinants. And while we know that zoonotic infections can arise and will arise in the future because of the nature of globalization, urbanization, the loss of the biodiversity, the coming together of people and animals, both wild and domestic animals, and mixing, as well as illegal trade in wildlife. Many of these factors are going to make sure that these events occur more and more frequently in the future. So we need to study and understand the origin of this pandemic, how the SARS-CoV-2 came about. But we do know the factors which enable these zoonotic infections to happen. And therefore, we need to understand much better in the context of what is known as One Health, which is environment, animal health, and human health being interlinked. Damage to one or disruptions in one system are going to have impacts on the others. This is also true for things like antimicrobial resistance. The use of antibiotics in the animal sector, veterinary sector, and agriculture sector is going to have an impact on antimicrobial resistance in humans. So we need to think really in a systems way about how these three systems are interlinked and how actions in one can impact action or cause a reaction in the other. And we need to address the root causes again, which is complex, but it needs to be done, and we need to involve, therefore, not just epidemiologists and medical doctors, but veterinarians, environmental experts, experts on animal migration, virologists who study both animal and human viruses, anthropologists, social scientists. So public health as a field is multidisciplinary, and I think we need to strengthen those parts of the system which currently are not very strong. And it would be great to see public health departments in medical schools become multidisciplinary by recruiting staff that have all of these different expertise and then can work together to understand. Because, you know, all of this is also linked to behavior, animal behavior, human behavior. And unless we understand the fundamentals of how to bring about behavior change, it's very difficult to have lasting change on the ground. And I say this not just for with respect to emerging infections, but also with respect to non-communicable diseases, which of course we know cause a major burden of disease in India and in many low and middle income countries today. The leading causes of death are not infectious diseases, but non-communicable diseases, for which we know that many of the risk factors involve behavior change. They do also involve policy change. Health systems, did overcome many of the challenges by putting in place measures, by diverting workforce as well as resources, diagnostic capacity, labs, everything was diverted to COVID. And as a result, we will see, and we have already seen, the impact on other diseases like tuberculosis, like HIV, where it's estimated that far fewer people, 20% less detection of TB in 2020, less detection of HIV, less of preventive services outreach was happening for HIV, and in some countries there were also disruptions in drug supplies. And therefore, many people may have missed their treatment, more people may have died. We still don't know the data. But what we do know is that many other diseases were impacted. In fact, the WHO did 2 pulse surveys. The last one was done in January of 2021. 136 countries participated. 96% of countries reported interruptions in at least one essential health service of the list of essential health services that were looked at. And over half of the countries had disruptions in many of the essential health services, including maternal and child health, immunization, NCD care, cancer treatment, like diabetes and hypertension treatments, TB, malaria, and as well as essential surgeries. And of course, rehabilitation, palliation, mental health services. All of these were impacted in many of the countries. So looking, again, to fix this, we need to have a resilient health system. That means we need more of staff. We saw how the system was stretched. So workforce is important, investment in primary healthcare, investment in logistics, in drug supply networks, investment in diagnostics. We see how important diagnostics is. It's been neglected. So every primary healthcare center must have access to essential diagnostics. The WHO has an essential diagnostics list. The ICMR and the Indian government, when I was in the ICMR, we had started working on the essential diagnostic list for India, just like the essentials medicines list. So it's critical to pay attention to that. So early detection, you need diagnostics. We now see the importance of genomic surveillance. That's being strengthened in the country. We have a consortium of labs today. Again, they should go beyond COVID. Genetic sequencing is very important to understand other diseases as well, the spread of diseases like dengue, like chikungunya, like tuberculosis. All of these will benefit. So genetic epidemiology is also a field that has to work hand in hand with classical epidemiology. Financing, of course, we need to invest more in health as a whole, both in healthcare delivery, but also in addressing the upstream determinants and risk factors of health, which are mainly around nutrition, improving dietary diversity, alcohol and tobacco control. Road safety is extremely important. Of course, safe drinking water, sanitation, and the living environment. These are the factors that impact on one's health, and again, more of an impact on non-communicable diseases. Air pollution. I forgot to mention that air pollution is one of the most important risk factors for health. As you know, WHO just released the new guidelines on air quality, where we have actually lowered the limits of PM2.5 and PM10. And so every country will have to look at their own standards. And we have to still a big challenge ahead of us, both in terms of indoor and outdoor air pollution. If you travel in rural areas and tribal areas, you still see quite a significant proportion of people, though it has come down because of the big push for the use of LPG, but you still see rural women cooking on wood fires and being exposed to a lot of indoor air pollution. So I want to say a few words about data. Of course, I already mentioned the workforce. The workforce, again, we need to think about what cadres of workers do we need in order to have a good primary healthcare system. Of course, you need doctors and you need nurses, and you can have nurses that are looking at antenatal, at NCD, at infectious diseases, and so on. But you also need the other disciplines to provide a comprehensive primary healthcare. So you need a physiotherapist, you need rehabilitation experts, you need somebody who understands nutrition and can do some counseling. You need somebody who can screen for mental health problems. And then, of course, you need the specialists with whom one can have a system of referral nowadays, even digitally, using the eSanjeevani platform that the government of India has established, as well as other platforms. So digital tools and technologies can play a very important role, both in the diagnosis of diseases by using artificial intelligence. It's been shown now that you can use algorithms to read chest x-rays, for example, for screening for TB. Algorithms are being developed to screen pathology slides, and algorithms also to make diagnostic decisions. All of these need validation, need research. So again, I would like to emphasize that I hope that this association and that all of the medical school departments of community and public health will invest in research, because the need of the hour today is local data. Good decision making can only be done when there is good data to base those decisions on. And good data has to come from trained people like you, working on the ground, who are collecting the information and putting it together in a systematic way, analyzing it, and then presenting it to the program officials as well as the policymakers. And it makes such a big difference. You know, epidemiology without data is just a myth, it's just a story, whereas data also needs to become a story in order to be used well. So when you start looking at data and start telling a story, this is what can actually change and move the needle on many of the policies. Because very often, if you are in a data-free zone, there is no way in which you can draw attention to the problem. So another way of describing the importance of data is that you shine a light, you bring a light into a dark corner. these surveys that are done, which tell you the proportion of people suffering from mental health illness. It may shock you, may wake you up, but then it forces you also to act. Similarly, the National Prevalence Survey for TB, which is presently being completed, will tell us where we are today with the TB epidemiology situation in the country, and will help us to make changes in the RNTCP. So I cannot overemphasize the importance of having data, and for data is at different levels. You need data collection on the ground. You need people who are trained to do that. The data has to be reliable and credible, which means that needs to be checked. A lot of data today is unusable because it's just not of high enough quality. Then you need the statisticians, you need biostatisticians who can understand when they're analyzing the data. Then you need, of course, critical thinking to look at the data and say, what is it telling us, and compared to before, or what is it informing us? And then you need public health specialists and clinical specialists and doctors and researchers who have the communication skills to be able to communicate this both to the public and to the policymakers. I do want to emphasize also on the communication, because that's become again so important during the pandemic. We see the amount of misinformation out there has to be countered by credible, transparent, easy to understand information where people like us are updating the public in a simple, easy to understand way, but also explaining how science works and how science is not static. We've seen through the pandemic the amazing contributions of science, of R&D in producing diagnostics, producing vaccines in record time. So technology and science is delivered for us. We then need to use those tools wisely with humility and with compassion, as well as with equity in mind. And equity is not just a factor that needs to be considered globally between countries. It's very important, but also within countries, within communities. We know that there are inequities that exist, and therefore, whenever we're rolling out a public health program, we need to keep those in mind and see how are we going to reach those people who otherwise are always at the back of the queue. Recently, I traveled to a few tribal areas in Tamil Nadu, and I could see that these people have been cut off because of lack of digital connectivity. The rest of us take it for granted. But for them, whether it's health, whether it's education, or whether it's livelihoods, they have no digital connectivity, and therefore they're at a huge disadvantage. So even if you roll out telehealth and telemedicine, these people cannot make use of it. They have to travel 15 kilometers, either by walk or by a bus, in order to get to a point where there is some network connectivity. So this puts people at a huge disadvantage, and so it's important for us as leaders in the public health space to constantly be looking at that equity angle, at the gender angle, in order to ensure that we do not disadvantage people who are already disadvantaged. And finally, I think leadership shown by countries have determined whether they did well or not. It needed an all-of-government approach. It needed a multi-sectoral coordination. On the one hand, you had the public health imperatives. On the other hand, you had the economic considerations, and both had to come together. And the social support systems were very, very important during the time of the pandemic. And therefore, it shows to us that you cannot work in a siloed way when it comes to this type of an emergency. Every sector has to come together and contribute. And of course, we've seen a very good collaboration between the private and the public sector also happening at this time. And finally, I think community engagement is maybe the most important and critical. So certainly not the last thing that one should think of. It should be the first when one is faced with a public health crisis and an emergency. Again, when we think of public health, we should think broadly beyond infectious diseases. So I always think of hypertension as being one of our biggest public health crises today, probably leading to many more deaths than any other condition. If you look at the sheer numbers, 1 in 4, 1 in 5 adults today having hypertension, which is not under control. And globally, I think the numbers are staggering. It's something like 1.2 billion people who have hypertension. which majority of them are not under control. These are the people who go on obviously to develop strokes and cardiovascular disease and kidney disease, for which we will then have to establish more and more centers. For dialysis, more and more centers. For cardiac surgery. So rather than that, we need to address the diagnosis and treatment of people with hypertension and also prevention wherever possible. Again, coming back to the fact that you need individuals, families, and communities to get engaged, to be aware of their health. And now I think it's happened. People are aware of health issues. People have started talking about it. But health literacy and scientific literacy is something that one has to work on systematically and consistently in order to get to a point where you have a population that believes in its public health experts and understands when certain messages are given to them and then takes the appropriate action. So with that, I would like to thank you for giving me this opportunity to share my thoughts. Wish you all a very good conference indeed, and look forward to meeting many of you in person very soon. Thank you very much. Namaste.
Thank you so much, ma'am, for that informative message and your best wishes. Now I call upon Dr. Gautam Roy to felicitate Dr. Sanjay K. Rai, President IPHA. May I also request Dr. Sitanshu to felicitate Dr. Sanghamitra Ghosh. Thank you, sir and ma'am. So before we conclude the ceremony, I request Dr. Sitanshu Shekharkar, Professor and Head Department of Preventive and Social Medicine, JIPMA, and Organizing Secretary, Iphacon 2021, to say a few words. Over to you, sir.
Good evening, everyone. Can you hear me? Yes. So it's my privilege to propose the vote of thanks, or nowadays we use the term called words of thanks for this 65th IPHA Con, or 65th Annual National Conference of Indian Public Health Association, that is being conducted by the IPHA Pondicherry State Branch in collaboration with the Department of Preventive and Social Medicine, JIPMER International School of Public Health, and all other medical colleges which are present in a part of the IPHA Pondicherry State Branch in Pondicherry. So at the outset, I would like to express my profound gratitude to our chief guest, Dr. Soumya Swaminathan, for her valuable time and her message about the cause of public health and how we should work together, and how the importance of data and epidemiology should go together hand in hand for informed decision making. So thank you so much, ma'am. And in your words of wisdom always will inspire us to do take public health to a higher cause. We are very grateful to our beloved director, Dr. Rakesh Agarwal, who has been always a source of guidance, and he tries to push us to explore new boundaries and try to do quality job all the time. So he's not here, but he has extended his best wishes and regards to all the members present over here. Thank you, sir. We are very grateful to our president of our branch, president of IPHA, Dr. Sanjay Rai. I'll tell you one thing, evening 8 o'clock or night 11:30, whenever you call, he will answer your call. So it's indeed a pleasure to interact with you, sir. Earlier we used to interact a little bit, but during the conference as as organizing secretary, you'll realize that there are so many things to clarify, so many things to understand, and so many things to learn. Thank you so much, sir, for your time all the time, and with a smiling face. Never ever approach them, what are the issues that we should discuss, all these things he guided with a very cool head and appropriately. Thank you so much, sir, for all your guidance. The second important person in this whole scheme of things is Dr. Sanghamitra Ghosh, a general secretary, if you can say. An ordinary member or a branch member or secretary can always approach her, can get her guidance. She has been not after my life, after our life for last 5 years to conduct an organizer or to organize the function over here. So we started with 60th round when Pradeep called me once and told, आपको करना है तो कर लो, नहीं तो मैं कर रहा हूँ. That's how the journey started, and finally we never knew that we are going to have this conference online. We always desired to have it offline. So with the such infrastructure we have now, we wanted to showcase the strength of the department to the whole country at least, and maybe we'll see some other time we can meet. So thank you so much, ma'am, for your constant encouragement. And always she works very closely with young people and try to promote them and give them the due recognition that is there, which is a great thing. So thank you for doing that always. So after that, I'll come to Dr. Gautam later on, because sir, okay, I'll come later on for that. So let me tell about the conference little bit. So as we all know, the theme of the conference is public health more than ever now. Very apt considering the time that we are going through. It has got 3 sub-themes. The overall theme was that the 3 sub-themes were, the first one was to talk about the effect of COVID-19 on our health system. So today we had 4 excellent plenary sessions on that, the effect of COVID-19. The next 2 days, we are going to have discussion on public health action and capacity building, how to deal with such situation in the future. So this program was very carefully crafted and designed to address the issues of public health in recent times, and also try to give an opportunity for all the postgraduate, MPH and PhD candidates who are participating in this conference to learn something new, to learn and try to get something new from this conference. That was our endeavor. A lot of discussion went into this theme and sub-theme discussion. How do we, what plenaries we should include, what we should not, all those things. A lot of discussion happened in the department. I'm very grateful to the department faculty members who have contributed in each and every step for this and for the discussion and finalization of theme. There are certain new things that we tried in this conference. First, we shifted all the presentation, poster and oral, to one day, because our experience with conferences is what happens is when you have an oral presentation or a poster presentation to do, you don't pay attention to the plenaries. A lot of effort goes in arranging for those plenaries. So what we thought as a group is, let's do the poster and oral presentation one day ahead, because it's a virtual conference. So the pre-conference, what was announced in 2020 in AIMS Delhi was 23rd to 26th, where 23rd was supposed to be the pre-conference workshop. We took that advantage of that, converting that pre-conference workshop into paper presentation and research discussion. So when we started with that, we received an unprecedented 850 abstracts. We never thought that. So the scientific committee had a very tough time. The scientific committee was led by Dr. Premarajan, Dr. Mahalakshmi, Dr. Sonali, and Dr. Venkatachalam. They did a lot of good work with all the support from our residents and MPH trainees and PhD trainees as well. So after having done that, so that's the first innovation that we tried. The second innovation what we tried is to look at how can we encourage engagement during the plenary session. So we have announced prizes for them. The people who or the students who are going to ask questions will be identified, and they will be sent books. So if there is something that is left out of this conference, at least they will take that book with them and try to remember that in 65th Iphacon, a book was given to them. It will be delivered to them through either by post, if you see if the cost permits that, or it can be done through an Amazon book delivery system. So something of that sort we are planning to do. The other innovation that we also tried is to have 11 pre-conference workshops. It started from 3rd of September and ended on 19th of September with Dr. Kavita, the professor and head of IGMC, and Dr. Palnivel led that effort. And Dr. Kavita, can please let's clap for her. So all those hard work and almost 11 pre-conference workshops involving 50 to 60 external faculty members, 800 delegates attended. The number of people who presented their posters or abstracts, the same number of group were there. So it was wonderful. We had the involvement of a lot of pre-conference workshops of public health importance, starting from leadership with data analysis, diagnostic test evaluation, then quasi-experimental design. So many things we did, and it was the feedback was very encouraging. We are very happy to get that feedback. For a teacher, the feedback from students actually gives you that motivation to go for the last mile. So that's how we did it, and that's another innovation. Probably in the history of IPHA, in a single day, 800 abstracts presentation is a record to my mind, to my knowledge. So in a single day, 10 sessions, 30 parallel sessions, and 450 abstracts, commendable job. I never thought that we could do it, but it was done so smoothly. And when the Central Council members came here and did and told, it went on very smoothly. It was such a satisfying note yesterday. So thank you so much for all those hard work, department. There are so many things to be told, but the time is there. I don't want to stand between you and the dinner. So that's another thing that we should remember. But there are certain people, some names that I should must take. Without that, this words of thanks will not be complete. The first thing, as I told, I'll come back to Dr. Gautam Roy, and we come back to Dr. Gautam Roy all the time at the last moment. Sir's presence, is Sir will. It's actually, I have no words to express that. So Sir will be there. He will not be there. But whenever there is a problem, Sir will be always there behind you. That's the leadership quality he has taught us, and try to give that freedom to do whatever you want to do. He's the organizing chairperson, but he will come and ask you, are you facing any problem? Any issues, please come to me. We'll discuss and sort it out. Thank you so much, sir. And the whole department looks for guidance from you. We have Dr. Premarajan over here, who is the chair of the scientific committee. Sir, please. The other faculty members are not here, but as I told you, the names are Dr. Sonali, Dr. Mahalakshmi, Dr. It may be a little long, please bear with me, because I have to do this, otherwise it will not be complete. So the team worked, and the residents, I'll come back to them at the end. So that's how the team is. We are a very cohesive team, and we take pride in that. Then after this, the pre-conference work, the scientific committee pre-conference workshop, Dr. Palni is not here. Dr. Kavita and Dr. Palni, they worked very hard for doing that 11 pre-conference workshop. The other important, in this whole cog of the wheel is there is a person called Dr. Suvita. So why don't you stand, Dr. Suvita? the chair of WebM Tech Committee. She'll never be seen, that the remarkable qualities she has. But she will not allow to have a single mistake in the whole process. So the organizational goal, how to keep the organizational goal in front of the personal goal, we must learn from Dr. Suvita. So thank you, Dr. Suvita. She was the joint secretary and also took so many other responsibility for that. Dr. Jaya for registration, all the issues related to registration, all the issues related to online problems and other things were sorted out by the team from registration. Dr. Swarup for the souvenir committee, the book that you see in front of you is all the hard work by the souvenir committee. Dr. Junata for refreshment, Dr. Ganesh for financing, and Dr. Venkat for all the travel and refreshment related issues. So the department is a wonderful place to work in, and so fortunate to be in this department. Finally, coming back to the residents, without that, no work can be done, no work is possible. We get energy from our residents. So those who are present here, please stand up. The residents, those who are here, please. Residents, MPS students, PhDs, please stand up, those who are here. And those who are who have joined us online, big round of applause for them. All the recordings, Stuti, Anurag in the plenary session, wonderful job. So many people have contributed, so many man hours are there. It appears very easy when you see that these things are done. But there is a lot of planning, there is a lot of hard work, a lot of midnight oil that we burn to make this seeming. Thank you so much. And please sit down, please sit down. So I think all my check boxes are ticked now. So lastly, I thank all the members of organizing committee from other departments, other medical colleges who have contributed. We had a lot of, probably this is the workshop, the conference where we have almost 10 online calls with our medical colleges. We involved them in each and every step. And all the team members are here. Dr. Avijit from HOD of Mahatma Gandhi. So Dr. Anil Purti, Dr. Kalai Selvan, all these people who have helped us in conducting this conference. And there are certain central council members also, those who are always there. So can you stand up, Pradeep? So Pradeep, Dr. Maushumi, please, all the central council members who have traveled here. We are very thankful to all of you. And
commitment to IPHN, especially Madam.
Yes.
She was very strict this time on writing emails.
So it was wonderful to have you all here. Thank you so much for visiting us. And there are a lot of work that we wanted to do, showcase our department, showcase the city, so to you the city of Pondicherry. But because of Corona, it has to be COVID. It has to be organized in a more subtle way, so in a more dormant way probably, but not the scientific rigor, and the energy is the same. The same amount of enthusiasm all of us have put in. So thank you so much. With this, I stop here. I'm sorry I have taken your time a little more, but one thing is we would like to have your feedback because we always strive for improvement. Tomorrow should be better than today. That's the motto that we carry forward. So anything that you would like to tell us, please feel free, give your feedback. We'll definitely try to improve. To all the members, all the staff in the department as well, I take this opportunity to thank them. And I stop here. Thank you so much for your presence here. Thank you, sir.
Very well done.
Yes, yes.
Very well
And the virtual Patram VNCs is also a wonderful team that we have got. They were very, very accommodative. Our demands were enormous, but still they were very patient. And thank you so much for doing this. And probably this is not the first time that we are doing it. It will continue. The association will continue. Thank you, Pratik, and thank you, Abhishek. And thank you, Mr. Raja. So there are so many people there. So it was, these are the names that are coming to my mind offhand. So thank you so much. Thank you so much.
Thank you so much, sir, for both those words and your constant guidance. So with this, I request you all to stand for the national anthem.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मागे जय गाथा जन जन मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Thank you, everyone. So this brings us to the end of the inaugural ceremony of the 65th Iphacon. And we hope that you will also join us for the subsequent days of the conference and have a great experience both at Iphacon 2021 and in Pondicherry as well. Thank you.
IPHA Zindabad. IPHA. Thank you.
Hello. 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 Hello.
Hello.